So welcome to the Symposium on Obesity and Kidney Transplantation. My name is Heather Gardner. We are really thrilled to have as many people here in person as we do. And seeing people in 3D is a welcome change after 2 years of being virtual, right? So I just have a few housekeeping items that I wanted to share before we get the event started. And I apparently have not had enough coffee yet. I apologize. There we go. All right. So for those of you joining virtually, you are muted. If you would like to chime in during the Q&A sessions, please feel free. You can unmute yourself, but you can also just use the chat feature, and we have somebody who will be monitoring that throughout the day and help to make sure that your questions are answered. I also wanted to let everybody know that we are recording this today. And this is to be able to provide folks who are not able to join today the opportunity to hear this conversation throughout the day later and to still earn some continuing education credits. The closed captioning should be already enabled for those of you joining virtually. If not, you should have a little button on the bottom of your Zoom that will allow you to enable the captioning. So the interactive chat feature is active, like I just mentioned. Please feel free to use that liberally. I think I just said that the meeting is being recorded. And the recording will be made available through the end of the year, which is when the website actually is paid through. So when the website comes up for renewal and I choose not to renew, that's when the recordings will go. I'm sure everybody is really eager to hear more about the continuing education credits. We were thrilled to be able to provide that to you freely. So in order to earn them, and I believe with social work, you now get 7 CEUs. Then we ask that you do attend the full meeting, participate in the workshop that we have planned for this afternoon, and complete the evaluation. So these credits are coming from the National Kidney Foundation. After the meeting is over, you should get an email from them with a link to an evaluation. And once you complete the evaluation, you'll earn the credits. And if you have any questions about that at any time, please don't hesitate to contact one of us. So I hope that you are aware already, but we have a few goals for the symposium today, and this is a working meeting. We are here to review and discuss current state of knowledge regarding obesity and kidney transplantation. We're also here to hear from patients who are struggling with both obesity and being on the wait list for a kidney transplant. So we're going to hear from them about the challenges that they have had and their successes. And then at the end of the day, the idea is to develop an agenda for future multidisciplinary work on obesity and kidney transplantation, so we can extend this field and make sure that we continue to learn and grow, hopefully from one another. So there are details on the website about how to develop research questions. During the breaks, we'll be prompting you to submit any questions that you have thought of for the keynote in session panel 1, and then for the keynote 2 in session panel 2. But we will help you along the way. And so you can think about questions that were raised by the panelists, the keynote speakers, and other people that you've been just sitting and chatting with, those that you generated yourself in considering some of the content that you've heard, or that you think that the field has not yet addressed. So we're interested in any questions that come to mind, really. And so this afternoon, we'll work collaboratively in the last hour to develop and refine some of the questions that you have submitted throughout the day, after which we'll have a reception. So I hope that you can all join us for the entire day, and the reception is a little boozy one. So those of you virtually, I'm sorry, you're going to miss it. But those who are here in person get to imbibe with us a little bit in this evening. So please stay for the whole session. And these are just instructions for that workshop. And I have not done this alone. I have a large group of people to thank for their contributions over the last 7-8 months. Many of them are around the room, but we had a planning committee that consisted of Dr. Serban Konstantinescu, our patient partner, Matthew Fassbinder, our resident nephrologist, Dr. Avram Gillespie, Karen Greathouse from Michigan, who's our resident dietitian, Rohit Soames, who is not here, I don't believe, but is our bariatric surgeon, Colleen Tewksbury, who is having twins today and is not able to be here, but she is actually at Penn and has contributed quite a lot. She's the program manager over there. Megan Urbanski, who is a postdoc at Emory, and she too is not able to be here in person. And then Marielle Van Thun, who is somewhere here. I can't, there she is. She's behind the this wall. She's from the National Kidney Foundation. And then I had a whole group of people who also were supporting. Rashawn Gass is the program coordinator, who I'm sure you've all been in contact with. Amy Contbear and Kate Gallagher too are from the Office of Community Engaged Research and Practice at Temple's College of Public Health. Rebecca Shaw, Sam Yeoman, our resident IT guy, who I'm sure will come up and help me again, and Laurel Chase. So thanks to the many people who went into making this a reality, and thanks to you all for joining us today. So at this point, I'd like to turn the mic over to Dr. Gillespie, who's going to introduce our first keynote.
Good morning and welcome everyone to the first keynote session of the Symposium on Obesity and Transplantation. My name is Avram Gillespie. I'm both a transplant and a general nephrologist, as well as a clinical researcher looking at kidney transplant disparities, as well as social determinants of health. And I'll be moderating this session. Once again, I would like to thank Dr. Gardner and all the other members of the committee for organizing the symposium to find solutions to the syndemic of obesity and kidney disease. I would like to commend Dr. Gardner for bringing together an international multidisciplinary team of experts from public health, medicine, as well as clinicians, advocacy groups, and people living with kidney disease. I'm confident with this team we'll develop research ideas and will inform solutions to this endemic. Thank you very much, Dr. Gardner. And now I'd like to introduce our first speaker, Babak Orandi. Dr. Babak Orandi attended the University of Michigan, where he obtained his bachelor's degree, was a Fulbright Fellow, his master's degree in clinical research, and his medical degree at the University of Michigan. This also included a clinical research year at the National Institute of Health. He then completed his general surgery residency at Johns Hopkins Hospital, where he also completed his PhD at the Johns Hopkins Bloomberg School of Public Health. He then completed an abdominal transplant surgery fellowship at the University of California in San Francisco. He is an assistant professor of abdominal organ transplant surgery at the University of Alabama. His research has been published in the leading transplant, nephrology, surgery journals, as well as the New England Journal of Medicine. Dr. Orandi will be speaking about whether the body mass index is appropriate for patient selection for kidney transplantation. In this talk, he will describe the obesity paradox in end-stage kidney disease and review the ongoing debate of transplant eligibility for people with moderate and severe obesity. This is a relevant and timely topic because in my practice, both as a transplant and general nephrologist, this is a clinical dilemma I encounter at each clinical session. With no further introductions, Dr. Orandi.
Okay, perfect. Thank you very much. So I think one of the things that's important to mention is that a lot of this talk is actually going to really be more about what we don't know. And I hope that sort of speaks to the spirit of this meeting and the goal of developing research and action agenda as we go forward. These are my disclosures to report. And as Dr. Gillespie said, these are the learning objectives for this talk. Since I'm the first speaker of the day, I'm going to take the liberty of doing a little bit of background epidemiology. I think a lot of us know this, but you can see that over the last 25, 30 years, we've seen quite a dramatic change in the prevalence of obesity in the United States. If you look at data from 1994, this is self-reported obesity. The highest category was 10 to 14% prevalence. But as you look at the most recent data from 2022, that is lower than even the lowest, higher than the lowest category available now with the broad swath of the South and Midwest having obesity prevalence of 35 to 40% essentially. Now, I must admit in fairness that there was a methodology change in the way they calculated this. So after 2000, you can't compare before 2011 and after. So the exact numbers don't really matter that much, except to sort of show that there's this enormous change over time. And so as we look forward to the future, it's estimated by that 2030, half of all US adults will have obesity, a quarter will have severe obesity, and that women, non-Hispanic, Blacks, and low-income adults will be most heavily affected by the obesity epidemic. And at the same time, we also have, of course, the chronic kidney disease epidemic. And so you can see that about 15% of US adults are walking around with chronic kidney disease, but that prevalence is higher in patients with obesity. And if you look at end-stage kidney disease, it's sort of just this linear trend that just keeps going up. And so in the last 2 decades, we've had essentially a doubling of the number of people who are living with end-stage kidney disease in the US. And so obesity is on the rise, chronic kidney disease and end-stage kidney disease are on the rise, but really they're sort of not going up, they're going up in tandem, but very much interconnected and together. And so obesity is actually driving much of the chronic kidney disease and end-stage kidney disease epidemic. And so certainly it does that through its complications, namely diabetes and hypertension, but also through endocrine and paracrine effects of adipose tissue that lead to inflammation, oxidative stress, insulin resistance, dysfunctional lipid metabolism, activation of the renin-angiotensin system. And this also leads to lipid and fat accumulation in the kidneys, development of glomerular hypertension, hyperfiltration injury, that then leads to focal or segmental glomerulosclerosis. And so even on the transplant wait list, we can see that patients that are considered to have the normal BMI of 18.5 to 25 are decreasing in prevalence on the wait list, whereas those who have obesity, overweight and obesity continue to increase over time. And again, these are just the people that actually make it onto the wait list. If you look at this top slide here, this is what we did is we looked at the US renal data system data and took an incident dialysis cohort of about 40,000 people and that we identified as having obesity as their sole contraindication to transplant, and then sort of followed them forward to see the likelihood of getting listed. And you can see that for patients that have increasing BMIs, a stepwise decrease in the likelihood of achieving transplant listing. And then conditional on getting listed, you can see in the bottom slide, the likelihood of actually achieving transplant. So we still see this disparity, even for people who've been approved to get to transplant. We see that there's still challenges in getting these folks transplanted. This is all despite the fact that we know that transplant provides a significant survival benefit regardless of BMI. And so you can see in this top cluster of lines, those are patients who underwent kidney transplant across a range of BMIs. And then the lower cluster are those patients with a range of BMIs who did not get transplant. And so the difference is dramatic, right? And if you look at the difference between those with lower BMI and those with a higher BMI, we're talking about a very, very small difference, right? And I think that's important to keep in mind because we have a lot of sort of barriers in place to transplant and to waitlisting to transplant for patients who have obesity and end-stage kidney disease. In a survey from about a decade ago, almost every single center in the country has a BMI cutoff that they use. Most use at somewhere between 35 and 45. At our center, our cutoff is 40-ish. Sometimes there's a little bit of wiggle room there, but that is sort of what most centers are employing. And there are certainly rationales for this, right? So there are technical challenges associated with performing a kidney transplant in the setting of obesity, largely from challenges in terms of operative exposure of the iliac vessels and the bladder. In patients that have a lot of truncal adiposity, there are increased risks of surgical site infection. We know they have a higher rate of delayed graft function, longer length of stay, more wound problems, like I said, graft and patient survival is worse. And I should say, from a programmatic point of view, these folks tend to, like I said, more complications, longer length of stay, and that doesn't tend to get reimbursed to transplant programs. And so there creates then a financial disincentive to help these patients. And then another sort of thing to consider is new onset diabetes after transplant, right? And so when you have patients after transplant that gain weight, they're at risk for developing diabetes, hypertension, hyperlipidemia, so all the hallmarks of metabolic syndrome. And then you add on all the mainstays of maintenance immunosuppression. So corticosteroids cause weight gain, but they also cause diabetes, hypertension, and hyperlipidemia. Calcineurin inhibitors do the same. Antiproliferative agents cause new onset diabetes, they cause hyperlipidemia, and mTOR inhibitors do as well. And so what you're ending up with is essentially adding fuel to the fire, right? So for patients who are already at risk for developing new onset diabetes after transplant because of the weight gain, you add on the immunosuppression, and we see that there's an up to 40% incidence of this after transplant, and obesity is a major risk factor for the development of diabetes after transplant. And that's very strongly associated with increased graft loss and increased mortality. The other thing that I think, and I'll also add that because of this and the risks of cardiovascular disease, we have almost 1 in 10, a little over 1 in 10 patients after kidney transplant are going to have an MI within 3 years of transplant. And we know that that's associated with a very high risk of mortality within 2 years of their MI. In addition, another barrier that I don't think we sort of talk about enough in transplant is the stigma associated with obesity or against obesity, right? And so this is really, I think, a very interesting study. It's a study of implicit and explicit bias over a number of different sort of topics. And the study was conducted from 2007 to 2016. You can see sort of rapid movement in explicit bias for sexuality diversity, right? We're getting rapid normalization of those, or improvement in explicit bias against people that have that. And this, again, this is in the general population. We see improvements in race, we see some improvements in skin tone, but and even some improvements in explicit body weight attitudes, right? But if you look at here at the bottom, you can sort of see, to get towards neutrality, it's going to take about 34 years, right? And then if you look at implicit bias, for folks with obesity, we're seeing that the biases against them are not changing at all. So, for example, attitudes towards race, on the optimistic end, we're looking at 57 years of achieving neutrality, but there's sort of no trend towards achieving neutrality in the implicit biases against patients with obesity. Now, I would argue that since the study, the end of this study was conducted in 2016, I would argue that since that time, there have been a lot of secular political trends that might change the direction of some of these things, but the point remains the same, that we've in general improved our attitudes towards a lot of different things, a lot of different diverse things, but towards obesity, it does not seem to be changing as much. I sort of found this article, and 96% of parents express explicit bias towards children with obesity. I mean, if parents have that towards children, you can imagine what that means for patients that are in the healthcare system, right? And so that does translate into bias from healthcare providers, right? So this is a really interesting study because it showed, this was a survey conducted in 2001 and again in 2013 that showed that that respondents have improvement in their implicit bias, but actually worsening of their explicit bias. This is considering patients who have obesity as bad and lazy, right? But the remarkable thing is who was surveyed in this study. It was actually attendees of Obesity Week, right? The annual scientific meeting for obesity researchers and clinicians, right? I mean, that is pretty remarkable that people that dedicate their careers to this still suffer from this bias, right? And that translates into our patients. And especially when you think about transplant, because it's not just, do they have, anatomy that's amenable to transplant? Do they have insurance that will cover it, right? There's a big psychosocial component of the evaluation, right? Where you have to say, okay, are they compliant? And if you look at patients who have obesity as being bad, as being lazy, you're not, that may influence the evaluation and the likelihood of a patient achieving transplant. So I think that's an important thing that we don't really talk about that often, but is very important as we discuss obesity and kidney transplantation. And some more recent data, I know we had sort of hoped a few months ago that we were sort of reaching the end of the pandemic, but with over 100,000 new cases just yesterday in this country, I think it's important to point out that another reason that folks have sort of worried about transplanting patients with obesity is that they're much more likely to contract COVID, right? 3.3 times from the French data in the panel on the left. And then looking at national data here in the US, you can see that patients who died of COVID were much more likely to have obesity compared to patients who were on the wait list that died of other causes. And patients who underwent transplant that died were more likely to have obesity compared to those who died from other causes as well. And so, this does translate, all these factors do translate into worse graft survival on the left, and then worse patient survival seen on the right. But again, remember, we're comparing kidney transplant recipients to other kidney transplant recipients instead of what that patient is actually going to be facing, which is a life on dialysis. And remember, we had that giant spread in survival for those who underwent transplant and those who remained on dialysis. And so the question is really like, when do we intervene? How do we intervene? What is the best approach? And so, I think there's no controversy that our best bet is to prevent it before the onset of kidney disease, right? I'm not going out on a limb here, not going to get any angry emails about that, right? And I guess a little bit of an aside, just because this was published just 2 days ago, but the bottom article from our colleagues at NYU, and this is our work at UAB, that if you think about the importance of prevention, right? As we talk about how to get all these patients on the wait list and get them transplanted, we've done nothing to increase the supply. And so we may have them listed, but they still may end up dying on dialysis, right? And so I just sort of think as fascinating as all of this work that we and others have done in the realm of xenotransplant, if you step back for just a second and sort of think about the lengths that we will go to avoid prevention, right? I mean, we will genetically modify pigs and test those in humans. All right. Okay, I think maybe people can hear me now. Okay. So again, the question though, as we get further along this spectrum from kidney health to kidney disease, is when to intervene, how to intervene, what methods, lifestyle intervention, pharmacotherapy, anti-obesity procedures and surgeries. But it's a lot more complex than in the general population, right? And that's largely because of the obesity paradox. Okay, there we go. So, traditionally we think of obesity as being a risk factor for poor outcomes. And so as BMI goes up, risk of mortality goes up. But there seems to be a different survival curve for BMI in patients with advanced chronic kidney disease and end-stage kidney disease. And this is a slide taken from a paper by Dr. Kalantarzadeh, who's going to be speaking a little bit later in this session, but shows that there seems to be some protective association with higher BMI compared to patients in the normal BMI range. But it's interesting because it's not just in kidney disease, right? This has been demonstrated across a variety of chronic health conditions. Heart failure, COPD, peripheral vascular disease. We see this across a number of chronic conditions. And so there are a number of biologically plausible explanations for this, right? The first is, we see that it's observed across a number of conditions. So it's maybe not just some statistical artifact, right? I should also point out, this is very, very controversial, right? I have a very good friend and mentor who is very involved in all of this. And every time I write a paper and I send it to her for her to look at, she just highlights wherever I write obesity paradox and says, not true, crap. But going back to the biological plausibility, so normal BMI of 18 to 25 really rests on the assumption that normal is true for every single person in every single health state, right? So it doesn't matter your age, doesn't matter your sex, your race, what your health is like. For everybody, 18 and a half to 25, that is what should be normal, right? There's also the thought that having more adipose tissue may serve as a reserve for protein energy wasting that results from the chronic inflammation of many of these diseases and helps protect, gives you just a little bit more reserve. And then there's also, which I think this is a thought that I think is particularly salient for the hemodialysis population, that a higher systolic blood pressure is going to protect you against episodes of hypotension. There's also the thought that more adipose tissue allows for greater sequestration of toxins, and that increasing circulating lipids can scavenge endotoxin and help prevent infection. And so here's a sort of a framework to think about how how obesity may actually lead to some survival advantages, okay? If you sort of go to the flip side, right, that you don't believe that this is biologically plausible, if you think this is just statistical fallacy, then there are a number of explanations that would suggest or support that theory as well. It is hard to imagine that there's a disease that obesity causes a disease, but then somehow protects you from dying of that same disease, right? So there's the potential for confounding. A lot of papers about smoking, obviously that tends to lead to a lower BMI, and even attempts to control for it are not necessarily thorough enough. And that there are a heterogeneity of phenotypes within these broad BMI categories. And so it may not, there may be a lot of residual confounding, even though we adjust for many, many things, or there are things that we can't fully adjust for. There's definitely the concern for selection bias, right? Patients who survive their comorbidities long enough to be part of some big cohort study may be different than those who die earlier in the disease process. In addition, patients with obesity may have more comorbid conditions that lead them to seek medical attention earlier, more frequently, allowing other things to get picked up that lead to improved survival. There is the concern for reverse causation. So for patients that have a lower BMI, it's because they have other diseases that cause them to lose weight. The cachexia of cancer is a frequently cited example. And then misclassification, which I'll talk about in just a second. The other thing it's worth noting for proponents of the idea that this is just a statistical fallacy is that the protective effect of obesity goes away after transplant, right? We know that post-transplant patients with higher BMI have worse survival. But so back to the misclassification, I think one of the concerns really comes from using BMI as a measure of obesity, right? It doesn't distinguish between lean mass and fat mass, right? And we know that matters. It doesn't distinguish between where the fat is located. And like real estate, it's all about location, 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 right? And there's also distinction with quality of the fat, right? And so for those who are interested, there is a really fantastic review that was published in February in the New England Journal of Medicine on fat. It's really well written, really quite engaging read, but really goes into a lot of depth about the latest and greatest in terms of science. And it is so much more than we always used to think this was an inert thing. It's not. There's a lot of activity going on in the adipocytes. And so that review is definitely worth reading. But sort of to highlight the point of BMI's inability to really distinguish between obesity and non-obesity is this is shortly after when Trump was president, shortly after his first presidential physical was the results of that were released. Twitter never fails to disappoint. Everyone started pointing out that Donald Trump, Tebow, Mike Trout, they all have the same BMI, right? Probably different measures of obesity will come up with something different if you're using something other than BMI, right? And so I don't expect you to be able to really read this, but what this shows is that when you use other metrics for obesity, so waist to hip ratio, different radiographic measures of obesity, all of a sudden the relationship between BMI and mortality looks a lot more linear and a lot more conventional. Sort of you lose a little bit of that obesity paradox. Again, this is a hot topic that a lot of people feel very, very strongly about, but it's not just a matter of a simple academic debate that's not really of interest otherwise, right? It's actually really critical to understand if the obesity paradox is a result of statistical bias or biology, because the implications for managing patients really hinge on this. So if you look at the latest guidelines from KDIGO about the management and evaluation of candidates for kidney transplant, we get this sort of lukewarm recommendation of, we suggest weight loss interventions be offered to candidates with obesity prior to transplantation. And I'll point out, it's pretty low quality evidence, right? We don't actually know what we should do for these patients. We think we should get them to lose weight. We don't know when, we don't know how, we're not really even sure. Right. And that contrasts really sharply with what we see in the general population. Right. So these are the guidelines. Again, it's really just look at what's highlighted. Right. If you look at this is the general population, these are the guidelines of the American Association of Clinical Endocrinology and the American College of Endocrinology. It's just grade A evidence, like point after point, grade A, grade A, grade A. And that really stands in stark contrast to what we're trying to do for our patients that we're trying to get to kidney transplant. And so whether or not the obesity paradox is real, I do think that the look ahead study is worth kind of reviewing. These data are almost a decade old, but I think it offers an important lesson that we should think about when we're talking about weight loss, again, independent of the obesity paradox. So this was a randomized controlled trial of patients with type 2 diabetes. You can see sort of some of the inclusion criteria there, and patients were randomized to an intensive lifestyle intervention versus diabetes support and education, and that's the control group. The goal was to get to at least 7% weight loss. And for the intensive lifestyle intervention arm, they got group and individual counseling sessions. They were encouraged to do calorie restriction and increase their physical activity to at least 175 minutes of moderate intensity physical activity per week. And their composite endpoint was the first occurrence of death from cardiovascular causes, non-fatal MI, non-fatal stroke, or hospitalization for angina. This was a big study, right? There were over 5,000 people enrolled in this trial. And what they found was that there was no difference in their primary outcome, right? Pretty interesting, right? Because we didn't actually seem to help these people, at least not in terms of the primary endpoint. But what I think is worth looking at, you can see in the top left panel, the patients that got the intensive therapy, right? They lost weight. That first year they lost weight, but then they gained it back. In that first year, they became more physically fit, and then they lost it, right? Their waist circumference went down, so presumably they lost truncal adiposity, and then it went back up. Their A1C got better, and then it went back up. Now, it was always better than the control arm, but I think what to me is sort of most interesting about the study is one of the subsequent papers that looks at body composition during the 8 years of follow-up that these patients had, right? So you can see in the leftmost column, patients lost weight in that first year, and again, they gained it back. They lost fat, and then they gained it back. And then in that bottom left square, you can see that they lost muscle, but it remained lost. It didn't come back, right? So when people lose weight and then they regain it, they're regaining fat. They're not regaining muscle. And that's pretty important, right? In terms of the implications for patients who have chronic disease, who are at risk of frailty and sarcopenia. If you then ask them to lose weight, are we actually doing them a disservice? And I don't think anybody really knows the answer to that, at least not yet, right? And so as we think about if our level 2D recommendation is to offer weight loss interventions for patients that we're trying to get to transplant, then we have to at least consider the fact that if we're going to have cause them to lose muscle, what does that mean for them, right? And so this study just came out last week in obesity, and it's more general population, not CKD, not ESKD, not transplant patients. They showed that adding a high protein diet and calorie restriction led to the same amount of fat loss, but attenuated the amount of muscle that was lost, right? And I think that's pretty important, because if we're going to make patients lose weight, we really want to make them lose the weight that's from fat and not from muscle. And so I think, the other thing that was interesting in the study is that within the setting of a calorie restricted diet, having augmented protein intake also meant that it crowded out a lot of other, so they did a really extensive food diary in the study, but it crowded out a lot of other bad eating habits. And so patients ended up eating a lot healthier just by focusing more on their protein intake. And so I'll be really interested to hear some of our next speakers who are going to be talking about diet in our patient population. And so question is, what do we do for our patients with CKD and ESRD? And, despite the controversies related to the obesity paradox, no one is saying, let's get our patients to gain weight, right? No one's running around to dialysis centers saying, hey, you should gain weight, eat more, exercise less, right? But we still don't have a great idea of what to do. And so I think a lot of us are just flying with the best information that we have. And so, but there are real limitations to what we can do for those patients. And so, I think about diet, and this is sort of true for patients, regardless of the organ that's getting transplanted, but pre-transplant, post-transplant, you have a lot of restrictions, right? If you're diabetic, you're on a carb restricted diet, probably gonna be on a fat restricted diet. Our patients on dialysis are fluid, potassium, phos restricted. A lot of sodium restrictions. I encourage my patients to eat a high protein diet. I know that's not always the same for all like nephrologists, right? That's another area of controversy. I'm hoping we'll hear more about that later this morning. But when you sort of take into account these many restrictions, you're sort of left to wonder, what can my patients eat? I sort of sometimes, when you're talking to patients, I'm sitting there saying, well, you should try to do this and that. And they're like, well, what do you recommend I eat? And I sort of, I kind of try to change the subject. I don't know what else to say, right? And so obviously we're going to have more people talk this morning about where to go, what recommendations they would offer. But these are not easy conversations to have, because again, we don't have great data, right? In terms of exercise, right? I think that when we think about recommending this for patients, I think we also have to be very aware of what condition they're in and their comorbidities, right? So many of our patients have a poor EF. They can't do that much, right? Shortness of breath, chronic hypoxia, fluid retention. A lot of our liver kidney patients are encephalopathic leading up to transplant. They have accelerated muscle loss, sarcopenia, chronically fatigued. And so, for me, I don't necessarily feel like going to the gym. I'm just feeling tired, but that's sort of this compared to this much fatigue that you have from your chronic kidney disease, right? A lot of our patients are really unsteady. They have arthritis and orthopedic issues. I spend a lot of time in kidney eval clinic walking patients, because I do think it's a good test of what they're able to do. I always struggle though with the ones that have bad hips, bad backs, bad knees, and they're really limited by pain. And so simply telling patients to get more physical activity is hard. I sort of extrapolate some of in the last few years. There have been some nice studies coming out, including in JAMA from the CDC, that have shown that it's really just about getting steps in during the day. And so again, for patients that are able to, I just advise them, try to get more steps in the day. But the beauty of those studies, and that's what I always emphasize to patients, is that you get this survival benefit with more steps in the day, independent of how fast you get those steps. So you can sprint them or you can walk them at a pace that's comfortable for you. You still get the benefit, right? And I think that's really helpful for a lot of our patients, particularly those who are intimidated by the gym, right? Or don't have access to the gym, or don't have access to safe places to walk outdoors. They can go somewhere. I always tell patients, go to a Walmart. Most of the country lives within a short distance of a Walmart. It's flat, well lit, safe. I don't know that Walmart corporate is going to want me to tell them to send all these patients with chronic disease to their to their stores, but I do think it's an option for patients. So, but again, just recommending exercise is sort of easier said than done, as with most things with weight loss. Now, there is pharmacotherapy. This is a list of drugs that are FDA approved for weight loss. I've excluded a few like setmelanotide, which is indicated only for very specific genetic variants. And I've also excluded dialpha-propion, phendimetrazine, and benzphetamine, because when they were approved over 6 decades ago, and there's very little FDA guidance in terms of what to do with them in the setting of CKD and ESRD. And their use is really quite limited, but you can see that there's a lot of dose reductions that are required, and for some patients not, sort of contraindicated to use these medications. I put this slide up because I'm one of my favorite things as sort of a clinical researcher is to look at policy changes and see what kind of unintended consequences might occur. And so I think probably everybody in this room knows about the recent change to a race-free EGFR formula, right? And so one of the things that we did is we sort of used the NHANES database to quantify how many people would be eligible for anti-obesity pharmacotherapy, and then looked, because the whole point of this new formula is to help prevent the disparity that we see in terms of African Americans getting access to early referral for specialty nephrology care, and also earlier access to transplant referral. But on the flip side, it potentially precludes them from medications that are renally dosed, right? And so I think it's important to be aware of that potential. And so we see that there are going to be 350,000 more people, Black people, who will be sort of considered as having CKD stage 3 based on their EGFR, right? And it matters because it may not technically fit the definition of CKD, right? Especially lower levels of CKD if you don't have albuminuria and things like that. But when you think about how often EGFR is reported and how easy it is to just kind of look at that and use it sort of casually and indiscriminately, then we may end up precluding patients from getting treatment or getting the right dose to give them the maximal effect. And so depending on the medication, we see the number of Black people who would no longer get the highest dose or might be precluded from altogether ranges from the medication anywhere between 25 and 50%. So a little bit of a digression, but I think it does sort of also raise the point of we still don't even know how we should really be screening these patients, how we should be managing some of these things. So when you look at pharmacotherapy, again, this is general population, right? You can see that the GLP-1 analogs do a really nice job of meeting some nice secondary surrogate endpoints of lower likelihood of microalbuminuria, holding off on renal replacement therapy, things like that. But again, we don't actually know where on the spectrum of kidney disease these benefits, if they continue, or if we start to lose those benefits by causing them to lose weight. And then also mention the SGL2 inhibitors, not FDA approved for weight loss, but have that side effect. But again, real limitations as we talk about our patient population with more advanced kidney disease. Many of them will not be eligible, even though we do see that aside from the many cardiovascular improvements that we can see, you can also see significant improvements in renal outcomes as well. And so the next step, sort of the next, as you escalate in terms of management of patients with obesity, is weight loss surgery, right? And again, the question is timing. We published a meta-analysis a couple of years ago of patients that were moving towards transplant but had obesity precluding them and underwent bariatric surgery to try to achieve transplant. Kidney is a little bit different because with kidney, once you get on dialysis, it's hard to sort of get off that hamster wheel. But for patients that were moving towards heart, lung, liver transplant, a significant number of those patients, if they got bariatric surgery well before transplant or early enough, you could actually preclude the need for transplant altogether. I mean, these are patients that were like actively being evaluated for transplant. So I think that's really, interesting. But again, we don't know exactly where along that spectrum we should be intervening. And so if you do bariatric surgery first, these patients are obviously a little bit higher risk than the average patient with obesity undergoing bariatric surgery. And there's at least some earlier data that suggests that there's an increased risk of mortality, but I think this will get covered. So I don't want to go into too much detail on the specifics because people will talk about that later today. Some people, as I pointed out, may get bariatric surgery, lose weight, and potentially preclude the need for transplant. I'm sorry, we'll be able to get to transplant, and some will be able to avoid transplant altogether. Then there are others that are doing weight loss surgery after transplant, but that means you have to get to transplant, right? So many of our patients will not. They'll die before they ever achieve the survival benefit that transplant offers. Many of those patients will get transplanted with the goal of trying to get them to lose weight down the road, but may die of their cardiovascular comorbidities in particular before they're able to do that. And again, some will be able to lose weight and go on and live in improved health. But we also have to sort of point out that there are a number of barriers to effective care in our patient population, right? So many clinicians don't feel comfortable managing obesity despite how prevalent it is. Many people are uncomfortable even bringing it up. Reimbursement is poor for obesity management. And I think that does influence, if you've got a busy clinic, your ability to spend the time that it takes to actually have these discussions and go through these treatment algorithms. There's a lot of insurance denials. Frequently you have burdensome referrals and prior authorizations that are needed. My understanding is that colleagues at the VA, for example, have a much simpler time getting pharmacotherapy approved, because the VA is able to take a little bit of a larger view and say, okay, if we can prevent the comorbidities of obesity down the road, it may save us money up front, even though, a lot of the medications that are out there now, surgery, they're all expensive, right? And again, cost is an issue. There's a limited number of people who have the expertise to manage these things. And again, there's a lack of evidence about how we really should manage these patients. We have a lot of vague statements about offering weight loss interventions, but that doesn't really operationalize well to the wards. And so we need a lot more research. And I think hopefully today we can set some of that agenda, right? And so for patients in CKD stages 1 and 2, right, you're going to need large sample sizes. You're not going to get the hard endpoints of dialysis, achieving transplant, those sorts of things. So we'll have to use surrogate endpoints, need a lot of follow-up. You're not going to see those late stage events. And as we look sort of further down that spectrum, we've got studies I think that will be more amenable to studying weight loss interventions on progression to the hard endpoints of CKD and kidney failure. But that's going to require a lot of multidisciplinary engagement. That's what today I think is so exciting with all the people that are here in the audience and speaking today, because it requires multidisciplinary engagement. And given how many patients we're going to need for trials of these magnitude, it's going to take multi-center coordination. It's going to take a lot of advocacy from medical societies, right? The National Kidney Foundation, the Obesity Society, and patient advocacy groups as well. It's going to take money, significant investment from funding agencies, from industry, but certainly I think we can all see the value in preventing illness rather than reacting to it. And it's going to take patient engagement as well. And that is a long road, but I think that efforts like today are an important step on that road. So thank you, and I look forward to any questions.
So we have time for 2 questions. We're going to do one from the audience and then probably one from the chat. Does anyone have any questions here? Yes.
I think I hear you talk a lot about survival benefit. Can you talk about survival benefit and comparing to other obese patients? And are you saying survival benefit as opposed to quality of life benefit off of dialysis?
Yeah, that's a great point. So when we talk about survival benefit, sorry, the question is who the referring population is in terms of survival benefit for patients with obesity who get a kidney transplant. And sort of the comparator group, I think, is, I'm sort of, in general, I'm not in favor of too many comparisons between various groups that get a transplant, because again, you remember that slide where you have that cluster of patients who got transplanted, their survival is all pretty similar, right? If you zoom in, they look like real dramatic disparities, but in general, we're talking about, 1 year, 93, 95% survival, right? The comparison group is patients who would otherwise stay on dialysis. It's dialysis that is the comparator group. And so in general, I think we, study after study, whether you're looking at general kidney transplant population, highly sensitized patients undergoing desensitization in kidney transplant, we see that even though these are higher risk transplants, the survival benefit compared to remaining on dialysis is what we're really talking about. And your point about patient quality of life is a very, very good point, an important point, and an understudied point. That being said, I will say if you sort of look at the literature on kidney transplant in general, again, not specific to patients with obesity, but to transplant in general, patients tend to report improved health-related quality of life, overall quality of life, and a lot of their caregivers do as well. But I think that it does require more study. And I think that any of the studies that that I was just talking about that we should do going forward, will need to have a patient-reported outcome component, a significant patient-reported outcome component. One, because I think if we're putting patients through all this, we need to know that it's something that actually benefits their day-to-day lived experience. But also because the FDA is now putting more and more emphasis on patient-reported outcomes as they're looking towards approving various drugs. Thank you for that question. Yeah. Absolutely. Absolutely.
So, great. And so there's a lot of great questions from the chat, and I'll fill you in on those later. They include cardiovascular disease and its effect on kidney transplant, non-pharmacological interventions, which I do believe is coming up. One of the things that came up in the chat was that paper you gave on bias. And I know this is kind of within the scope of your talk, but the idea that as professionals, we have implicit bias. And then we use, so then we think by using the BMI cutoff, somehow this is an objective data point that's unbiased. But yet there's problems with the BMI. If you could just speak a little bit to that.
Sure.
In the remaining few
Sure.
minutes.
So the question is really about bias in the care of patients with obesity. Excuse me. And using BMI as a cutoff to sort of give us this veneer of objectivity. Like I mentioned, our BMI cutoff is 40-ish, right? Because BMI doesn't tell the full story. Patients who are very muscular, they have a higher BMI, but that doesn't really mean much. It also depends on where the weight is. And so the KDIGO guidelines that I showed, if you looked up 1 or 2 points, I think there was some 1B evidence that a transplant surgeon should evaluate the patient's habitus, right? And so part of it is depending on where their weight is. For patients that carry a lot of weight in their breasts, their buttocks, their thighs, that's a very different sort of technical exercise in terms of doing the kidney transplant compared to patients who carry it in their abdomen. But there's no doubt that there is bias in society in general and in the healthcare system. And I think, part of being able to address it is sort of speaking about it and recognizing that it's there. There are probably a lot of people more qualified than I to speak about specific interventions to address it and make sure we get around it and avoid it. But I think the first step is to acknowledge it.
Thank you very much. And anyone else who have questions, write them down because we will have a panel at the end of the day, and then we can do the questions and formulate research questions from those questions.
Thank you.
Also, thank you. You're welcome. You want to stop share? So we have folks from, who's our first one? Here she is. Okay.
Hi, I'd like to introduce our next speaker. She's going to be talking on healthy versus non-healthy weight or high risk and some of the differences in weight loss with people with kidney disease. Dr. Mira Nehari was trained at the University of Pennsylvania School of Medicine. She has been an invited speaker and selected on a variety of committees for the National Kidney Foundation with obesity and kidney disease. She's an active researcher, published author on many topics, speaker on kidney disease and obesity in a variety of arenas. She is a director of research, clinical research in kidney disease. She's also involved in a variety of transplant programs in the Philadelphia area. And thank you. She's also a associate professor of medicine at Drexel University School of Medicine.
Thank you so much for the kind invitation. I'm going to share my screen, hopefully with success. Hopefully that looks good to everybody. And I also apologize for my voice, which is lower than usual. I'm a little under the weather, but I'm so pleased to be here. My name is Mira Harhe, and the title of my presentation is Dying to be Thinner, Identifying High-Risk Weight Loss in End-Stage Kidney Disease. This is my disclosure. Oh, is there a problem?
Yeah, give us 1 second. I'm sorry.
Sure, no problem.
We just have to find the right screen.
Here it is.
He's not gonna be able to read. Keep saying this.
We can't get the right screen to pop up.
Should I?
They're sharing?
Yeah, they need to.
I thought I was sharing. Shall I try again?
Yeah, try again.
Okay. Can you see my screen?
Yep.
Okay. So I know you all heard the title of my presentation, and we can just jump right into learning objectives today. So today I'm going to quickly, in 10 minutes, examine the evidence linking weight loss to adverse health outcomes among people with end-stage kidney disease. Also hope to discuss the unique individual and systemic barriers to healthy weight loss for kidney transplant candidates, and to distinguish features of high risk and healthy weight loss, to introduce that concept and talk about some differences. So I need not repeat what Dr. Orandi already mentioned about the paradoxical association between obesity and survival on dialysis. Numerous papers have found that this association with higher body mass and survival. What I will add is that numerous papers have also found an association between weight loss and mortality in dialysis populations. I should say not just dialysis populations, but also people with CKD progressing to dialysis, people who are waitlisted, and incident dialysis populations. So these studies consistently are finding that weight loss is associated in an independent manner from BMI with higher risk of death in this population. And so what are these studies picking up? And are they kind of complementary findings to this paradoxical association between obesity and mortality in dialysis? So I'm sharing this study, which I published with some colleagues a few years ago. And this was looking at 10 years of deceased donor kidney transplant recipients in the United States. And we were asking the question of whether your relative weight change from the time you were waitlisted to the time you were transplanted was associated with differences in post-transplant outcomes. And so this figure has a lot of information. Just quickly, the underlying histogram in light green shows you the relative weight change of the entire population. So you see that for the most part, that big spike in the middle indicates that most people were kind of similar weight or lost some weight between the time of listing and transplantation. This is using the UNOS data set, and that you have people on the extremes as well. And that solid line that is surrounded by blue tells you the risk of dying after transplantation relative to being stable weight before transplant based on your relative weight change before transplant. And what you see is that as people reach a 10% or greater relative weight loss, that line starts to go up, so does your risk of dying after transplant relative to staying stable weight before transplant. And we found this same association for other post-transplant outcomes, transplant length of stay, and all-cause graft loss. And what was, most interesting to me about this finding is that it was robust after we adjusted for a variety of confounders, but it was also robust in the population that had severe obesity at the time that they were waitlisted. And those are the folks that, again, are mostly are the ones who are either advised or required to lose weight to receive a transplant. So we have been, my group has been conducting a qualitative study, talking to patients about their lived experiences of obesity on dialysis and of how it feels to lose weight. And this idea that there might be a healthier type of weight loss versus something risky that we're picking up in these observational studies. And so this is a map just showing you where our patients are coming from. These are interviews that we've conducted over the last year and a half. And the map underneath shows you the obesity prevalence in the region, but this is where the patients live. And I'm just going to read you some of these quotes and give you this sense that, also through these lived experiences, we're understanding that not all weight loss is created equal. So a male dialysis patient in the southeastern US with a BMI of 42 told us that, quote, "I don't think they, as in us healthcare providers, know that if somebody's dropping weight quickly, it could be because they're not necessarily doing it the healthiest." A male dialysis patient in the Western US with a BMI of 33 said the doctors think that gastric bypass is the magic bullet. It's not. I mean, if you're determined to eat as you did before, you're going to ruin that whole attempt and effort. And a female dialysis patient in the Midwestern US with a BMI of 40 said, 2 months ago, I was really sick and I lost 10 pounds because I had a sore throat and I couldn't eat. And the dietitian congratulated me and said, I think you lost these pounds and all you've got to do is lose some more and you can go get a transplant. So this research overall has led to this hypothesis that there are differences in the ways that people can lose weight. And anyone who's dealt with obesity in their own life or tried to lose weight may understand what I'm talking about when I say that not all weight loss is the same. But there is this idea of what we all hope to achieve, or for our patients, is healthy weight loss. That's weight loss that's associated with higher muscle mass or better nutrition, dietary choices, hemodynamic stability in the case of dialysis. And we hope that that healthy weight loss would lead to energy and strength and survival. But we must also acknowledge there's a possibility that these patients who have chronic disease, chronic inflammation, and multiple challenges for healthy weight loss could also experience high risk weight loss. So that might be weight loss where we're really not seeing improvements in nutrition or muscle mass, and we're seeing worse inflammation. And we might expect that, as some of these observational studies are showing, that high risk weight loss might lead to death, might lead to hospitalizations, might lead to worsening mobility. How do we differentiate? We did a study where we asked renal dietitians across the United States how easy it is to distinguish between this idea of healthy weight loss, what we're all hoping to see, and high-risk weight loss among end-stage kidney disease patients with obesity. In this, on the left, you'll see that the renal dietitians were quite sort of spread out, very difficult being towards the left. It's very difficult to tell with these patients what's going on with their weight loss, all the way to the right, very easy. For the most part, kind of in the middle, And when you talk to the patients in our qualitative study, they give us a more sort of in-depth understanding of what it means for them to have healthy weight loss. So for the patients, they talk about things like less knee pain, looking happy, being energetic, good attitude, stamina. And then, versus, a person who's having risky weight loss would be visibly frail. Rapid weight loss came up a lot. No desire to eat, no appetite, or in and out of the hospital. We did a study, a more recent study, where we had the advantage in this setting where we could actually differentiate between intentional and unintentional weight loss. This was a study that looked at 919 kidney transplant recipients, and we were able to look at the data that patients were asked at the time of transplant about their previous year's weight change and whether or not that weight change was intentional or unintentional. This was looking at 5% or more weight change in the previous year before transplant. And I'll just point out that it was really unintentional weight loss that in this study was associated with more post-transplant weight gain, a higher risk of death-censored graft loss, and higher mortality risk compared to being a stable weight after transplant. Whereas intentional weight loss was not associated with differences compared to having a stable weight. But where it gets to me very interesting is trying to understand what the differences are between unintentional and intentional weight loss in this population. Intentional weight loss, where you see the blue box there, you might not be surprised that the majority of people who reported intentional weight loss before transplant had an overweight or obese BMI before transplant. And, even despite their intentional weight loss, 40% of them reported low physical activity, 24% of them reported exhaustion. But when you get into unintentional weight loss, and again, this is a concept that's related to frailty, low functional status. In this setting, 66% of the people who reported unintentional weight loss also had an overweight or obese pre-transplant BMI. Nearly 60% of them reported low physical activity, and nearly 40% of them reported exhaustion. So you can understand that unintentional weight loss occurs in people with overweight and obese BMIs, and those outcomes are worse after transplant. And there's a difference there between what is happening unintentionally versus intentionally. So it probably goes without saying that most obese dialysis patients want to have healthy weight loss. When they're in studies and surveys of patients, people talk about the why. Transplant is very high up on the list, but studies have pointed to goals like better health and mobility, higher self-esteem. But we really do need to understand that there are unique barriers to healthy weight loss in this population. So when we talk to the patients in the qualitative study that has just concluded, a lot of them talk about the lack of energy, and it's really profound. I mean, most of them are living the lifestyle of in-center hemodialysis every other day of the week, feeling completely washed out after treatment, and really not having the energy to do the food shopping, prepare the healthy foods, make the healthy food choices. It's the quickest thing, to eat and then get a rest. The dietary restrictions are also really challenging. They limit the utility of many popular weight loss programs that give advice like drink a lot of water, to maintain satiety. Food costs and food insecurity come up as well, and then limited support in dialysis settings. So when I, as a transplant nephrologist, tell a patient that it's advisable that they lose weight, I'm counting very much on the support that they get not only through our transplant program nutritionists, but also their renal dietitians. I'm counting on the fact that they have nutrition care embedded in their dialysis care. But a lot of the patients report that really, that care, that obesity-specific care is quite limited in dialysis settings because there's so much else that has to be covered when they meet with their renal dietitian. And really that the goal setting is very short term. It's like, you need to reach this BMI for transplant, but they don't focus on all the other things or the long-term benefits of weight loss, long-term goals that I mentioned earlier. When we surveyed the renal dietitians about some of the challenges to providing weight loss support in the dialysis settings, the majority said, we just don't have the time. There's just too much to do. But a lot of them also reported they're not really trained for this. They're not really sure what to monitor. Others pointed to resources as well. Few said there were no challenges. And we talked to patients specifically about their perspectives on BMI thresholds for kidney transplantation. And I think that, in the interest of time, I won't read all of these quotes, but I will tell you the themes. So again, weight loss addressed really only in a transplant context. Kind of, this has never been mentioned to me before. No one's really talked to me about my weight or any other issues around it, except now transplant. They told me I need to lose 50 pounds. They give you some pamphlets and that's about it. The difficulty with the restrictions and other comorbidities, this real desire for more holistic care and understanding what drives obesity. The promotion of surgical measures, many patients said, these surgical obesity interventions are really kind of pushed on me. And I would really like it if there were other interventions that were an option. And one patient said, let's just say the gastric sleeve was a requirement to get on the transplant list. And then the specific idea of BMI as a barrier, so BMI thresholds also was very unpopular in this patient, this study. And one person said every transplant center that I've applied to, they have BMI criteria, which I think is frankly outdated. I wish they'd go by muscle mass. This is going to be presented at our upcoming ATC meeting. So in conclusion, when we talk about the features of high-risk weight loss, I'd just like to really state that unintentional weight loss is probably quite common in our population of interest, people with obesity who have end-stage kidney disease. And we really have to understand whether what we're seeing when we're monitoring these patients, even in the setting of a weight loss intervention, is this sort of high-risk weight loss. And what patients tell us is high-risk weight loss, what some studies are pointing to is lower energy, lower physical activity, rapid weight loss, and certainly weight loss around things like hospitalizations. Key barriers to healthy weight loss and end-stage kidney disease, things like the dietary restrictions. How do you work around those? I know there will be some speakers about talking about this. That's so great. Behavioral challenges, the things like low energy that really make it difficult to make good choices, and low perceived support from healthcare providers. We really need a village. We can't rely just on dialysis-related support to help these patients. And then priorities for improved obesity management from the patients. They ask for more holistic care. And they ask us to focus not just on the long-term goals, not just keeping the eye on the transplant prize, but really on the long-term goals of achieving a healthier weight. I just want to acknowledge all of the collaborators, colleagues, and the grant support for this work. Thank you very much.
Anybody in the audience want to ask a question? So the question is, has there been any thought on what you could do to differentiate on the people that are going through the unhealthy high risk weight loss as opposed to more nutritionally sound?
Yeah, this is exactly what we're focusing on now. And some of what we're learning through the qualitative evidence is that we really have to look at some of the physical activity, physical function, body composition measures, and quality of life as endpoints of weight loss. There's also a fair amount of agreement about rapid weight loss. And so understanding what healthy goal setting should be, and really being on alert, even in our patient population with obesity, for this unhealthy weight loss. Whatever we are picking up observationally certainly is consistent with this concept of reduced resilience to health stressors, and weight loss is part of that if it is in a high risk sort of manner. So all of those are where we're sort of where the evidence to date is sort of making us triangulate. But what are the exact right things to measure and how often to monitor are all good research questions.
Question from the chat is, any data on non-diet approaches that do not focus on intentional weight loss but improvements on health promoting behaviors instead?
It's a great question. I saw it from earlier, and I am not aware of studies that that have really just, especially in this population where we're not really looking at weight. We're looking at, other measures of health. I think it would be an incredibly valuable, even as secondary endpoints, better dietary quality and other sort of endpoints of health promoting behaviors would be an excellent line of research.
Then the next question is, when supporting patients through intentional weight loss versus unintentional weight loss, who should be the primary clinician? Is there such a person, renal dietitian versus transplant dietitian? Primary care, many physicians are not trained.
Yes. So what I didn't mention about our qualitative study is that we also spoke to a lot of different types of healthcare professionals to try to get at exactly this question. Renal dietitians, transplant dietitians, nephrologists. I would say that part of the issue is exactly what was mentioned by the person who asked this question, is that the training is very uneven. The time also to address this is very limited. And so, to me, what it means is that there really should be an added layer of support and monitoring beyond kind of our current the main sort of stakeholders that were mentioned. Who is that clinician? How often should patients be monitored? What should we be looking for? All areas of, I think, that are valuable for future research.
Okay, so the rest, keep putting the questions in the chat and we'll address them in the panel after. Thank you so much for such a wonderful talk.
Thank you. There was a comment that said, always ask your patient, how did you lose the weight? And I would just like to echo that. It's so important.
Also get the people involved in their goals too.
So I think we'll need you to stop sharing. And then Dr. Stuckey can share his. Yeah, sorry. Dr. Jesse's here. Okay. Are you more technologically savvy than I?
Well, we're about to find out.
Or shall we call Sam back in?
Joshi. Yep.
So I'd like to introduce Dr. Shivam Joshi. I had the honor of hearing him talk at NKF. I think it was 2019, totally changed the way I practice as a dietitian. He was educated at the Miami Miller School of Medicine. He did his undergrad at Duke. He's associate professor at NYU. He was the 2021 Joel Koppel Award winner, which is a very honor for the dietitians to award it to a physician that does great research promoting dietitians. He's highly requested speaker on plant-based diet and promoting changes in kidney diet. He's always very happy to share anything. He's very requested by dietitians all over the country. He's got many publications on keto and plant-based eating and kidney disease. And I'd like to turn over. Thank you so much.
Thank you for having me. Thank you for your kind words. Okay.
No problem. He needs speaker notes or not? You good to go.
Thank you for having me. I'm glad to be here. I'm going to pull out my phone so I could stay on time. So as mentioned, my talk is on plant-based diets for kidney transplant candidates. The reason we're talking about this because this could be a possible way forward But probably for today, it's probably a good research question because we don't have great research on this to talk about. We don't have that robust randomized controlled trial, let alone a meta-analysis of data to say that this will work. But what I hope to do in the next 9 minutes is to suggest that there are some reasons to think that this could work. So I have a few disclosures. None of them really pertain, but in the for the sake of full transparency. And more importantly, I do love my veggies. So a little bit about me. I'm a clinical assistant professor of medicine at NYU. All my time is at Bellevue. I work at a public hospital. I'm also a lifestyle medicine physician, nephrologist, primary care doctor, and these are my research interests. That's my team in the clinic, and I've been plant-based personally since 2013, and has helped my own health and the health of my patients. And today I will briefly be running through these topics: an introduction to plant-based diets, I should say there, a little bit of background on these diets, causes of kidney failure, how these diets could potentially improve health and kidney disease, especially the potential benefits for those who are transplant candidates. I'll talk a little bit about obesity, potential risks, my professional experience in conclusion, which seems like a lot, but pretty much one slide each on each topic. But rest assured, for many of these topics, I have whole PowerPoints ready to go. So what is a plant-based diet? So there's no exact definition. It doesn't even mean that you have to be vegan or vegetarian. Your diet is just mostly plants. And another way to say it is that you are eating less meat and dairy than the standard American diet. There's a lot of similar terms on this: plant dominant, plant strong, plant supportive. The list goes on and on. All that it means is that plants are the focus of the plate. So what is a plant-based diet, or what are some examples of a plant-based diet? You have Mediterranean, vegetarian, flexitarian, pescatarian, reducitarian, vegan, DASH, whole food, plant-based. These are all examples of a plant-based diet. Of course, with vegetarian diets, there are several subtypes, including lacto-vegetarian, ovo-vegetarian, and then combining the two, you can get lacto-ovo-vegetarian. But these are all examples of a plant-based diet. Plant-based diets can still be unhealthy. That is a photo of a burger that I ordered once. I, of course, had to try it to find out what is unhealthy. And those are examples of fruits, which are, of course, healthy. And I included this quote, and it touches on what Dr. Arandi was saying in his talk earlier. We go through such great lengths to modify a pig's heart, and then for prevention, we kind of just sail past it. But this is actually a quote from Christian Barnard, the first human heart transplant surgeon. And he said, or he's quoted as saying, that I've saved the lives of 150 people by heart transplants. If I had focused on preventive medicine earlier, I might have saved 150 million. And I think that's very true for both hearts and kidneys and many other diseases that could be prevented with lifestyle change. And the reason that it's important here in regards to kidney transplant is because the supply of kidneys is woefully inadequate to the demand for kidneys, as we all know. And that has gotten worse and has improved slightly due to some changes in categorizing who is on the wait list or who is active on the wait list. But as you can see, the take-home point is that demand for kidneys exceeds supply. It was only after I left med school that I kind of understood what were the causes of kidney failure driving that demand. And as you can see here, so the data lags a little bit. This is from the latest 2021 report from USRDS. And they look back, it takes them a few years to process this data. If you look back to 2019, 48% of cases of kidney failure were listed as diabetes, another 29% was hypertension. And when you combine that, 77% of kidney failure is either diabetes or high blood pressure. And if you look at that further, 90% of all diabetes is type 2 diabetes, and 90% of type 2 diabetes is preventable. And the same thing with high blood pressure, 80% of high blood pressure is preventable. So you can kind of see where I'm going with this is that if 77% of kidney failure is either diabetes or high blood pressure, and 80-90% of those cases are preventable, then you could argue that a large proportion of kidney failure is preventable. And that kind of leads me to my next point, which is preventing the causes of kidney disease. If we can prevent the causes of kidney disease, we could maybe not need conferences like this in the future, but then what would we do on a Friday morning? So we recently published this paper and we highlight this graphic comes from there. So the major causes of kidney disease are diabetes and high blood pressure, but obesity is emerging as a cause. And you could say obesity drives diabetes and high blood pressure. We know that as people lose weight, diabetes and high blood pressure does improve. For those who already have kidney disease, eating a healthy diet could potentially ameliorate some complications of kidney disease, like high phosphate levels, for which our patients are asked to take these large and cumbersome pills every time they eat, metabolic acidosis, which requires more pills, high blood pressure, toxins, and mortality. And then finally, there is some evidence to suggest an improvement in the decline in kidney function. And again, there's a lot of information behind all of these points, but I just mentioned them just to kind of bring them up. And that work ultimately led to the process to start and rethink what is the renal diet. I think everyone in this room has come across the renal diet in some way or talked about it, and probably has been unsatisfied with the renal diet, I would go so far as say. And I've been lucky enough to work with Dr. Cam Kalantar, who also happens to be the next speaker, on revising the perhaps the future of the renal diet. We've termed it the Plato diet, the plant-dominant low-protein diet for chronic kidney disease. And the idea behind it is to eat mostly plants, because plants have a lot of benefits, not only in patients with kidney disease, but those without kidney disease, but also to combine the beneficial aspects of eating a low protein diet. Together, this is the Plato diet, as we've termed it, and includes some other aspects, including limiting sodium, consuming fiber. And the idea is to do the things that we discussed in the previous slide: slow CKD progression, delay kidney failure, improving overall health, and hopefully improving survival. Do we have robust, conclusive evidence that we can do this? No, but neither did the prior renal diet. The prior renal diet was just expert opinion based on almost no evidence. This actually has a little bit of evidence and is several steps forward compared to the traditional renal diet. So my professional experience with plant-based diets in chronic kidney disease, especially advanced chronic kidney disease, which are the folks who would ultimately be considered for kidney transplants, that they may help them reduce weight and help them qualify for a transplant. I've had several patients in my own experience with that, may delay the need to start dialysis, and that includes low protein diets, as we discussed, and also their counterpart, very low protein diets, which include keto analogs, may also reduce the severity of comorbidities, may reduce pill burden, and may also reduce some symptoms of mild uremia. And there's also evidence to suggest all of these as well. But the main focus of today is on weight loss, so I'll spend a little bit of time talking about that. So how can plant foods help with weight loss? There's several ways that this can happen. There is no specific one paper that discusses this in patients with kidney disease, but the best paper I could find is this paper here that was written a few years ago. And what they go through and describe is that there's multiple factors that could help with weight loss. So the idea is that these foods are high in fiber, which is devoid of calories. It occupies space, may help with satiety. Plant foods generally have a lot of water, which helps people feel full. But more importantly, it helps avoid eating these extremely calorically dense processed foods that surround our environments and are everywhere in society. You know which foods I'm talking about. They're everywhere in restaurants and vending machines and in our fridges and everywhere. And these foods are not healthy. They're not fruits and vegetables or whole grains or beans or lentils or everything else. And they're the foods that we eat and contribute to an excess of calories, which ultimately leads to weight gain. Some people have also theorized that eating plant foods may increase metabolism. That is controversial. And then also there may be an increase in the thermic effect of food, which is the metabolic cost of extracting the energy from that food. An important point to note with weight loss is that caloric restriction is the underlying theme for all weight loss. A calorie is not a calorie, but also it is, I would argue, impossible to lose weight without restricting calories. And when you look at multiple diets that have been published and researched over time, the universal aspect of all of these diets is that they're restricting calories in some fashion. So if you know that, then you can take that point one step further and determine which diet does that and which diet actually carries the most benefits and the least amount of risk. And this is why I have these scales to kind of weigh the risks and benefits of each diet. So anytime you consider any dietary pattern, you want to consider the benefits versus the risks. Each diet has its own unique aspects to it, the ability to adhere to it in a long term, the cost and availability of this food. Unfortunately, due to a variety of reasons, fruits and vegetables are not very affordable in some places, in many places, but can be if you find them in season and certain things. Food quantity is also important, and also which refers to calories, and but also the food quality. So I'll talk a little bit about a study that looked at a vegan diet and keto analogs. This is a study that talked about how if it was possible to delay dialysis. This was a prospective randomized multi-center controlled study, 48 months of follow-up, 56 patients in each arm. These patients had uremic symptoms at the time of randomization. And what they found is that patients who were randomized to a diet arm were able to delay dialysis. 71% experienced a median 9.8 month delay in dialysis, and there was also improved survival at 2 years. This is just one of many studies that can show the potential benefit of these diets, but I thought this one was worth mentioning because I see many patients. I receive requests for consultations of people who have mild uremic symptoms and they want to delay dialysis so they can make it onto a transplant list and ultimately get transplanted. Unfortunately, I wish I could see patients earlier in the time course, maybe at stage 3 or 4, but many of them come to me with GFRs less than 10, and then it's challenging. I included this slide to mention the potential benefits of a plant-based diet post-transplantation. When you look at the literature, there's a couple of nice review papers that discuss this issue. They mention studies showing a possible lower risk of graft failure, a lower risk of kidney function decline of the transplanted kidney, a lower risk of death, lower risk of metabolic syndrome, and then also a lot of other markers that are just generally good for health, including lower oxidative stress, blood pressure, lipids, insulin resistance, inflammation, and arterial stiffness. As I mentioned, all diets have potential risks. Plant-based diets have potential risks, including hyperkalemia, protein deficiency, B12 deficiency, vitamin D deficiency, which can also be seen in omnivores as well, and iron deficiency. But many of these issues can be appropriately managed. Some of them, I think, are overblown. And then a couple of these we have written ourselves. These are 2 papers that Cam and I have written over the years. A lot of my work is pretty much focused on this. A wise man, I think from Philadelphia, said this quote, but I can't remember the ending of the quote. An ounce of prevention does something, but the idea is to move people along the spectrum from eating probably some of the unhealthiest food on the planet to hopefully the healthiest food on the planet, some of the healthiest food. So some suggested reading. These are 2 review papers that talk about plant-based diets or diets in general as they relate to patients on the kidney transplant waitlist or who have been transplanted already. There's many people I'd like to thank. I would not be here without their help and insight. And I will now take questions, and I want to thank all of you for staying awake during my whirlwind tour of plant-based diets and kidney transplant candidates. Yeah. Yeah. Yeah, so once patients are on dialysis, since dialysis is a catabolic state, they should be getting 1.0 to 1.2 grams per kilogram of protein per ideal body weight, assuming they're in maintenance dialysis and they don't have any acute illnesses. Prior to that, there is some variability as to what can be done, should be done. Average amount of protein intake for all comers is around 1.2 grams per kilogram per day, which some nephrologists will argue I'm in that camp. That's probably too much for someone with CKD 4 or 5 because that probably hastens the decline in kidney function. So what we've seen as of recently, and this has also been reflected in the guidelines, to consider a lower amount of protein intake, 0.6 to 0.8, which classifies as low protein, but you can go to very low protein, which is less than that. But if you do go to very low protein, which is less than that 0.6 number, then you should consider supplementing with the keto acid analogs, which have recently become available in the United States. Does that answer your question? 0.6 to 0.8 is considered an adequate amount. You don't have to supplement additionally, but that is relative to the patient. If they have a wound or they have something else going on, their metabolic needs may be higher, but assuming that this is not occurring and they just have CKD5, I often recommend a protein intake in that range. Some people say if you are elderly and eating a plant-based diet to add a 10% correction factor due to a decrease in absorption of the protein quality, but somewhere in that area is adequate. Any other questions? All three. That table is just buzzing with questions. Okay, we'll start from. Yeah, exactly. And I still get comments from patients, even providers, dietitians, saying that it's hard to combat the confusion. There's so much confusion, so much of the old information percolating. But hopefully the information does get out there. Okay, going down that table, middle person. Yeah, thanks for mentioning that paper. If my research assistant was here, he would have loved to hear you say that title because that was his idea, but I'm happy to share it. I'll be back there and you can give me your email and I can email it to you. And then last person at that table. Okay, first question was just more of a comment that there's a little bit of dissonance out there between the new information and old information, but it sounds like it's percolating. And the second question is asking for a copy of a recent paper that Cam and I wrote, taking the kale out of hyperkalemia, which references perhaps the overstated risk of plant-based diets causing hyperkalemia. We show evidence that suggests that's not the case, but there are potential ways that you could do that if you really wanted to, which why would you? At any rate, and the last person at that table. Oh, yeah, sure. If you want, and if anyone wants my slides or wants a paper, I'll be back there at least through lunch. No, thank you.
It's my pleasure to introduce the next speaker, Dr. Cam Kalantar. He's the USC nephrology chief of nephrology, studied medicine at University of Bonn, Germany, MPH and PhD degree in nutritional epidemiology from UC Berkeley, trained at the University of Nuremberg and SUNY Brooklyn and University of California, San Francisco Medical School, triple certified internal medicine, nephrology and peds, certified transplant physician, authored nearly 1,000 peer-reviewed papers and numerous NIH grants to conduct studies for CKD, dialysis and transplant, past president of several professional societies and current co-chair of World Kidney Day. He's the editor-in-chief of the Journal of Renal Nutrition with the National Kidney Foundation. He's president-elect of the National Forum of ESRD Networks.
Great. Thank you, Karen. I apologize to colleagues. I'm currently in Paris, France, in the convention center. It's ERA, European Renal Association Congress. The ambient environment is somewhat loud. I try my best to talk as loudly as possible, but I hope everybody agrees that instead of me walking to Eiffel Tower, I'm sitting here to be part of this great conference. I learn a lot by listening to the first speakers, including Dr. Orandi, Dr. Jorge, and my friend and colleague, Dr. Shivan Joshi. So I'm going to move relatively fast because in 15 minutes, I have to show a lot of slides, the sources of slides, the objectives of today, which is pretty much the title says. This is something that was highlighted. I wasn't supposed to talk about this obesity paradox. That means in the general population, obesity is bad. In dialysis patients, obesity is good. And do I believe in that? Or is it just something I have published? Yes, I believe in that. In fact, I pass out sandwiches every 2 to 3 months during my dialysis rounds. And I insist that dialysis patients should gain weight, dry weight, not water weight. In studies of the SRTR data and DaVita data, we found that out of 14,000 patients waitlisted under DaVita, those who lost weight while waiting for transplant, their mortality was high. So essentially what we are looking at here, again, is waitlisted transplant patients, those who gain weight, gain dry weight versus those who lost weight. If you want your transplant patients to live long enough to be transplant waitlisted patient, then you better be careful with that. And here I'm ongoing with all the respects I have for all transplant surgeons. They're my friends. I like them a lot, but I don't let them force our dialysis patients to lose weight. I'm not sure if it's good or bad, but I believe there is biologic plausibility. But if you look at muscle mass, then that's yes. Then I have to give up, because muscle mass weight loss is associated with worse survival, right? So maybe weight loss is muscle mass loss. So I'm not sure. And here I'm going to for the sake of being balance, I'm going to also share with you one piece of data where we found that obese patients who get kidney transplant, then delayed graft function is higher. So I'm going to give 1 point to those who are against obesity because delayed graft function goes up. When the Hissens, of course, you guys know, goes up and so forth and so on. But this is what we see. So therefore, we can be discussed back and forth, is it good or bad to lose weight? So high BMI in transplant waitlist dialysis patient is associated with greater survival. Losing weight increased death while waiting for transplant. However, delayed graft function is different. Now, let's move on to what I'm charged to present, essentially what's going on. So in the past, this is about dietary management of patients with CKD, life-sustaining supportive care, and what is better now in 2022, this is called later is better, supportive care, life-sustaining care, but this is right now you're sitting, it's the era of value-based models, CKCC and KCF, kidney care first. And if you look at historically, 50 years ago at this time, the first and last socialist medicine was signed by President Richard Nixon. This is called ESRD program. ESRD, whether you like R or not, is the name of the legislation. You can change the name of legislation from R to K, ESRD legislation. And dialysis is hope. Dialysis has given 50 years of hope of continuing valued relationship and rehabilitation, achieving goals and pursuits. However, if we can delay dialysis start, why not? While patient, this is the era again of value-based models. Preemptive transplant is going to go through the roof, hopefully, based on the 3 pillars of value-based models. And therefore, delaying dialysis is not for just old people or avoiding dialysis for everybody, because there is also incentives from the government. And preservative management is going to be the prime times topic. Prolonging dialysis-free time and achieving the greatest survival while patient is delaying and deferring dialysis. But how can this be achieved? Is there a magic pill to delay dialysis? If we had it, we would have already offered it to our patients. So this is the model that, again, I highlighted in Lancet paper recently. And I said that here, diet and lifestyle modification is the foundation of conservative management, kidney preserving care. To achieve these goals. That means to reduce uremia so that patients don't need to start dialysis, as well as other things. And as I said here, this was all started in July of 2019 when previous president, it doesn't matter which party the previous or current presidents are presidents, and they have, unfortunately, and in this area, they have worked consistently, realign and align. That means reducing number of dialysis patients by 25% by 2030, and aiming more home dialysis patient dialysis, and also aiming more kidney transplant and preemptive kidney transplant. Again, value-based models of 2022 that started just a few weeks ago. And how can this be achieved? I'm not going to talk about exercise because there are exercise colleagues here. I'm going to talk about diet modifications and how we can achieve through diet. Now, what if our dietitians and our very smart people, especially doctors, says go eat a lot of protein? It's good for you. Imagine I'm sitting in a conference right now here. I have to go to dinner, faculty dinner in Paris is actually evening, and they're gonna say that, hey, Dr. Counter, why don't you eat a lot of protein? And everybody else is looking at me. So should I give up to the pressure that high protein is good? And the fact is that protein, on average, the US population eats 1.3 to 1.4 grams of protein per kilogram per day. And low protein is defined as a protein amount that is less than 0.8. Now, you're going to be surprised that 0.8 is actually normal, it's not low. But given the cultural pressure, we have labeled it as low protein. And below 0.6 is very low protein, as Dr. Shivam mentioned. And Dr. Joshi mentioned, as Shivam mentioned. So now KDOQI guidelines has suggested that CKD patients without diabetes should eat 0.55 to 0.6, and with diabetes, 0.6 to 0.8. Some of them is based on randomized trials, some of them opinion-based. For example, for diabetes, there is not a lot of data. Now, let's see if it is safe or not. First of all, is it working? In 1994, the so-called MDRD study, modification of diet for in renal disease, or MD and RDs, that means nephrologists and RDs, dieticians work together. So that's why the abbreviation was chosen, showed that low protein diet didn't work. This is essentially the famous famous figure of that study that, hey, it doesn't work. But something a lot of people forgot is that the fact that had no diabetic patient, and over 40% of patients were PKD. PKD patients, it takes decades for them to progress to ESRD. Good for them, but bad for the study. Now, if you look at here, why low protein or high protein? If you look at here, what's happening with the glomeruli, what ACE and ARBs do, they essentially open the efferent arterioles, or SGLT2 inhibitors. They tighten afferent artery, and that's what you can achieve with low protein diet without side effects of these medications, for instance. So now, if I look at here now, again, vasoconstriction versus of afferent versus vasodilatation of the efferent arterioles, SGLT2 versus ACE inhibitors, you can achieve this. Right now, those, if you were in Paris, those who were eating a lot of protein with me, with amino acid surge, the afferent artery is open and GFR goes through the roof. Now, imagine, I have not had a chance to eat a lot today at all because I've been busy going from one meeting to the other meeting. My amino acid surge is low and my GFR is low. So therefore, this is one great study from 30 years ago. Tutel, who is still around, and Dufronzo, who is still around, both of them are very active. They essentially gave amino acid infusion to diabetic patients and noticed that GFR goes from 95 to 165. You double GFR by eating a lot of protein. Now, next time you tell your diabetic patients, go and eat a lot of protein to lose weight, just see what you do with the kidneys. You overburden the kidney. And even in people who are sitting here don't have diabetes, your GFR goes from 90s to 130s. So studies have shown that high protein intake is associated with the risk, higher risk, tendency to high risk of kidney disease. And that's why when we said high protein diet can be harmful, unleashing the taboo, we already unleashed the taboo 3 or 4 years ago. And this is the aftermath of saying that high protein diet may be good for so many things, but not for kidneys. And that one is, even that one that I'm saying is debated. So therefore, if you look at MDRD study, initially actually GFR got worse, because when you don't eat enough protein, GFR gets worse. It's like ACE inhibitors and SGLT2 inhibitors. When you start first, creatinine goes up before over time it slows down. I mean, see, if you had looked at this study from month 3, the study would have been positive, and we would have been in different dimensions, like Dr. Strange's different, or Spider-Man, giving low protein diet. But we are not in that universe. We're in the universe that in the other study was considered positive, was negative, sorry, and low protein diet went away. But if you look at all these studies are very similar. Low protein diet, RAS inhibitors, SGLT inhibitors, initially things get worse before it gets better, right? So very similar. So I don't know why low protein diet, nobody pays attention to that for CKD patients. And with all these great medications, this is called why cardiologists, when they give statin, they also say run, change diet and lifestyle. But nephrology just give them this medication, that medication, we don't change anything. Usually not. Now, is there a harm of low protein diet? Can low protein diet cause malnutrition? Guess what? The amount of the protein that's recommended by the Institute of Medicine, National Academy of Medicine, is only 0.8. And when I say only 0.8, actually 0.8 grams per kilogram per day is the recommended dietary allowance. And most of the time we eat 50, 100% higher than that, and we call it normal protein diet, not even high protein diet. So that means it has been very safe based on metabolic studies. And in the past, one of the problems with MDRD was that the protein should come from high biologic value proteins. And Dr. Shivam Joshi taught me that was wrong. And he's right that this is complete. This is something, there is no even data about eating more animal proteins when you eat less proteins to ensure that you have all essential amino acids. If anything, plant dominant diet is what we recommend now, that at least 50%, if not even 2/3 or 80% or 90% of protein should be plant protein as compared to animal protein, and data about high biologic value should be questioned. So this is what I would suggest to dialysis, I'm sorry, not dialysis patients, I'm talking about patients with CKD, not on dialysis. Remember that this is the title of my presentation. And what about potassium? I think again, Dr. Joshi and others mentioned that in this era, even in the past, we never had any credible data suggesting that all these don't eat banana, avocado, all those things have ever helped, except for making our patients being more restricted with good, healthy food. Now, what about monitoring? What about adherence? Well, all patients who come and fly to see me from Philadelphia, for example, Philadelphia doctors, they tell them you need to start dialysis, and they come and fly to Southern California to see me. And I say that come here 2 days ahead of time, sit down, collect 24-hour urine, make sure you don't place it next to orange juice so people don't confuse it with drink, but do a good job, 24-hour collection. The first urine of the morning, they won't know. After that, everything collected until morning of day 2. Then we calculate urine creatinine to make sure it's not over or under collections. And then with that comes now with the value-based models and supplements. What is there a role for supplement? Well, that's 1 hour talk that I'm presenting in 65 seconds. And the answer is that data have shown the lower is the protein. That means you go below 0.6, below 0.4, 0.5, then this lowers the rate of progression. But you can't go as low because then you may cause harm. This is where malnutrition, protein, energy wasting becomes very likely. So what have been done in the past in 70s and 80s, and now again coming back, is to give keto analogs of amino acids. And these are amino acids without nitrogen. It's like science fiction, how amino acids define having nitrogen. Now imagine it doesn't have nitrogen, it's still amino acids. And these are called keto analogs of amino acids that has nothing to do with ketogenic diet. Some people call it keto diet. This is keto acids or keto analogs of amino acids. A lot of data from the past that are coming back now. No credible study in recent years, but all studies actually, there's one study from Romania, because keto analogs exist in many other countries to slow progression. And keto analogs exist right now in your liver because there is deamination of amino acids. And this is one of the studies that when patients start starting dialysis, they continued low protein diet. Even old people with keto analogs, they did as well. Now, I encourage you guys to go and look at them. So why? Because in the value-based model, in the VBM, the revolution of the CMS in kidney care with the 3 pillars that started this month as you're sitting, this is going to become very important. Now, barriers, is there room for animal versus plant-based protein, or is it about quality? I said, no, it's not just quantity, it's quality. Animal, this is one of the greatest studies from a late colleague from Greece, who showed that for the same amount of animal-based protein, low protein diet, if you replace it with plant-based protein, then the outcome, greater outcome is achieved. And here also epidemiological studies have shown here, similarly from Dr. Bedou here, that once over 50% of the protein is from plant-based, then the ESRD, the CKD mortality goes down. So with all these plant dominant and this great name that has become quite hot, Play-Doh, the question is what to do and what to recommend. I'm going to end my presentation with one slide, which is pure opinion. People come and tell me, Dr. Calta, I have just one kidney. I donate my kidney. I have kidney cancer. What should I do or eat? Should I just live normal life? I say, yes, live normal life, but please don't go to Brazilian restaurants. Don't go to those dietitians or surgeons who tell you eat a lot of protein to lose weight. Don't do that. avoid more than 1 gram per kilogram per day of protein, and also keep your BMI low, exercise, and do a lot of great things, avoid hypertension, so that you donated kidneys, you should live as long as possible. What about transplanted patients? This is where we need studies. We need randomized studies. Could be done very easily. We need proof of concept studies, but some data have shown that plant-based diet and low protein diet helps with longevity of transplanted kidneys. Now, this is the essentially what KDOKI and ISRNM, International Urinary Metabolism, recommended, 0.55, 0.6, 0.6 to 0.8, pretty much for everybody, 0.8 to 1 for those who have 1 kidney, and below 0.6, which is very low protein diet, maybe for CKD 4 and 5 in the era of value-based models, and high protein diet for dialysis patient. As you can see here, this is the ultimate precision medicine, not one size fits all. And we are working on the project World Kidney Recipes through the International Federation of Kidney Foundations. And also one of our R1 grants is about those choices, including nutritional management in the era of value-based models. And look at this statement: when diet is wrong, medicine of no use. So some 5,000 years ago, no disease that can be treated by diet should be treated by any other means. So in summary, obesity paradox in dialysis patients has been shown consistently. It probably has biological plausibility. High protein diet is recommended to dialysis patients. For non-dialysis patients, CKD, nutritional management was important, is important, it's becoming even more important. Low protein diet is 0.6 to 0.8, and at least half of it, if not most of it, should be plant-based protein. Data are not enough. We need data. A lot of things are based on old data. Plants dominant is more than 50% being plant proteins, fruits and vegetables. Hyperkalemia has been overrated. And together, hopefully we work together to come up with the best precision medicine and precision nutrition for these patients. I'd like to acknowledge colleagues here, and thank you very much for allowing me from France, Paris, France, to be connected. Thank you.
Thank you so much. I'm sorry we kept you from the Eiffel Tower, but hopefully you'll be able to make your way over there for a little while.
All right, I guess colleagues are worried that I can make it to running around in Paris. I'm going to catch up tomorrow morning before my flights, so I'll do that.
Well, have a great flight, safe travels, and thank you again.
Thank you. Bye-bye.
Bye-bye. So we are a little behind. We are supposed to have a break at 11:30. So I'm going to suggest we take a 5-minute break. For those of us that need a little bit of a bio break, the bathrooms are down to the left. And we will make sure that the PowerPoints and recordings are available on the website probably by Monday. And so I'll see you back here in 5 minutes. Okay, hi everyone. I know not everyone has come back yet, but we do want to get started. I think given the delays, what we'll do, we'll go through 1:30? No, 12:45. I apologize. Where am I? Are we in Philly tonight right now? I don't know where I am. Okay, so we'll have a regular 45 minutes panel, and then we will take a shorter lunch at half hour. And it's my pleasure now to introduce Dr. Rohit Sones. He directs the bariatric surgery program here at Temple University and will be moderating this panel.
All right. Hi, everyone. It's like really so good to see everybody in person for this conference. And obviously the hybrid model is great. So thanks to everybody on Zoom who's joining us. This is really kind of like an exciting kind of topic, and I'm so glad to have such esteemed speakers kind of like speaking about this. And really, it's one of those options that, from a bariatric perspective, a bariatric surgeon's perspective, it's a complicated kind of scenario. As you know, bariatric surgery works in like really fine margins in terms of complications and things of that nature. So in general, this patient population, I feel like is like nationally maybe a little neglected from terms of bariatric surgery and bariatric care. So this topic I think is extremely important. And I think that we have a great set in this panel to kind of help address some of the concerns and help kind of inform us about what this is. So without further ado, I'd like to kind of like introduce our first speaker, who's Dr. Marianne Lim. She's assistant professor of clinical medicine at University of Penn Perelman School of Medicine. She's also the co-lead for the clinical implementation team of the Penn Transplant Institute of Strategic Planning. So I think she is going to be an excellent speaker to tell us about the effectiveness and safety of non-surgical and surgical weight loss in kidney transplantation candidates. So Dr. Lim, you have the field. Can you share your?
Yes, thank you very much for that very nice introduction. And let me see, am I sharing?
Not yet.
Do you see my slides now? It says I'm screen sharing.
Yes, we can see your slides.
Okay,
thank you.
Great. Thank you very much again for that introduction. And thank you for everyone who stayed on for this part of the symposium. I am honored to be a speaker alongside all these great speakers today. And a special thanks to the organizers of this symposium for inviting me. So in the next 10 minutes, I'm tasked to provide to you evidence for the safety and efficacy of non-surgical and surgical weight loss strategies for our obese kidney transplant candidates. So I have nothing to disclose. Again, the goal is to discuss weight loss strategies, specifically focusing on available evidence on the safety and efficacy of these strategies as it pertains to getting patients to waitlist and transplantation. So as far as non-surgical strategies are concerned, divided into non-pharmacologic and pharmacologic. A lot of the non-pharmacologic strategies, including behavioral changes, dietary changes, and exercise, we've discussed in the last part. Some of the things that weren't discussed are behavioral changes and exercise. And as far as these non-pharmacologic strategies are involved, we know that it's challenging enough for non-kidney patients. It's much more challenging for kidney patients, as Dr. Harhe discussed earlier, because we have to work within the limits of renal diet, work within the limits of the time they spent on dialysis, and their limited exercise tolerance due to coexisting conditions, whether it's anemia or post-dialysis fatigue and other comorbidities. And a lot of times it really involves a multidisciplinary group of people to help our patients with that. Not just dietitians, not just the providers, but also maybe a physiotherapist, maybe pharmacists, and maybe people to get them the healthy food that they need. And this is not always readily available to our patients. Dialysis patients might actually get a little bit more support within the dialysis unit, but for our patients who are pre-dialysis, this really becomes challenging. And then just a side note about medications, this really needs to be looked at because there are certain medications that promote weight gain. And in telling our patients to lose weight, we really should focus on medications that will not make them gain weight. And if there's any chance to shift them away from these medications, we should. Now, moving on to pharmacologic agents. So as the prior speakers noted earlier, there's very few pharmacologic agents that are studied in advanced CKD and end-stage kidney disease. So let's take a look at what's available. So this is an older study, but it's actually one of the fewer studies that's been done that looked at getting patients to waitlist and transplant. It looked at orlistat, which as we all know is a lipase inhibitor, and it promotes weight loss. They actually did a 6-month intensive intervention and followed the patients for 18 more months. But they had a multidisciplinary team, including a renal dietitian, an exercise physiotherapist, the nephrologist, some support from transplant coordinators, and the pharmacist. And what they really focus on is not just the drug itself, but low-fat, calorie-reduced renal diet, regular exercise, and behavioral therapy. It's a small study. They had 44 patients in the treatment group, and the 20 patients who did not want to be included became their controls. Only 32 of the 44 patients completed the intervention. Nevertheless, we found that orlistat was safe in this group of patients. There was no evidence of hyperoxalosis or more rapid decline in GFR, and no patients withdrew because of the adverse effect. However, they did see that a majority did not achieve target weight. There was a 5 to 6 kilogram weight loss within the first 6 months that persisted. And in at least this group of people, they found that a third of the patients were able to achieve enough weight loss to be activated to the wait list. This is compared to the 6% who were in the control group. What about other agents? So whether these results can be replicated on a wider scale, we don't know, because of course, this intervention was a 24-month intervention, and it involved multidisciplinary care providers, which won't necessarily be available to a lot of our patients. So what about other agents? So one promising group of agents is the GLP-1 agonist. As far as safety is concerned, if you look at the product insert, it'll say use with caution in patients with CKD stage 4 or GFR less than 30. But it has been a randomized controlled trial, small trial involving 20 end-stage kidney disease patients and 20 control patients with type 2 diabetes who were given liraglutide and placebo. What they found was that in patients with end-stage kidney disease, their liraglutide concentration tended to be higher compared to patients without kidney disease. However, there was no indication of a progressive accumulation of the liraglutide. They also noted that nausea and vomiting were more common, but it was transient. And over the 12-week period, they noted a weight drop of 2.4 in the kidney disease group and 2.9 in the control group. So modest, but did have weight loss. So they said that the study did not have adequate power for conclusions, but this was their outcomes. In a larger multi-center randomized controlled trial that primarily looked at cardiovascular outcomes, they looked at pre-specified secondary analysis looking at patients with kidney disease. And in this 9,000 participant trial, there were about 200 patients with CKD stage 4. And what they found was that in those patients with kidney disease, the rate of adverse kidney events were not actually that different for those patients who were given liraglutide versus placebo. And moreover, they found that the benefits of liraglutide as far as proteinuria and decline in GFR is concerned was similar compared to the whole group. So suggesting that perhaps not only is it safe, it might actually still offer kidney benefits even in advanced kidney disease patients. There hasn't been any trial though looking at this agent as far as getting patients to waitlist or transplantation. Having said that, there is an ongoing trial that started enrolling in June of last year. They are targeting 150 participants according to what's listed on clinicaltrials.gov. And what they're trying to do is to see if lifestyle counseling, in addition to semaglutide, will get patients who are obese and needing transplant to waitlist or transplantation. So this will be interesting to follow and to see the results of the study. So basically that's it as far as what I've found on non-surgical strategies in getting patients to waitlist or transplant. So what about surgical strategies? Let's take a look first at the safety data. So as far as safety data is concerned, the study looked at the NESQIP data of more than 300,000 patients without CKD and more than 2,000 patients with CKD who underwent bariatric surgery between 2015 to 2016. And what they found was that as far as 30-day reoperation and readmission rate, patients with CKD and end-stage kidney disease were at higher risk. As far as mortality risk, the patients with end-stage kidney disease also were at higher risk. However, when they looked at rates of adverse outcomes overall across all age groups, they're all very, very low. So what they've concluded is that as far as CKD and kidney disease patients, they may have higher risk of surgery complications, but since the absolute numbers were low, this CKD and end-stage kidney disease should not be perceived as a contraindication to bariatric surgery. Another paper that looked at sort of the trends in bariatric surgery over the last decade is this paper by Sheets that looked at Medicare claims database. And it's over 200,000 non-end-stage kidney disease patients and over 2,000 patients with end-stage kidney disease. And what they found was over the 10-year period of 2006 to 2016, the use of bariatric surgery in patients with end-stage kidney disease has increased ninefold. And whereas in the early 2000, laparoscopic sleeve gastrectomy comprised less than 1% of patients who underwent bariatric surgery, in the later years, it was the main type of bariatric surgery that was performed in patients. As far as outcomes go, they found that the readmission rates and length of stay were higher. However, the complication rates were actually similar. And so again, they concluded that patients with end-stage kidney disease should not be seen as a contraindication for bariatric surgery. What about effectiveness to getting patients to waitlist or transplant? So I will say that the data that we have are limited by small numbers. There's a lot of papers that are out there. I sort of like picked out the ones that have an N of 20 or higher. All of these are single center prospectively collected data that they've looked at retrospectively. So you'll see that the largest number of patients comes from the Cincinnati group, and it was 52 patients when they published their data in 2015, and more than 240 when they published this data in 2020. You'll see that the patient population consisted of dialysis patients and patients not yet on dialysis, but were considered transplant candidates. And as far as surgery is concerned, most of this utilized laparoscopic sleeve gastrectomy. And not discounting what we've talked about the limitations of BMI, but this is what is published and what's being used. You'll see that the pre-op and post-op BMI of these patients really significantly declined. And as far as what we're trying to look at is, did the procedure get these patients to waitlist and transplant? And you'll see that this is the number of patients who are then waitlisted and transplanted compared to the number of patients, the initial N that was there. And you'll see that a lot of patients are actually successfully waitlisted and transplanted. So I won't go into detail because of the limitations of time, but in summary, there's very few studies that really are looking at non-surgical weight loss strategies. And I know that this is probably something that's of interest to everyone. And so this is something that really needs to be done. As far as pharmacologic agents, GLP-1 agonists looks promising. Maybe they're safe. The data is very limited because they're small numbers. So we need more studies looking at larger group of patients and looking at how effective this is. As far as bariatric surgery is concerned, the studies again are limited by a lack of prospective randomized controlled studies. But what we have with the claims and registry data, they show that complication rates might be higher, but the absolute numbers are small. And so they're effective, as we can see, based on the small studies that we have. Considering the mortality benefit of transplant to our patients, I think surgical weight loss strategies should be offered to all appropriate transplant candidates. And with that, I end. Thank you very much. And if there are any questions.
Thank you, Dr. Lim. That was excellent. At this time, we're going to just kind of move on to the next panelist, so all of the panelists have enough time. We'll take questions at the end. We'll take questions from both the audience and from the Zoomosphere. So at this time, I'd like to kind of introduce Dr. Christophe Dumont. He is an associate professor of surgery at the University of Pennsylvania Perelman School of Medicine. He is going to talk to us about Roux-en-Y gastric bypass for renal patients. This is an exciting topic just because the choice of operation is really a big deal to our patients. And, you know, we have data on the metabolic effects of the gastric bypass, and I think this is going to be an excellent conversation to have from a bariatric standpoint. So thank you, Dr. Drummond. Do you have the ability to share the screen at this point?
Can you see my slides?
No, sir, we do not have that yet.
1 second. Can you see it now?
Yes, perfect. Thank you.
So first of all, thank you for allowing me to participate in this amazing conference. I would congratulate your institution, Temple, who really is our conscience in the city of Philadelphia in bringing out very important population-based elements to the public. So my topic is going to be trying to focus on bariatric surgery and the gateway to kidney transplantation. So the topic here is really bariatric surgery as a treatment modality for obesity is well known, but we also know that severe obesity is a true barrier to kidney transplantation. And I want to present to you a little bit the evidence we have now of the safety and effectiveness of bariatric surgery before and after kidney transplantation. So the concept of bariatric surgery as a treatment option in the general population is well described. 1/3 of the US population has a BMI of greater than 30. This is a major public health issue, and the effect of obesity on diabetes, hypertension, end-stage renal disease is very well described. In the general population, 5 to 7% of total weight loss can be achieved with diet and exercise. Medication can lead to 7 to 10% of excess weight loss, and surgery can allow 20 to 35% of total weight loss. The two most common procedures that we perform at our institution are sleeve gastrectomy and gastric bypass. Gastric bypass has a malabsorptive aspect in addition to a restrictive aspect. Sleeve gastrectomy, you remove the left side of the stomach, so it's more of a restrictive process. I want to emphasize that both procedures have a very strong metabolic impact. Very large studies are now available that really show over longer time periods the effect of gastric bypass, sleeve gastrectomy, and diet and exercise. And they kind of confirm these findings that you can really achieve about 25 to 35% weight loss with bypass, 20 to 25% weight loss with sleeve, and about 5% weight loss with diet only. If you look at larger population studies, outcomes of the MBS-ACRIP, we see that since 2011, there's been a dramatic increase in sleeve gastrectomies as the primary bariatric procedures. To date, in the United States, about 150,000 sleeve gastrectomies are performed, and gastric bypasses to date are reduced to less than 50,000. The evidence for that is a significant reduction in overall morbidity and mortality with sleeve compared to gastric bypass, with a very similar reduction in comorbid conditions such as sleep apnea and diabetes. The main point is that regardless of the surgical procedure, long studies such as the initial SOS studies published 2013 by Shestrom et al. At New England Journal of Medicine and confirmed with follow-up studies show a clear survival benefit in the obese surgery population compared to the control. Similar to the general population, there's been a drastic increase in obesity in the pre-transplant and post-transplant and chronic kidney disease patient population. About 1/3 of the current population in the United States is obese in this patient population group. Of the 750,000 patients on the transplant list, 1/3 is obese, defined as a BMI greater than 35. In contrast, transplant recipients, only 12% of transplant recipients to date have a BMI greater than 35%. We talked before about the hesitance of transplant surgeons in performing surgery in higher BMI classes. Most centers have a BMI cutoff relative of 38 and an absolute BMI cutoff of 41. The reasons for that are increased wound infections, delayed graft function, graft failure, cardiac disease, increased length of stay, and cost in higher BMI classes. In contrast, we know that patients that are obese and would be transplant recipients would see lower long-term mortality, lower cardiovascular risk, and an increase in potentially increase of survival. But this increase of survival is not seen in subclasses with BMI greater than 40, which again is the reason to limit transplant in these higher BMI classes. So in a way, there is a joint responsibility between patients and managing clinicians in understanding weight and how healthy weight management can improve patients' access to transplant. Because of this problem, we looked within our program at Markov modeling, just potential risk stratification based on available data, because we knew that patients who are prevented from getting on the dialysis list have an increased mortality than patients who potentially would go on the dialysis list. So we created a decision analysis model where we pushed hypothetical patients through either diet and exercise or gastric bypass. And what this model shows is that over time, as patients go from a high BMI to a low BMI, their transplant rates increases and their mortality improves. So in this hypothetical model, once a patient reached a BMI of 40, there's a clear survival benefit of patients who undergo gastric bypass versus patients who are diet and exercise for 1 or 2 years. So because of that modeling at our institution, we worked then at looking at the real outcomes of real patients. And I will try to show you our findings regarding weight loss, allograft function, mortality, and morbidity and survival benefit. So in a first study, which was published by Dr. Cohen, and Dr. Lim was very involved in this study, we looked at 43 patients before transplant and 21 patients after transplant who underwent bariatric surgery. So 63% gastric bypass, 21% sleeve gastrectomy, 14% adjustable gastric banding in the pre-transplant, and 28% gastric bypass, 48% sleeve, and 19% in the post-transplant group. It's clear that in both patient groups, we achieved weight loss very similar to what we see in the general patient population. As Dr. Lim alluded to before, there was a clear benefit to allograft function and mortality, both in the pre-transplant and in the post-transplant group. in a larger study based on population-based studies from the MBSA CRIP, which includes more than 400,000 patients. We looked at patients' outcomes with chronic kidney disease and end-stage kidney disease in this population group. So most patients with chronic kidney disease and end-stage kidney disease are not comparable to the general patient population. Hypertension, diabetes, hyperlipidemia, and obstructive sleep apnea are much higher in these patients than in the general population who undergo bariatric surgery. The predominant surgical procedure in these patients was sleeve gastrectomy. If we look at the mortality, reoperation, intervention, and readmission, the mortality in the chronic kidney disease group was 0.4%, and the mortality in the patients with end-stage kidney disease was 1.4%. Reoperation, intervention, and readmission were also higher. So if you look at these data, you can say that patients with end-stage kidney disease have a higher mortality and reoperation risks compared to chronic kidney disease and no kidney disease patients. If you put these data in context of the expected mortality, the expected mortality for the chronic kidney disease patients was higher than in the operated patients. So the natural cause of death in patients without surgery was higher than in patients with surgery. Similar, in patients with end-stage kidney disease, the observed mortality was lower or comparable to the expected mortality, specifically to the end-stage kidney disease patients. If we look at bariatric surgery and compare it to elective surgery, the mortality of bariatric surgery was far less than mortality of elective surgery in this patient population. And I want to allude you to a recent publication of Sheets et al., JAMA Surgery 2020. As Dr. Lim alluded to in a previous talk, they looked at access to bariatric surgery in this patient population, which has increased ninefold. But this is, to my knowledge, the first study that really shows a significant increase in survival in patients receiving bariatric surgery prior to kidney transplant. So in summary, I think bariatric surgery in patients with chronic kidney disease and end-stage regional end-stage renal disease is safe. It reduces weight, it reduces obesity-related comorbidities, increases access to kidney transplantation, and increases survival. In the post-transplant bariatric surgery population, it leads to better graft survival and function, higher rates of postoperative complications, but potentially increased survival based on limited studies. So there is no consensus regarding the optimal timing and the ideal type of bariatric surgery. Sleeve gastrectomy is associated with a reduced risk of postoperative complications. Bypass provides survival benefit in Markov modeling, but has never been shown to show any benefits compared to sleeves in real patient data. So future studies are needed to look at the impact of bariatric surgery in the long-term reduction of cardiovascular complications and in the management of post-transplant diabetes in the obese patients. Thank you so much.
Excellent. Thank you. Thanks so much, sir. Appreciate it. Our last speaker is Dr. Tariq from Houston Methodist. He is going to be talking to us about bariatric surgery more from like an outcomes perspective, which I think will be really an important thing because, as you know, one of the biggest barriers of kind of recommending bariatric surgery is just to kind of have a discussion about like some of the outcomes and potential risks and benefits of the treatment modality. So I'm hoping that his talk will elucidate a little bit of that and demystify it a little bit for everybody. And certainly, as I mentioned, please keep sending in your questions through the chat, and we'll get to the audience questions right after this talk. Thank you. Are you able to share? Okay. Are you having any trouble? Sure. Oh. Should we do that then, or is he back? Okay.
Sorry, I have some technical issues. Let me try to share my screen.
Yep, we can see it. Excellent. Thank you.
Oh, sorry about that, everyone. Thank you for inviting me, and I'm excited to be here in this very relevant topic to all of us who are in this field. I'll try to touch upon some of the studies that have already been mentioned and some additional ones and raise some questions here. We'll get right to it. As most of this audience knows, anywhere from 95 to 100,000 patients are waitlisted on the kidney, and like Dr. Duman mentioned, about 14,000 of them are BMI 35 to 50. And I won't belabor this. Facts have been mentioned already. The concern about increased body mass index and renal transplant recipients, and that's already been mentioned. Part of this in the decision-making process, the concern about the complication risks, where some of these studies, this one's from 2017, where the mortality rate, 1-year mortality rate mentioned as 4%, major complications as 4.3%, and they have some concerns about bariatric surgery before kidney transplantation, while sort of giving a green light to after kidney transplantation. And yes, those, as mentioned, those mortality rates and complication rates are there, but how do they compare to patients in general? The perioperative mortality, which can be in this paper about 0.8%, but as we'll see in subsequent papers, is even lower. And the 1-year mortality of bariatric surgery patients of 3.9% before kidney transplant and 2.5% after, how does it compare? Well, 1-year mortality rate maybe 7% on the wait list and 3% after transplant. So taking that into comparison, it's actually better, even though the baseline may be higher. Looking at our experience with this, again, as mentioned, most of the studies are sleeve-heavy studies. I think like Dr. Dumon's group, ours is actually gastric bypass heavy compared to being a sleeve heavy series. And what the patient characteristics for our patients were similar in terms of the usual patients of hypertension, 65%, diabetes, 50%, etc. Again, the 30-day readmission, 5% is a little bit higher than normal. The transfusion rate of 5% is a bit higher than normal, with normally being in the 2 to 3% range or less. The reoperation rate was 5%, but I think we've done at least almost a similar number of 20, 30 more patients subsequently, and without a reoperation, that rate being down to probably 2.5, 3% now. But one of the reoperations was for an unusual problem we don't think related to an early recurrence of a hiatal hernia in a sleeve patient with nausea, vomiting. But blood bleeding is a risk after renal patients. And as we'll see in some of the risk models, that's always a concern, though a low concern. Our average BMI was around 44, and our 1 year patient basically weight loss meeting target BMI of 35 or less was 75%, with 33 of the 38 follow-up. And at 2 years, it was about 70% with 12 of the 17 still meeting that BMI. So depending on where they started and how much time there is, they're settling in that range. Can we get 100% of them below target BMI? That's unclear. With need longer term follow-up with that. In that shorter term follow-up, we had about 11% had been transplanted already, and several more have been done since actually that publication. But how do we balance this with the paradox that has been mentioned? The beneficial effects of bariatric surgery, but do you lose some lean body mass and get more sarcopenic with surgery? You do lose fat, but you lose some lean body mass too. There's benefit of transplant, but how do we reconcile that with the obesity paradox? Diving into the study mentioned by Dr. Tuman, Dr. Sheets from the Michigan group about from the US renal data system, and then them matching the controls 3 to 1 and looking at primary outcome of their 5-year all-cause mortality. So about 1,600 surgery patients compared to 4,700 controls. Sleeve bypass around the equal number and form the majority, 45, 41%, median follow-up of 3 years. So all-cause mortality about 25% in the surgery group, about 40% in the control group. And this was significant. When kidney transplants were excluded, because that may have mortality benefit, just surgery and end-stage renal disease, there was still a significant benefit, 31% versus 44% in the controls. About 33% were transplanted in the surgery group and 20% in the control group. So what I wanted to emphasize here is these graphs are already shown by Dr. Duman, but in this table, if we look at it, this does raise some interesting questions in this study. And this is one of the largest studies we have, this database that's comparing longitudinally bariatric surgery patients to renal dialysis patients who did not have surgery, and they try to, with matched controls. So if we look at the hazard ratios for the BMI of 35 to 39 group, right? This would be arguably the controversial one. Do they get too much weight? Where does obesity paradox come into play here if these people get operated on? If you look at the 1 year, clearly there's an increased risk of mortality with surgery. If you look at the 3 year and the 5 year, the confidence intervals span either side of one. And so arguably in that BMI range, according to this study, there is of limited, if any, benefit of bariatric surgery. Certainly in the BMI 40 to 45 and above, there's seems to be clear benefit. The first year, yes, there's an uptake in mortality, understandably through some early surgical complications, even though they'll be low. But this is interesting. The other interesting factor is if you compare the procedures, the sleeve versus gastric bypass. If you look at the confidence intervals here with the sleeve, whether it's at a 3 year, 5 year, or 7 year, once we exclude the first year, which we know there is a slight increase in mortality in the surgical arm, there's significant benefit with about half the mortality in the sleeve arm. But if you look at the gastric bypass confidence intervals, it's not as reassuring with, yes, increased mortality in the first year, but also in the no difference in the 3rd or 5th year. By 7th year, the confidence intervals are below 1, and there may be some benefit to bypass. So I think these are areas, some clues to what to study more of. This recent publication in Annals of Surgery, just very recently, a few months ago, from the Kaiser Permanente system, comparing pre-dialysis patients, not CKD 3 to 5. So a similar study with 800 surgery patients with matched controls, median follow-up of 3 years. Again, a significant mortality benefit of surgery, 3.6% versus 9.8%. However, a slight uptick in those progressing to end-stage renal disease, with 2.9% in the surgery arm and 1.5% in the control arm. That is interesting. Of course, not surprisingly, the BMI greater than 50 undergoing surgery had the highest benefit. This is just a Kaplan-Meier for the mortality benefit, clearly showing the surgery arm benefit, but this is the end-stage renal disease. So in the first 3 years, so most of the reported data for bariatric surgery improving CKD, improvements in CKD parameters have been sort of 3-year studies. This is a study with longer follow-up. And so up till 3-year mark, 1,000 days or 1,200 days, yes, surgery shows benefit, but in this cohort with the matched controls, actually beyond 1,500 days or so, there's a worsening of end-stage renal disease in the surgical arm. This is now, they do say as they go further, the number of events decreases, so it may not be adequately powered for that, but and the total number of events is 14 progressing to renal failure once beyond 2,000 days. So, but it is interesting. In their initial one-to-one match controls, the difference between the two arms, between those progressing to renal failure and in the control and surgical arm, were not different, 3.2 versus 3.1%, but the mortality was significantly different. This study has been, I think, already mentioned, another large database study. This is just to, again, emphasize, compared to 400,000 regular patients, to 1,244 with end-stage renal disease from the database for 30-day perioperative outcomes. The reoperation rate is 3 times higher in relative terms, but in absolute terms, it's still 3%. Transfusion rate is double in relative terms, but it's still only 1.5% compared to 0.7. Similarly for sepsis. So I think the main issue, the main reassuring thing is, in absolute terms, the complication rates are still very acceptable and probably not too different, especially in sleeve patients, from these patients undergoing laparoscopic cholecystectomy or other common general surgical procedures. So this study is from Temple, actually, again, on the MBSA-QIP database. Again, this was from a few years ago, but similar results mentioned, both in terms of relative reoperation and readmission rates being higher in the CKD population, but overall in absolute terms, not that significant. And to wrap up, I just wanted to tell you how we practically currently maybe involve this decision-making tool. This is our MBSA-QIP, our Metabolic Bariatric Surgery Quality Improvement Project Risk Calculator from the American College of Surgeons. It has parameters for dialysis, cardiac disease, and if they've had PCI, if they've had a PE, and other basic parameters like diabetes, hypertension, smoking, functional status. And so, and this is, it has data on hundreds of thousands of patients. So if we put a typical, this is data for a 30-day perioperative risk for someone, a 52-year-old female with a BMI of 48, with hypertension, insulin-dependent diabetes, hyperlipidemia, and on dialysis. So if we compare this to, if I put this data in and we compare this to someone without dialysis, but the exact same characteristics. So if we look at the bleed rate, 1.6%. If you look at the sleeve and bypass, you can ignore the biliopancreatic diversion duodenal switch. That is a more complicated procedure. And the reoperation rate of 2.2% versus 0.8%. And this is the same characteristics based on hundreds of thousands of patients, hundreds of thousands of non-dialysis patients at this time, without HD, but same characteristics. Yes, everything's about 0.5 to 1% lower, and in some cases only 0.2 to 0.3% lower. So in relative terms, yes, 30 to 40% higher, 50% higher complication rate, but in absolute terms, again, 0.5%, 1% higher risk. And mortality risk, as you can see on the very first column, 0.13%, 0.18%, 0.3% for bypass. So minor differences there in the HD population. And it also gives us the weight loss with HD or without HD. This is just a predicted weight loss. 76 pounds for the sleeve, 91 for the bypass in the first year, 75 and 90. So similar, whether you're on hemodialysis or not, if you're otherwise a diabetic, etc., without chronic kidney failure. And similar comorbidity resolution, same thing. The predicted, whether if it's a sleeve or a bypass, your total diabetes resolution is 50% with a bypass, 35% with a sleeve, with obviously significant improvement, and 33% with a sleeve, 45% with a bypass. So very similar results in terms of efficacy, with some increased risk, but in absolute terms, I think a fairly acceptable risk. So basically, the combo of obesity and renal failure is significantly increases. And the good part is all the dialysis patients are covered by Medicare, and Medicare covers bariatric surgery without an issue. So they all have coverage. The outcomes after surgery, of course, still need to be further defined. We don't have randomized studies. These are mostly small studies or database studies. And there are a lot of questions. What's the BMI range? What's the comorbidities? What's the optimal procedure? If it's a bypassed limb length, what about oxalate nephropathy, the timing, etc. So these are all questions that we have to answer. Thank you. Sorry if I went a little bit over time.
No, you did excellent. That was like great timing, actually. So thank you so much. At this time, just to open it up for questions from all three panelists. I have a few questions on Zoom that we can ask, but anybody in the audience that have any questions for the three panelists? All right, I'll just cut to the questions from Zoom then to start. The first question is for Dr. Lim. Really, the question was regarding like the Orlistat study, but it can kind of like be a little bit more generalized as well. Weight gain after being activated on the wait list. Did people maintain the weight loss from what you can tell, or because the wait list is so long and people are there for many years, did they see weight regain again?
Great question. So as far as the Orlistat study, they actually had like a 6-month intensive trial, and then 18 months or of less intensive, but they still followed the patient. So within that time frame, 5 to 6 kilograms in the 6 months, and then sustained to like 8.4 was the median weight loss at 2 years. But after that, I think they stopped following. It's a very expensive study to do, is multidisciplinary. So I don't think they like had any more publications after that, actually. As far as other studies are concerned, I know that the Diwan study, they looked at that. And so they published in the 2015 and they published again in 2020. So a lot of those patients actually had sustained weight loss for them to like still be on the wait list and then later on qualify for transplant.
Excellent, thank you. Thanks for the response. The next question is for Dr. Dumont. In terms of muscle loss and sarcopenic obesity that develops kind of like after bariatric surgery, the question was regarding like the timing of transplant. How long should one usually wait after bariatric surgery, but before transplant surgery?
That's a great question. So typically, the aim of bariatric surgery is basically reaching transplant candidacy, being waitlisted. Most weight loss happens within 18 months of surgery, so that's 1.5 years. You can divide it up in 3 blocks. I would say most of the weight loss is in the first 6 months. It slows down a little bit over the next 6 months, slows down over the next 6 months. So typically it's between 6 and 12 months that patients become eligible for transplant.
Excellent, thank you. And then I guess, Dr. Tark, just a follow-up question regarding what you were talking about, oxalate nephropathy. Should that play a role in terms of decision-making between like gastric bypass and sleeve, or some of the rates that you mentioned? Does that kind of like point us in one direction or the other regarding which operation we should choose for this particular population? Or are there other factors that come into play when discussing? I saw that your program was like bypass heavy. Is there a reason why potentially that was the case, or how you guys were moving in that direction?
No, I think the short answer is we don't know, but what the optimal procedure is, just as I showed, is maybe gastric bypass in data-wise is not as beneficial in terms of mortality, but maybe in terms of getting them to transplant. So as far as the nephropathy, oxalate nephropathy questions, no, that doesn't generally enter our mind because like I said, until that last sheet study came out with the longer term data, general thought was even bypass patients, it improves CKD parameters that when you follow. And it's only in this study after the 3 or 4 years, there's some concern does the progression to ESRD increase. And they don't, in that paper, they don't know what the mechanism for that is. I suppose that could be one aspect, oxalate nephropathy, but in our case, we just choose what based on the standard criteria. Basically, for some of the cardiac patients that we do on LVADs, etc., we're really trying to minimize risk for their transplant, and so in them we do preferentially choose a sleeve. Some of the liver transplant ones because of access to the biliary tract, but in renal patients, we just go pretty much use our regular criteria. If they have significant reflux, if maybe diabetes control needs to be extra strong or something, and they've not been diabetic that long. So it's the usual criteria for the renal patients.
Yeah, that's been our experience here at Temple as well. I mean, really, we try to, with the renal disease patients, we seem to be wanting to treat the metabolic syndrome, and sometimes the bypass just gives us that little extra. And this next question is really for all three panelists. So whoever kind of thinks that, whoever wants to answer, I think it's a really important question. In terms of patients that are, a PD, the peritoneal dialysis patients, are there any special considerations for this patient population in terms of discussing bariatric surgery?
I would, PD patient, I would be very reluctant to perform a gastric bypass. I also think that, as Dr. Tariq said, I was trying to highlight in my presentation is that since 2011, there's been a dramatic increase in sleeves over the entire United States. And so I think in a PD patient, that would be my preference. I'd like to hear Dr. Tariq's opinion on this as well.
I agree with that as well, that unless, so my experience, so first of all, even from the data, there are very few PD patients, so we don't have much to go on from there. But just in our experience, usually with the sleeve patients, we've been able to salvage the PD catheter. With a bypass, there is reluctance in some patients. Like we've had a patient who had, like, for example, significant reflux in Barrett's esophagus, and sleeves a contraindication, and in which case we do a bypass knowing that they may lose their PD, but temporarily, potentially only. So that's what we do. We stop PD, or we take the PD catheter out even, and then it can always be reinserted later if so desired. But in general, yes, in the algorithm for peritoneal dialysis patients, our preference is sleeve as well.
Excellent. And then I think there's one last question on the Zoomosphere in terms of like BMI cutoff. Is there a particular BMI where bariatric surgery would be like highly recommended? I know like we had discussed that a BMI of over 41 is usually a contraindication to transplant. So as a bridge to transplant, is there a particular BMI or a particular set of comorbidities that you guys see that would make a patient a better candidate for bariatric surgery, or versus just straight to transplant?
mean, I guess I'll take a quick initial shot at it, but I mean, some of it's obviously transplant center related, and where the obesity is, there are transplant centers which will consider a BMI of 38, 40 if there's not a lot of central obesity, and but the main my thing is, if your patient is renal failure and they have a BMI of over 45 and certainly over 50, what evidence is there, if any, that your medical management is going to bring them down? Next to zero evidence. And so you're really, I think it's a disservice to that patient to try excessively long medical, sorry if I'm being a little surgeon and here, but it is just, a BMI 50, 55 patient with renal failure. Just yesterday, I did a BMI 70 with renal failure who's been on dialysis for years. And I'm like, what were they thinking with a BMI of 70 on dialysis? Is he going to lose weight? Yes, try losing weight yourself. And there will be a rare patient who will be able to, but the majority can't. And this is the most surefire way of that way. Now, the BMI 35 to 40, that's debatable.
Oh, excellent response. Any other questions? I see a hand raised in the back. So I'll repeat the question so that everyone can hear, both on Zoom and the panelists. The question was really, again, regarding like special considerations post-bariatric surgery in the end-stage renal disease population, whether there should be anything specific or special in terms of nutritional labs or potentially like nutritional education that needs to be provided to a post-bariatric patient that has end-stage renal disease. And also supplements, I guess.
Can I answer that?
Yeah, absolutely.
So I think this is an area where we need more research. I think this is an area that, like, I learned a lot from this conference. I learned a lot from interacting with Dr. Lim and her colleagues here at Penn, understanding this patient population better. I think Dr. Tariq may have a similar experience, that as clinicians, we are very focused on surgical outcomes, but really understanding long-term nutritional deficiencies and nutritional needs in these patients, as I think is still lacking. So I think that's where we need input from nephrologists and dietitians to help us guide, because I think the honest answer, we barely know the weight category for these patients that benefit from surgery. And it would be really beneficial to understand a combination of surgery with long-term diet outcomes.
I would echo those sentiments. We really don't understand. And even to the point what's earlier been made in the conference regarding sarcopenia, high protein diet, low protein diet, to some extent, I'm actually of the surgical camp that you don't have to have a super high protein diet. In fact, sometimes when we overemphasize the protein and minimize the carbohydrate, they get more sarcopenia. So everyone gets some sarcopenia from bariatric surgery. No one loses 100% of their weight in fat. But how much of we don't even have good data post bariatric surgery based on a body composition. It's a very small series of how much and which patients lose more lean body mass, because those are the ones that will plateau out earlier. Even in our study, and I think that's mimicked, where maybe 20%, if your average BMI is 44, 45, maybe 20% of them will never get to a BMI of 35. Why is that? Why are they stalling early? Yes, lifestyle matters, etc. But some of them is they plateau out too quickly. Their metabolism does go down as they lose weight and lose their muscle, and they reach plateau too early. Are we making them even more sarcopenic by overemphasizing excessive protein, minimizing carbohydrates or good carbohydrates at least, etc. So there's a lot to study in this aspect as well.
Any other questions? All right. I think that was an excellent discussion. Thank you to all of our panelists. And it seems that, as everybody has said, there's a lot to study. So I'm hoping that we can generate some really important investigative questions that hopefully we can combine our forces to study, because the numbers here are not great. So if we combine forces, we may be able to power our studies enough. Thank you all for your time. Appreciate it.
Good afternoon, everyone. I'm Dr. David Sarwer. I'm the Associate Dean for Research in the College of Public Health and also Director of the Center for Obesity Research and Education. And I have the great honor of introducing our next keynote speaker. Dr. Carel LaRue is the full professor of experimental pathology at the School of Medicine at the University College at Dublin, which means we have him working a little bit overtime on a Friday night. Dr. LaRue graduated from medical school in Pretoria, South Africa, and he completed his senior house officer training at the Barts and London Hospital, his SBR training in metabolic medicine at the Hammersmith Hospital, and his PhD at the Imperial College of London. He accepted a position as chair of head of pathology at the University College in Dublin in 2011. He received the President of Ireland Young Researcher Award from the Science Foundation of Ireland, a Clinical Scientist Award from the National Institute Health Research in the UK, and a Wellcome Trust Clinical Research Fellowship, among many other awards. A very popular lecturer and scholar, he has supervised several Masters of Science, MD, and PhD students, many of whom have gone on to successful academic careers around the world. He leads a highly successful independent research group and has published his work in numerous high-impact papers over the years and in the areas of obesity and bariatric surgery. His translational research on the understanding of the physiological role and pathological changes in appetite control and the impact of bariatric surgery on diabetes has led him to become an internationally recognized thought leader and a highly sought after invited speaker. While I've known of Dr. LaRue's work for several years, I had the great chance to see him present in person and get to know him a little bit in 2019, where we were both presenters at the International Congress of Bariatric and Metabolic Surgery in Santiago, Chile. 2019 doesn't seem so long ago in some ways, and then seems like a lifetime ago in others. This was right around the time that we began to think about planning this meeting. And very quickly, Dr. LaRue rose to the top of my list of potential keynote speakers. So I'm absolutely thrilled to have him join us today from his home. And it is my great pleasure to introduce him and have him share his expertise with all of us. Dr. LaRue.
That's very kind, and thank you for such a wonderful introduction. I just want to start with this slide. This is a famous painting that hangs in the National Gallery in London of the Victorians thinking about science. And you can see how, these concepts, of science really scared some people. You can see the young girl in the front looking away. You can see how other people, maybe the two gentlemen at the front, really being fascinated by the science, and somebody like the lady on the left really not being fussed about any of this. But I would like us to be like the little boy on the right-hand side, who's opening the window, that's shining more light on this question, this idea that 15% weight loss should now become the target for patients with obesity and chronic kidney disease. These are my conflicts of interest, and we work with lots of different companies, with pharmaceutical companies, with nutrition companies, and also with surgical companies, because we don't actually think that there is one silver bullet. We think that we need more nutritional treatment, we need more pharmacotherapy, and we certainly also need more surgical treatment. And as an internal medicine doctor and pathologist, I've been really interested in how surgery has worked, and the previous panel was excellent at highlighting the benefits of bariatric surgery. So I'm going to dive right straight into that and suggest to us that our understanding of the disease of type 2 diabetes, and certainly the disease of obesity, is certainly not at the level where we want it to be. We still think about type 2 diabetes as one disease, and many of us still think about obesity as one disease. Now, if we maybe had that conversation in the 1950s about cancer, we thought that cancer was one disease, and we talked about finding a cure for cancer. In the same way as we're now talking about finding a treatment or a cure for obesity. But I think what we see in this slide showing type 2 diabetes really represents at least 5 different clusters. And we can see that this cluster of so-called severe insulin-resistant diabetes, when we look at the left axis, this is the time to chronic kidney disease. We see that these are the patients that develop chronic kidney disease far earlier than those really at the bottom, which is the so-called morbid obesity and diabetes cohort. So everybody with diabetes, everybody with obesity are not at the same risk of developing chronic kidney disease. And therefore, we need to understand this better. And it's really been bariatric surgery, again, that's shone another light on this. And this is new data from François Petou in France and Ricardo Cohen in Brazil, where they looked at bariatric surgery impacts on different types of diabetes. And you can see using those 5 clusters, again, it's the severe insulin-resistant diabetes group, the same group that led to chronic kidney disease, that were the group that responded the best when it comes to bariatric surgery. So it is correct that we are looking for which of our surgical procedures are best for patients with diabetes, but we can also turn that question around and say which type of patients with diabetes, and especially those at risk of chronic kidney disease, may do best with our surgical procedures. And again, we are now starting to understand this idea about personalized medicine. So is it time to think differently about diabetes? Is it time to think differently about chronic kidney disease? And certainly thinking about surgery as a treatment option has allowed us great insight. Now, I will remind you, and you've seen the slide before, that there's more than 13 randomized controlled studies now. And whether or not you rank it in rising BMI rates, you could see that the outcomes, whether or not it's BMI above 35 or below 35 in randomized controlled trials, are very similar. But the problem with these trials is they were set up to test glycemia. They were not really set up to test the end organ disease of diabetes, which of course could be chronic kidney disease. So we do have level 1 evidence that surgery is better than our usual care within medicine. And this was clearly done not that long ago, but as we just heard, 2019 sounds like, a lifetime ago to many of us. And yet, you can see those studies are done in 2012, 2015, relatively recent, but again, medical progress is amazing. And we're going to come back to that in a second. I do, however, want to highlight that in this randomized controlled trial between sleeve gastrectomy, gastric bypass, and base medicine, that both the operations, sleeve and bypass, outperform base medicine, not only on metabolic control, but also on quality of life. And we should not forget that the quality of life of our patients with chronic kidney disease are very often inhibited by their functional ability. And when these patients lose more than 15% weight, they very often tell us, yes, it's wonderful that my diabetes is under control, but it is amazing that I can now put my socks and my shoes on, that I now can walk up 2 flights of stairs without being short of breath. So it's the functional domains that very often drive quality of life. And that is because the absolute amount of weight loss with these operations are typically in the order of 25%. And that is far better than what was usually achieved with maybe only 4 or 5% with best medical treatment. Now, of course, we know from the SOS study looking at more than 22-year data that bariatric surgery significantly reduces end-stage kidney disease. So we know that it's not only good for making people's quality of life better, it's not only good for making their morbidity better, but it's also good for reducing mortality. Now, we don't yet have the randomized controlled trials, but the previous speakers have eloquently outlined all the cohort studies that are very consistent and in the same direction.
So why is it? Let's take a deep dive into why does surgery do such a good job? Because then we understand this idea about 15% weight loss. What do we need to do? And what we can see in the randomized study, this is Saeed Ikramuddin's randomized controlled study between bypass and lifestyle. Yes, surgery is much better, but look at the improvements in hemoglobin A1C, changes in lipids, and also changes in blood pressure. So what are the mechanisms? Is this all weight loss dependent or is it weight loss independent? That's a big question, maybe for another day, but I would argue that that weight loss is dominant, but there's also some weight loss independent effects that we are seeing from surgery. And here's an example of urine sodium excretion that we can see in patients with gastric banding and gastric bypass. And if we look at the bottom panel and at 10 years, you can see that blood pressure improves in patients with gastric bypass, but those with banding with sometimes similar weight loss did not have the same improvements in blood pressure. But we can see that in gastric bypass, we have this increase in sodium excretion. So we can see that the gut is talking to the kidney and allowing some improvements. We also see when we look at inflammation, and especially inflammation that's measured in urine, but we can with some comfort say this reflects the inflammation that's happening in the kidney. If we look at gastric banding, gastric bypass, or sleeve gastrectomy in the upper panel on the right, you can see dramatic improvements in inflammation as measured by MCP1 over here in urine. So that is a dramatic improvement that we don't always talk about, this improvement in inflammation that we see within the kidney. So what about randomized controlled trials? And it was Ricardo Cohen that set up this randomized controlled trial of 100 patients with diabetic kidney disease. So these patients had CKD stage 2, early disease. They had GFRs that were above 60, but they had albuminuria. And you can see that these patients were randomized to either having best medical treatment or surgery plus best medical treatment. And I think that is an important point when we're going to talk about, what is the benefits of 15% weight loss. We don't have to do it only with surgery or only with medicine. We can certainly think about the combination of approaches. So just to remind you, all these patients had albuminuria, they had a BMI between 30 and 35, and they had CKD, G1 to G3 and A1 to A3. And the premise of this was built on a very old study, the so-called STENO2 study, where they showed that just by combining treatments, such as simple treatments, ACE inhibitors, statins, metformin, by combining treatments, we are more successful than these treatments on their own. So this was the idea about using surgery plus best medicine. And what you can see from the 2-year data, this is interim analysis. The 5-year data is now ready for analysis this year. But the 2-year data showed a dramatic improvement in albuminuria on the left side with surgery that you can see 86% of patients were able to achieve remission of albuminuria. But I want to focus also a moment here on the best medical treatment. When we powered this study, we powered it on the principle that surgery would be 5 times better than best medicine, because that was the best evidence that we had at the time. But of course, during the study's duration, we had GLP-1s that we heard about, we had SGLT2s that we heard about, and therefore everybody in the best medical treatment arm were either on GLP-1, SGLT2, or a combination of GLP-1 and SGLT2. And we know that these medications have dramatically changed the landscape for patients with chronic kidney disease. Now, I will point out on the right-hand side that despite us using these really excellent new medications, that surgery was still better numerically when we looked at urine albumin creatinine ratio. So surgery was still very, very good. But you can see that the gap between medicine and surgery is narrowing all the time. So let's think about the mechanisms. How can surgery improve diabetic kidney disease? And I don't have to tell this audience about the podocyte and just the role that it plays in protecting and as a protective layer within the body. And of course, with diabetes and certainly with obesity, we see a breakdown, of this protective layer and therefore leaking of albumin into the urine. So what we were able to do is to try to replicate what we did in humans also in an animal model with diabetic kidney disease. So here we used ZDF rats, and we were able to randomize them to gastric bypass or sham operated. And we could then harvest them at 20 weeks. But now, of course, we had the ability to actually look into the kidney. But first of all, just to reassure you that when we operate on a rat, when we do a gastric bypass, we get exactly the same effects than when we do a gastric bypass on a human. We get about 20%, 25% weight loss. You can see at the bottom left-hand side, a dramatic improvement in glycemia. And on the right-hand side in the panel, you can see exactly the same outcome that we saw in the humans. We saw a dramatic reduction in urine albumin creatinine ratios in the bypass rats in comparison to the sham-operated FAR rats, who in fact went on to develop significant albuminuria. But what happens at the level of histology? And we can see here looking at Desmond as an expression and looking at damage in the glomerulus. You can see the first panel on the left, those are our control rats that don't have diabetes and diabetic kidney disease. The middle panel are those rats that do have diabetic kidney disease and had a sham operation. And you can see the bypass on the right, where we can see that we have not completely reverted the damage, but certainly we have significantly attenuated the damage to the glomerulus. Let's do electromicroscopy, and you can see in the left-hand top-hand side, there you see the podocytes of those are the little finger processes that you can see on the electron microscope over there. In our control group that did not have diabetic kidney disease, on the right-hand top, you can see the podocytes being destroyed, as being disrupted like my hand, in those animals that had the sham operated. And the two panels on the bottom, you can see how the podocytes are not perfect, but they are certainly preserved in those rats that had a gastric bypass. So histological evidence of how these operations are protecting the glomerulus and the kidney. But now, with these improvements in treatments, what about us replicating the bypass in the so-called medical bypass? And what we are able to do here in the blue line is the gastric bypass, and in the green line is our medical bypass. So these are animals that have received GLP-1 analogs, that have received ACE inhibitors, statins, fibrates, and also some diet restriction to match them for the improvements. And you can see that on the top left-hand side, we've matched them for weight. In the bottom right-hand side is the consequence of that, where we also have therefore achieved very similar, if not identical, glycemic control in our animals. And when we now look at the improvements in urine albumin creatinine ratio, we can see that similar to the randomized control trial, the bypass is still very, very good. But now suddenly with our 15% weight loss and our medications, we can see that we can replicate what is happening in the bypass as far as the change in urine albumin creatinine ratio is concerned. And again, just to reassure you, when we look at the bypass on the bottom left-hand side and the medical bypass on the bottom right-hand side of those electron microscopes, you can see that the podocytes look very similar. So very reassuring that we are able to replicate some of these effects in animals. So of course, we are interested in the metabolic pathways, and we can see that most of these metabolic pathways, when we do metabolomics, proteomics, and lipidomics, point to inflammation. So very important point. But now I want to change tack and say, so what are our chances of replicating what we are seeing with the gastric bypass by using medicine, just when it comes to the weight loss and the glycemic improvement? And of course, you have already heard about the STEP studies with semaglutide, showing that in patients with diabetes, we can get substantial weight loss that can be maintained provided that we continue the medication. So really 10% weight loss on average. But I will remind you that 15% of patients achieved at least 20% weight loss. So yes, With surgery, we get 20-25% weight loss with people with type 2 diabetes. But here we can see that the proportion, a substantial proportion, 15%, can achieve 20% weight loss with the drugs that is available to you right now. And you've heard from the previous speakers that these drugs are also safe in patients, even when they have CKD stage 4 and 5. When we look at the glycemic improvements, we are seeing glycemic improvements with these medications that's very similar to the improvements that we saw with gastric bypass. So dropping people with hemoglobin A1Cs of over 8 down to hemoglobin A1Cs of 6.2, 6.3, below the threshold where we would normally diagnose people with type 2 diabetes. What is new, and I'm showing here you a new amylin analog that has just completed a phase 2 study that has just been published, showing that we are able to achieve, again, 10% weight loss, at least in 26 weeks. And you can see those curves, people are still continuing to lose weight. So these are not people with diabetes. Of course, people with diabetes always lose less weight than those that do not have diabetes. These are people without diabetes, but very substantial. And of course, now we are awaiting the studies to start a little bit later this year, when we're going to combine semaglutide with Cagri, so-called Cagri-Sema studies. And I'm showing you here the phase 1 study that was published in the Lancet, showing that 17% weight loss at 20 weeks. Now, the level of weight loss is very similar to what we see after a sleeve gastrectomy and even a gastric bypass at 20 weeks in patients that do not have type 2 diabetes. And you can see those curves, certainly there's nowhere near being plateaued. So the phase 3 studies are now going to test whether or not we can get people on average to 25% weight loss with these treatments. And of course, we already have now approval from the FDA with tirzepatide. And I'm showing you here the data comparing semaglutide in the gray line at the bottom and tirzepatide in the blue line, again dropping hemoglobin A1C from 8.5 down to 6, similar to what we see with surgery. And now also when it comes to weight loss, we can see 12% weight loss in patients with type 2 diabetes at 40 weeks. Very impressive results. And you may have seen the press release recently in people without type 2 diabetes losing 22% of their body weight on average. Again, not as good as surgery, but really that gap is narrowing. So let me start summarizing and suggest to you that if we are thinking about using surgical treatments, for people with chronic kidney disease. And I know Alon Friedman has also worked on something very similar, but here I'm just showing you with type 2 diabetes, but we can use the same concept. So even people with a BMI above 30, between 30 and 35, if they have poor control, and I would say if they have complications of diabetes that we are not able to adequately address with our medications, for example, patients with diabetes and chronic kidney disease, then metabolic surgery should be considered. It's not about the weight loss. It's about the health gain that these patients can have. And you saw that these surgeries can be performed safely, and we can see from the randomized controlled trials just how effective they are. But I also want to urge you that in those patients that may not want bariatric surgery, there's no point in forcing somebody to have a treatment that they don't want. But I think everybody should be offered surgery as an option. But certainly for those people that do not want surgery, now we also have other treatments that can be valuable when it comes to achieving at least 15% weight loss. So what are our next steps? If we just think about the American Diabetes Association, you will remember that at the top line, and I'm drawing your attention just to the first line under the heading there, it says first line therapy is metformin and comprehensive lifestyle, including weight management and physical activity. So it is already there. That is the first thing that you should do if you have a patient with diabetes or a patient with diabetes with chronic kidney disease. The first thing to consider is metformin and intensive lifestyle. But it's a little bit complex and nobody could really get this lifestyle thing right So what we are suggesting simply, because remember, these guidelines already establishes chronic kidney disease on the far left-hand side, as those patients should be considered for GLP-1s and SGLT2s or combinations of them. So we already have chronic kidney disease focus there. But what we would suggest is just let's simplify this diagram. And all I'm suggesting is by just changing the words. So the first line therapy is metformin and more than 15% weight loss. Now, it does not matter if the patient is newly diagnosed, or in fact, if the patient is late stage on insulin and chronic kidney disease. This should still be the first thing that we do. And, we as clinicians will find the best treatment that could achieve at least 15% weight loss, be that with nutritional therapies, be it with pharmacotherapy, or be it with surgical therapies. And it's not surgery against medicine or medicine against nutritional therapies. We use whatever we need to use to get people across the 15% line. And we know that then we're going to empower clinicians to really make a difference when it comes to treating our patients with diabetes and chronic kidney disease. So let me conclude and say 15% weight loss improves the metabolic micromilieu. 15% weight loss can address the complications of obesity and chronic kidney disease, and changes in the perspective needs to be away from weight loss towards health gain. The purpose of treating obesity is not weight loss. The purpose of treating obesity is health gain. And there's very few patients that would benefit more from this than our patients with chronic kidney disease. So please allow me to thank the team at home that's doing all the hard work, as well as our international collaborators. And I'm handing back to the chair. Thank you very much.
Well, Dr. LaRue, thank you for the tour de force presentation that I fully anticipated that you were going to give to all of us. We are up against our lunch break, and I know it's the end of the day for you, but I want to see if there's any questions here in our audience in person, and see if people want to put questions in the chat as well.
I had a quick question.
Actually, we have a question here in the room first. Let's start with that one. So, Dr. LaRue, the question is: do you have recommendations on the expected time frame or the anticipated time frame to achieve that 15% weight loss?
So whatever we do, if we have really effective treatments like surgery, for example, or the new drugs like tirzepatide or semaglutide, we will achieve the weight nadir at about 1 year. For surgery, it's typically between 12 months and 18 months. And I think we're going to see the same, with the new treatments. And I don't think there's a massive problem in taking at least 1 year to get to our weight nadir. The ultimate thing is, of course, to get as many patients to that as possible.
Would you, just to follow up with that, would you also then recommend that a patient demonstrate a period of time of weight stability, or do you think as soon as we get to around 15%, we're at that sweet spot?
I think that's a great question. I think we've learned from surgery, even when we look at gastric banding, which is not as effective as bypass or sleeve gastrectomy, we see that more is better. Yeah. So, I always thought at some point there must be sort of a threshold that if you get, 25% weight loss instead of 20% weight loss, there's not that much to gain. But actually it appears that, certainly 20% is better than 15%, 25% is better than 20%. And coming back to that point, that's really the opportunity. So we heard earlier about, operating on a patient with a BMI, of 70, for example. We know that even with our best operations, we probably are only going to reduce that patient's BMI from 70, maybe down to 50. So the idea now is, can we actually add tirzepatide, or can we add semaglutide and take them from a BMI of 50 down to a BMI, of 40, for example. So I think the future, and that's what we do in cancer all the time, right? We'll never say it's surgery, will I choose surgery or radiochemotherapy? You'll say, how can I combine radiochemotherapy with surgery to actually put my patient's disease into remission and keep them in remission in the long term? So I think we're going to need more surgery, but I certainly think our patients after surgery will need more medication to really achieve, optimal weight loss and health gain.
And I think we had another question from somebody who was chiming in remotely.
Hi, it's Nabil Tariq from Houston. Thank you for the great lecture. Actually, I had a two-part question, but you answered it already regarding boosting the BMI 70 patients. But I think as these therapies are coming along, and there can be somewhat equivalency compared to surgery, that we can embark on actual randomized trials now where patients can be convinced of this, as opposed to before where it was sort of like choose a 5% potential weight loss versus 30% potential weight loss. But if it's in that 20% range medically versus 25-30 surgically, I think it's going to be hopefully a lot more feasible. It was just a comment, wondering your thoughts on that aspect.
Yeah, no, I mean, a lot of people are correctly, calling for randomized controlled studies now, because we can genuinely have equipoise. We actually now have two treatments that will provide, similar types of weight loss. My concern with that, just ideologically, is one, that surgery will win hands down when it comes to cost, because surgery is incredibly cheap. Because even if you pay $15,000 or $20,000 up front, the cost long term is really good. There's very few treatments that is as cost effective as surgery. The downside, however, is surgery will lose, when it comes to complications, because we don't have a 5% morbidity rate, in the first 30 days or 90 days, etc. So we are really comparing apples against pears here. And the problem is that we are setting ourselves up, as we do in medicine, against A versus B. And, and I think what we really need to think about is, how do we use these things together? So because our problem has been that, when we may have these arguments, about drugs is better than diets, then, the payers just look at us and say, well, listen, once you guys have sorted this out, come and tell us what the answer is, and then we'll actually engage in obesity treatment, where what we want to do, and I think we're all in agreement with that. We want more nutritional treatments, we want more pharmacotherapy, we want more surgery, rather than less of it. So there's so few people, even with chronic kidney disease, with obesity, that's currently actively treated, that we just want to increase the number of people with treatment. But I agree, academically, those studies are really important and need to be done. I agree with that.
Well, Dr. Leroux, again, on behalf of the entire program committee, I want to thank you for joining us. Thank you for carving out a little bit into your family and Friday evening time to present with us. It's great to see you remotely. Hopefully I will see you in person sooner rather than later in the calendar year.
Thank you so much.
Great. Take care.
And congratulations.
Thank you so much, Dr. Sarwar, for moderating that session. We are into, again, our lunch. So we have about 25 minutes for lunch today. We're going to start again promptly at 2 with our patient panel. In the meantime, we have a little QR code. I'm going to put up a new screen for you. If you have any questions, and it sounds like we have a lot of really great questions that are brewing, some questions about topics that have not yet really been studied really intensively yet and need to be, please start putting them into our survey. So you can use the QR code to access the survey. The survey link is also on the website, but I'll make sure that the code is up here for you during the lunch break. And we'll see you back here at 2 p.m.
Click on the X
They'll tell us that they can't. If that's the case, then we'll just have to pass the mic. Where's the video?
Turn it on now. Green light. Test, test. Testing the mic.
All right, we're starting late yet again. My apologies. I think that may be the theme for today. It's my pleasure to introduce Marielle Van Thun from the National Kidney Foundation. She is going to be introducing and speaking with our patient partners who have agreed to come and share their experience with weight loss and kidney transplantation, both challenges and successes. So I will turn it over to you.
Thank you, Heather. Hi, everyone in the room. Hi, everyone online. My name is Marielle from the National Kidney Foundation. I'm in the Philadelphia office serving Eastern Pennsylvania and the state of New Jersey. Thrilled to be part of the planning committee and to be here with all of you today. So we do have our panel discussion. So I'd like to invite Matthew, Ingrid, and Susan. And we're going to have a conversation about sharing your stories and your experience with this. So you're welcome to come on up. Okay, you can do that too. Yeah, we'll just roll them over. All set? Perfect. Okay. Okay. Okay, so thank you to the three of you for being here today and for letting me ask you questions. Matthew, you have the microphone, so if you want to start, if you just want to summarize your health journey for us, talk into the mic because that is connected to the live stream, and then we can pass it down, down the row.
Okay. Hi, my name is Matt. I live in Cherry Hill. My problem started probably around 2016, somewhere in there. I guess my creatinine level was getting high. My family doctor really didn't stress the importance of that to me. So towards the end of 15, he suggested I go to a specialist and that I probably would need a transplant. I was like, geez, I didn't even get a chance to run to get over that first hurdle. I was running into a brick wall. So January of 16, I had an appointment set up for him. I never hit that appointment because in December of 15, I had a GI bleed and that just blew everything up. So I went to a nephrologist and he was monitoring me from that point forward. I was doing good as can be expected, but I had anemia. I wasn't getting around real well, still going to work, still doing what I could, but the anemia really hit me in the head. I couldn't walk from here to the door without looking for a chair to sit down. I was 385 pounds. So after doing research and so forth, I decided that bariatric surgery was what I needed to do. Yes, I could do it on my own now that I have a goal to do, but I wanted to get there as quickly as I could because transplant hopefully was coming. I wanted to get on the list. So in April of 2018, I got bariatric surgery. Prior to the surgery, you had your consultation meetings and so forth. I lost 47 pounds before I got there. So, I know eventually I could, but the early pounds were easy and then it just, tapered off. So I did the right thing with the surgery. I did that. I eventually got on the list on October 16th of 18, which was about 7.5 months later, somewhere in there. 6 weeks after that, I got a call. I was a perfect match. That actually saved both me and my daughter, who was in the final stages of giving me a living kidney. So I was very appreciative to her, and was sort of off guard that I got the call. Fortunately, I got the call. Went to bed that the night of the call, left my phone plugged in the kitchen. Went upstairs to go to bed and missed the call. They call on the landline about an hour and a half later, and we never answer the landline. That's there for 911. However, me and my wife looked at each other and said, I think this is an important call. So we picked it up, and they had a kidney in waiting, but 2 other people were ahead of me. They had multiple organs. So later Wednesday, the next night, they confirmed, get in the hospital. You're going to be operated on tomorrow morning, Thanksgiving morning.
Wow.
So I had kidney instead of turkey.
That's great.
Anyway, I ended up losing 170 pounds. I feel great. Everything went fabulous. I mean, I couldn't have scripted a better story than this, other than not being in this position in the first place. But, my kidney transplant, the bariatric surgery, all that, they gave me excellent roadmaps. And besides all that excellent care, the most important thing to me to make this work was me and my desire to get it done. Just because I wanted it done doesn't mean it was going to get done. I had to get it. I had to go through it. I had to want it, and then I had to do it. So the important thing is you can want all you want, but you have to do in order to get what you want.
Wow. Thank you, Matt. Great.
I think I'm going to beat you in my story. I know we all win. That's right. My name is Ingrid Cruz, and my story begins because I am a type 1 diabetic. So I've had childhood diabetes since I was 14. And really, when I first got diabetes, in that time, they had pig insulin, and the pig insulin was very well for my body, but then they took it off the market. So after 5 years of it being in the market, they took it off. Human insulin is not that great for mine. So my levels were always high. They always try to keep it down. We got the insulin pump, and that's what has been keeping it controlled. In 2011, by the way, I'm a preschool teacher. I still am, but I don't teach anymore. I'm retired. In 2011, I was in my classroom and I started seeing double. So I had 15 children, and I was like, where did these 30 kids come from? Wait a second, what's going on? I was like, wait, did I get more kids? So I was like, I'm seeing 30 kids, what's going on? So I went to the doctor's office, and then he gives me then he tells me that I am becoming blind, and then it's going to be a gradual thing. So by 2012, my doctor said I was legally blind. And by 2013, I retired from teaching. That year, even though I was still not on dialysis, I was in the transplant team in New York City in Mount Sinai Hospital, because that's where I'm from New York. And I went through a lot over there because we tried to do the gastric sleeve over there, and they said, no, you're a diabetic. That's never going to go away. There's no way that you can do it. So they really put me down Like I was like, well, forget it. I'm not gonna, then it's never gonna happen. But in 2013, what happened was I got my fistula done, but I still was on like a diet with the transplant team. And I didn't get on dialysis until May 9th of 2015. So I'm like now on dialysis, what, 6 years, 7 years? When I moved here to Philadelphia 3 years ago, I got on the transplant team. Well, I started doing all the stuff, and it was like 2019, and they said I needed to lose more weight. I was losing weight, but it was so slow because I have hyperthyroidism, I have the diabetes, I have all that. So it wasn't even that easy to lose the weight. So then they put me together with Dr. Soanes. They said, well, Ms. Cruz, if you want a kidney pancreas, then you're gonna have to get the gastric sleeve. I said, oh, well, okay, sure. I mean, they told me in New York, no, but once I met with Dr. Soanes, and he was like, no, you can do it. There's a possibility, like you need to get this done. You're young. How old do I look? Excuse me? I wish, for real? No, I'm 45. Yeah, I'm 45. So he's like, you're still young enough to like, you know, be okay and to get both your pancreas and kidney. So I was like, well, let's go ahead. But guess what? It was 2019 and then COVID hit 2020. So he was like, I can't, you know, we can't do it until it opens. Let me wait. And then when he finally said, okay, they're opening up, but let me just do a few, let me just make sure. Right. And so my surgery was August 25th of 2020. Before I went to the surgery, I lost like 25 pounds. He was like, oh, you can only lose 10. I said, I'll lose more than that, watch. That's what I told him, I'll lose more than that, you'll see. And he was like, Ms. Cruz, you lost like 25. I was like, great, yes. Which I know that I could, but it was just a slow process. So I have lost in total, how much have I lost? Wait, let me see. Like 67 pounds. I'm trying to lose more, but this Latino body is not that easy to like lose everything, all of this. So I'm still, you know, working at it. Still, it's a process, you know, and it's like Mr. Matt said, you have to want to do it. I was already ready. I mean, he said, yeah, he said, let's do it. I said, yes, whatever, now, let's go now. You know, because I really want my kidney and my pancreas. After that, I've gone through other things. It's been a hard journey because then they said that I had cancer in my right kidney. So in past October, I had to be off the list again and then get the kidney taken out. Then they took another 3 months to get me back on the list. So I was really upset. Then in February, they tell me I have breast cancer. And thank God it's not. And so that was another holdup. So I'm just here waiting, and I'm so happy to be here.
Well, thank you for sharing, Ingrid. And you can sit, you can stay sitting. Thank you for sharing, Ingrid, and especially with your continued journey. We keep wishing good things for you. So go ahead, Susan.
Okay, I'm a typical, my entire life I've been overweight. I come from a large family, and it was, if you wanted seconds or something, you better eat fast, and that was not a good thing. First diet at age 7. I was on diet pills at age 8. I graduated high school. I was already over 200 pounds in high school. I knew I was going to be heavy. My heaviest weight that I know of was 297. I could have went over 300, I don't know. But I stopped myself when I saw a scale at 297. I had high blood pressure because of this. I was going on and off to different weight loss programs. You know, LA weight loss and all those others that they give you diuretics, and it's just ridiculous. I find that Weight Watchers works for me. You're able to eat all kinds of food. I don't like a lot of vegetables. That is a big problem. But my high blood pressure caused my kidneys to shut down. And I didn't know that's what was happening. I thought I was going through menopause early. I was 44. I had gained 10 pounds even though I was dieting and I was watching. Then the following month, I gained another 10 pounds and then I gained more. It got to the point that I had an appointment to see my doctor. She saw me for 2 seconds, said, go back to the front, get your money back that you paid them, and go right to the emergency room. I'm calling them now and telling them you're on your way. This was in 2010. I had trouble. I couldn't walk 2 steps without stopping. To go up the stairs, it would take me 20 minutes because I would have to do 1 step, wait, 1 step, wait, 1 step, wait. When I was in the hospital, they didn't know what was going on with my heart because my heart, from so much fluid being on me, was enlarged. So they wanted to wait before they said I had a heart condition. Thank God, once they got the fluid off of me, my heart went back to normal size. I was in the hospital for 3 weeks. While there, they did a sleep apnea test on me, found out I had that. But the first week, fluid came off 50 pounds.
Wow.
The second week, 10 pounds. The third week, another 10. So now I'm down to what they call your dry weight in dialysis. They had put the fistula in me the second week I was there. They started me on the third week to find out how many minutes and where they would have to set the machine and find my dry weight. I started dialysis at a center the following day that I left the hospital. I was told about transplants and I went to a particular hospital, which is now closed. And the bariatric team there, the kidney team there, the doctor that I saw that day said to me, "You've always been overweight?" I said, "Yes." He goes, "Well, then you're not going to lose enough weight to get a kidney. So don't bother going through the process of being tested any further. Go ahead home." So of course I'm discouraged. About 5 years later, one of the nurses at my dialysis unit said that they're having some success over at Temple with the larger people in kidney transplants. And now I was watching my weight the entire time. So while I'm watching my weight, I'm losing. I go to the kidney people. They say, they look at me, they take my belly, we're pushing my belly from side to side. I've lost about 50 pounds on my own. He goes, "Well, maybe we can just send you to a plastic surgeon. He can remove this excess skin and then you can have a transplant." So I go to a plastic surgeon. Plastic surgeon says, "Well, your insurance will cover it if you lose about another 25 pounds. So he said, "Why don't you go see the bariatric people?" So now I'm working with the kidney people, the bariatric people, and a plastic surgeon on a regular basis. They're keeping track of how much I've lost, and I just made it because my BMI used to be 55, and you can only get it through your insurance if it's 40 or higher. But when I saw the bariatric people, my BMI was 40 point something. So I was just on the line. If I was 10 pounds lighter, I wouldn't have made it where the insurance would have covered it. I had the sleeve done actually a year after my sister did for her own reasons. Again, we're all big people. Within that year, I lost the weight I needed to lose to have the skin removed. So I actually, March the following year, it was January, I had the bariatric sleeve done. March the following year, I had my skin removed. They took above my belly. From my legs to my belly, I was cut from side to side. Now, I wanted to have that done before I got a kidney because once I got a kidney, I knew anti-rejection drugs would make it harder to heal. So the point was get it done first. They were able to take 17.5 pounds of skin. So just, with my arms, I don't worry about what they look like. If they flap, it's excess skin. It's one of my scars. I'm dealing with it. I'd rather have the flapping skin arm than have a health problem. So basically my job since 2010 has been my health. I keep a very good record of all my doctors, their phone numbers, their fax numbers, when I've seen them, what procedures I've had, what medications I'm on, what other illnesses I've had, because I've also had skin cancer where I did what they call phototherapy, where you get into a light booth and they shoot you. It's like getting in a suntanning booth, but it's standing straight up and down. I had that twice before the transplant and once after. One of the transplant anti-rejection meds is a catalyst for it. So I'm on the lowest dose I can get of that and still have it do its job.
When did you get your transplant?
My transplant was November 18th, 18. So
Right.
I'm over 3 years now. It's 3.5 years.
Wonderful.
I've had, right after my transplant, I had a bladder infection. But I said to myself, well, bladder wasn't used for 8 years. Of course there's bacteria in there. It's going to take its time to come out. I mean, let's be real. It wasn't used for over 8 years. I was on dialysis 3 times a week. It took me a while to learn how to drink, only 32 ounces. And now I'm having trouble drinking more. So you get it one way, you get it the other. First thing they tell you is stop the brown rice and the wheat pastas and go to white when you go on dialysis. Well, you get the new kidney, they're like, we want you, don't eat this, go back to eating that. First list they gave me had chocolate on it, Coke and Pepsi. Yeah, a lot of things that I was told I couldn't have, they're like, we want you to have them now. Yeah. So it was like, I was like, okay, but it's still, my stomach is still smaller and I can't drink soda because of that. Bubbles don't agree with that. My portions are still small. I can eat every 2 hours, but again, my portions are still small. If I eat too much, I will be sick. And that's something you have to be aware of. Thing is, I was put on one of my anti-rejection meds is a steroid. And when I was put on that, I gained weight back. Not all of my weight, thank God. I stopped myself. But it took a while to get it under control. And then COVID hit. Then because I was on dialysis for so long, I have 2 heart conditions now that I'm aware of and I take care of as much as I can.
So Susan, I'll start with you and then we can go back down the line. But I'm curious if there was somebody else in your position waiting to get a kidney transplant who was told they needed to lose weight, what advice might you share with them, or what might you share from your experience that would be helpful for others to hear?
You gotta have a doctor that's willing to work with you and talk to you as a human, not as just somebody walking in the door. And someone that's going to listen to you and have support at home that listens to you. Because one of the worst things, my mother would call me at dialysis and say, can you stop at McDonald's or Popeyes, which is right across the street? Or when I'd be at Weight Watchers, she'd call and say, stop at Dunkin' Donuts and get me a sandwich on your way home. So that kind of support is not support. You need to have support. They need to understand it's not helping you. So that is one of the main things. Have the support of your doctors. Do what they tell you to do. Here's the thing. I did what they told me to do. Once I got on a list, I had a kidney in less than a week.
Wow.
The time I put on dialysis was considered, my age was considered, and the fact that I listened to my doctors. All these things are important and they work together. And it's just one step at a time. That's one thing I've learned through Weight Watchers. Everything is one step at a time. You build on it.
Thank you. Thank you for sharing that. And Ingrid, do you want to could share any as you continue to wait, or
Yeah, I'm still waiting.
you have a different perspective, but just the encouragement. I mean, you sound so positive still. I mean, as you continue to wait.
Well, just do your research also. The good thing is that you have the good doctors, but don't always take their word for it. Nothing on you, Dr. Stones. I took your word for it. But do your own research. Know what they're telling you. If they explain something to you, find out what it is, on your own also. Because that's important. Use them all the time. See, I was calling I don't know, some people get the surgery and they forget about the doctors. Well, I was calling Tori, I was calling the dietitian, I was calling Dr. Stones, I was calling everybody. Oh my God, Dr. Stones, oh my God, it hurts. No, you're okay. I ate this and it hurts. No, you're okay. It's okay. You can do that. And then I had some other surgeries and I was like, well, can I eat this while I'm on this surgery? And it's just a whole big mess. But just talk to your doctors, talk to the dietitians, have a good support group. Like she said, like Miss Susan said, I have my caretaker, Maria here. Maria, párate. Párate. That's my caretaker. I have no family here. I say that's my angel. She's been taking care of me for 4 years, way before all of this stuff happened here in Philadelphia. My story is a sad one. I was married. My husband brought me here and then left me here abandoned. And guess what? I have my own apartment. I'm good. I'm doing great. Don't worry about it. I'm good. But just make sure you have a good support system. I have the church. I have Maria. She makes me exercise. She's telling me, you're not going to eat that. Come on, please. No, you're not going to eat that. That's not good for you. And she's on a diet with me, which is good. I agree with you when you say that you cannot have a person that's living with you and is not willing to do it with you. They might not eat everything you eat, but she anything that I say that I'm going to eat that is good for me, she goes ahead and she eats it along with me. So that's a good help.
That's great. Thank you for sharing.
Thank you for that. Very, very encouraging and an inspiration to me to keep going. I guess I elected the bariatric surgery to get there quicker. I knew I could do it on my own, but it could have been a year, could have been a year and a half. So depending on your situation, I chose the surgery and I got there, and I got there just in time because there was one waiting for me shortly thereafter. So just, use the advice that people give you, and just good luck. You have to stick with it. Things don't happen overnight. This is a slow process, but it gets faster the more you're involved, the more you investigate, and the more you want to put into it. It doesn't come to you unless you go out and get it. One thing that I did 2 weeks prior to the bariatric surgery, they put me on dialysis. I was floating along and they were trying to hold off, but they said 2 weeks before bariatric, you're on dialysis. So I did. I got the bariatric surgery, and a week after that at dialysis, they sent me to the emergency room because my blood pressure wasn't jumping back up. I was in the 110s normally, but it needs to go over 100 before they'll release you. Well, the one time it didn't come back, and I was like, okay, I have to find out more information. I have to get involved with it. So I talked to the dialysis people, and I said, I had the bariatric surgery. I'm on dialysis. How can we make both of these work? I still want to lose weight, and I have to be on dialysis. So we went back and forth after that, and I recorded my weight before dialysis, after dialysis, and talked with them before dialysis started, saying, okay, today we want to take 2 pounds off. Today we want to take 2.5. How did you feel last week? So I interacted with them, and I pushed the issue that I still should be losing 2 pounds a week, and I wanted to stay on track. So get involved. No, we'll provide all the information you can, but you have to want it. You have to look at it and do it to help yourself. So I did that. I went on the fast track. and things just happened. After the bariatric surgery, you're required to go on one support group meeting for insurance purposes. I went there, I learned a lot. I kept going back, I never stopped. I'm still 4 years out and I'm still going online. I participate. I think of myself as a group leader because I share a lot of my ideas. Couple quick ideas is you have control of your diet. Think of things that you can eat that have high protein, you like, and fit in with the calories. I brought some samples of my own creation, honey mustard and tuna. Get rid of the mayo, get rid of the fat, put a little sweetness in there to temper your sweet taste. Okay, I did tuna and cranberry sauce. Again, the sweet taste, something I like. I tailored it to my taste, but other people may enjoy it. One of my meals is ground turkey and green beans. I put a little syrup, about a ½ ounce of syrup in there. Sweetness, the whole meal is sweet, so my taste for sweetness goes away after that. So again, tailor the food that you have to adjust before bariatric and after bariatric are two different worlds. Okay. Get the food that you like, temper it to what helps you for the rest of the day, and that'll kill two temptations. Okay, it helped me. I lost 170 pounds. I feel great. Well, prior to the new year, I was doing 27,000 steps a day.
Wow.
Okay. Had a stent put in and that cut it back a little bit, but I feel great. Again, I want it. I'm going to get it. And I did it. Another suggestion is keep track of all your phone calls to the insurance companies. Okay. Who, what, when, where, and follow up. That's important. They don't follow up. You have to. I have a spreadsheet, keeps track of my weight, my sugars when I had to. I'm off of that now. Right after transplant, the sugars are real wacky, and you know, whatever you have to do to track it, put it on a sheet. It could be handwritten. Doesn't matter. Just keep track of it and know where you are. My calories, my diet, my sugars, all that, my fitness pal. Keep track of it. It could be on paper, but keep track of it. Know where you are at all times. Know how you can tweak things. All right. Just keep track of it so you know that you're going down the path that all the healthcare providers provided for you. They're excellent out there. Take their advice. And just one last quick thing for the bariatric support group, get involved. If that's the path that you're doing with the bariatric, get involved, even if you're there just to listen. You don't have to be a speaker. You could be a listener. That's every time I go to the support group, I learn something and I try to pass it along, but go there even to listen.
That's great. Thank you. Yeah, thank you. Is this 2:45 or 3? 2:45. Okay, so we have about 7 minutes left, I think, if I can see the clock correctly. So are there any questions in the room for our very brave speakers? We have one question. Yes, go ahead. So I'll just say the question again for anyone online. The question is your perspective as a patient. If you have any advice for the healthcare providers from your perspective, what you would want them to know as a patient.
Since I got the mic, I'll start.
You can start. Sure.
For me, my primary care was probably the weakest link. Okay, I didn't go to the doctors that often. I was never sick. I guess I went for my annuals and, you know, they could have said this level's high, that level's high. Well, it didn't mean anything to me. Hit me over the head, make me understand. Okay, creatinine, what's that? I don't know. it's a little high. Okay. We'll see what happens next test. No, tell me my kidney's failing. You know, just make sure you, well, hit us over the head, make sure we understand that that's, you know, we have to realize that it's important. I didn't know that until I was up against a brick wall.
I think for me is just to have a heart. In New York, when they told me, no, you can never do this, this will never work for you, you're diabetic. I mean, that really put me down. And when I met Dr. Soanes and he was like, no, we can do it. And I'm like, are you sure? He's like, yeah, we can do this. And so just have a heart, because I mean, you might not be in that position, but there might be a family member of yours in that position, and just put yourself in that, you know, category. Like, what would it feel like if my family member would be in this position, and how would I probably talk to them? So just, you know, and I'm sure that if you're in this profession is because you do have a heart. So just, you know, being yourselves, and like Mr. Matt said, just let us know what it is and tell us the truth. You know, this is serious. You know, this is going to happen if you don't take care of this now, and we're going to listen to you. You know, that's it.
Great, thank you. Yeah, I had the same problem. Someone told me no, and for 5 years I did nothing but, you know, try to lose weight, because I've always tried to lose weight. You need to be compassionate. You need to explain things and explain it in a way that we understand, and give us resources to go to. I do Weight Watchers. I do virtual, like he does the bariatric meetings. I do virtual meetings every single day for Weight Watchers. It keeps me under control, keeps me honest. And I need people around me, my support. So you need to be a support person if you're in the medical profession, not just someone who analyzes the data and that's it. You need to be supportive. That is one of the main things. The more supportive you are, the more your patients will react in the proper way and get done what they need to do. Because we have to be our own advocate, and you're part of our support.
Thank you. We have some really great feedback from online. I just want to read this to you from our participants who are watching, who said, you've been the best part so far today. Thank you for your honesty and caring. They love that you're sharing and for giving clinicians valuable perspective of the highs and lows that you face. So I wanted to share that positive feedback. And we also have a question from online. Did you feel you were prepared for the impact of prednisone post-transplant and the impact on weight gain, and how that after you had lost weight post-transplant, gaining weight again, how you felt about that, how you dealt with that? Susan, you have the mic if you want to start.
Yeah, I think I had the worst problem with it. Out of the three of us, I gained back out of the 140 pounds that I had lost. I gained back like 65 of it. I am now down 25 of the 65 I gained back. I'm doing it one day at a time. I'm doing it with support and with knowledge. And that's key. I talk to my doctors. I talk to my family members, because everybody in my family's got health issues. I think everybody's like that. You don't know what someone else is going through. You need to have the support. It is so important. I think if I hadn't had the support of my sister, who had the bariatric surgery the year before me, I might not have done so well. And let me tell you, when you're only allowed to drink 32 ounces and you got to choose which protein you're going to have that day and how much of it, because the first 6 weeks, all you do is drink. That's a hard choice to make and stick with, because other people who have the bariatric, they can have protein shake in between a protein chicken or a protein tuna, but we have to choose. And when I came to the prednisone afterwards, I knew I was going to gain weight, but it wasn't until I said, Susan, this is ridiculous, stop. And I started my process from the beginning again to lose. It's hard. And I'm older. I have other health issues. It is hard to stop and lose again, but I'm doing it one day at a time, one step at a time.
That's great. Thank you.
Well, I'm not there yet, but I have gained 7 pounds, and these 7 pounds are the hardest ever to lose. Right? Am I right? I'm not there with the prednisone, so I can't answer that.
As far as the prednisone goes, to me, it didn't affect me one bit. I track my weight every day. So if I see it go up 0.2 pounds, which is the increment on the scale, I'm saying, what can I do to take that off? So I've lost my weight and I've been steady for 3 years now. So,
That's wonderful.
you know, I may go overboard with tracking and everything, but it's working. So.
Great. And if I can just like in the last 1 minute that we have, the other question we have online, were there any additional support resources, anything specific that you wish you had while going from your transplant team specifically? So Matt, pre-transplant, or maybe Ingrid while still waiting, either perspective.
No, listen to your doctors. They give you a great roadmap and follow it. Again, I track it, I follow it, I take what they give me, and I adapt it to my needs. But they're there for consultation, support, and they'll answer your questions regardless of whether you have an appointment or you don't. Call the office. When in doubt, call. The worst they can say is, you know, you're not going to get any better than what you are now, but, you know, if you don't ask, you're not going to get further information.
For me, just know that they're people also, and that the transplant department is backed up. And so you have, for real. And so you have to be on top of them. You have to constantly keep calling them and say, hey, it's Ingrid. Am I still good? Are we good? Are we good? Thumbs up. Because they have a lot of other patients. And if you don't advocate for yourself, then no one's going to advocate for you.
All right, thank you. Closing thoughts, Susan?
Like they say, listen to what your support team, which includes all your doctors and nurses, dietitians, and even the social workers, they really do have ways of helping you, and that is important. You listen to them, you make notes, you take what they tell you, you find out information online. My sister says to me, why do I read as much medical information when every time someone tells me I have something? Well, because I'm going to deal with it in the right way. And, you know, there's one thing I have, there's no medicine for it. It just will happen if it happens. So I have to be aware of it. And my support team needs to be aware of it. So that is, you know, just do what you're told to do. And hopefully they'll be kind in the way they tell you.
Great. Well, let's give a big round of applause to our 3 participants. And I also want to echo thanks for sharing your stories, for being so honest and open and in front of a room of people, which is not always the easiest thing to do. So thank you. Thank you.
Thank you so much. So we actually are a little early because I clearly don't keep track of time well. So we do have a little bit of extra time if anybody has any last questions. And there is.
Oh, okay. I'm going to hand you back the microphone.
Primarily your primary care doctor was obesity. That's one issue, but I keep thinking of that as a healthcare practitioner, that time. You know, time can be really limited for us, you know, when we're caring for patients. So I'm just going to assume you guys encountered that along the way. What is something, if you know that you're meeting with somebody and they're kind of rushed, what would help from your perspective what do you want from that practitioner? If that practitioner has a very limited time with you, what would help you to not feel like they're not taking time with you, or they're not?
Well, I don't know about you, but I make sure that if there's a question I have in my head, I have it written down to ask the person I'm seeing. I think it's so important. Plus, I keep a very detailed, he does too, but I keep a very detailed thing that I update on a regular basis as to what's going on. So when one practitioner asks me, when's the last time you saw your heart doctor? I can say when I did. When's the last time you saw your pulmonary doctor? I can say when it was and what procedures they had me do. I have that information with me. I carry it in a folder whenever I see somebody, especially if it's a new doctor. So it's a matter of preparing myself before I go.
I think for me, wait, hold on. I have a senior moment right now. What was the question again? Oh, okay, I got it. I have all of my doctor's numbers, so I text them if I need to. Sometimes if I was in the emergency room, I'd sometimes text Dr. Zones or Dr. Amy Awame, like, I'm over here. What can I do? What's happening? Something, my stomach is not feeling well or whatever. But I have them, at least I'm able to get in contact with them quickly, and they will do anything in their power to. So I guess some doctors don't like that, but even if you have the My Chart, just try to email them through there, and they will get to you as quickly as they can. You know, that's the only thing that we can ask from you, you know.
My suggestion is get a hardbound book. Go in with questions. Don't leave until they're answered. I write the questions on one side, I leave the other side blank, and that needs to be filled in before I leave. It's hardbound because I can't say the dog ate my homework. It's together, and you can go back and refer to your answers if you forget something. Keep it all together. They're there for you. Okay, you're not there to give them a quick visit and leave. You're there. They're there to help you with your questions. Get them answered, keep them for reference, and don't leave until you have them answered.
Yeah, and again, not that everybody is limited for time, but I certainly know that primary care doctors have like maybe in most cases. So as a dietitian, we're lucky here at Temple. We're fortunate we have more time given to us. I don't really feel this rush. But again, I just wanted to see if there's something maybe we should be doing to encourage other patients, to be as exemplary as you guys are. You guys are phenomenal.
Oh, when I'm waiting for my doctor's appointment, if I'm 10 or 15 minutes sitting in the thing, I'm thinking, I'm not mad. I'm saying, this is good. The person in front of me is getting their answers questioned or their questions answered. Okay. I mean, I don't care if I'm a half hour or 45 minutes there. That's a half hour or 45 minutes that somebody else is getting attention to. So be patient in the room and be patient in the doctor's room. Right? Get your answers get your questions answered.
And be patient with the patients.
I'm a patient.
Yeah.
All right. Thank
Great.
you so
Yeah,
very much.
thank you.
So we have our last panel, and we have Dr. Serban Constantinescu, who is going to moderate. Thank you so much, Marielle.
Sure. Thank you for this.
And Sam is going to help us.
Is this still a hot mic?
I will see the chat. I will see the chat. You know, because I can put my own computer and I can see the chat. But or let me see. Or let me see. In such way, I can monitor the chat, but actually, no. Right. And let's see, I have everything here. Okay, I think that all is set. Let's see. Okay, I'll put this here. The PowerPoint or anything? No. I'm doing only the presentations. Yes.
Let me stop sharing the screen.
Let's see. I will do. Okay. So the camera is there, correct?
Yeah. So that's how you'll see it.
What do you say?
That's exactly how you'll do it.
Okay, good. Perfect. Let me see the. Do they share? And then I can get. Okay, perfect. Then. Okay, good. Fine. Oh, I'll do like this. I got it. I got it. Oh, the camera is there. Okay. Let me see. This is can be up. Let's see. Done. Can you put it up? Perfect. Exactly. I think you have to put it a little up. And then we have to move this in. Oh, perfect. Perfect. I think that we are fine. I think we are fine. Good. Hmm? 56, we still have time. We still have time. Good. So now, how can do they have access to how do they have access to the speaker?
So you are the speaker.
Yes. Okay. And then I will give them the share screen.
Yeah. So Rashawn will be giving people access to share their screen. So
I see. Good.
Yeah.
And will be does he have the schedule? So the first will be Dr. Kilaki. Yes. Yeah. We are in contact with her. Perfect. Oh, I should mute, correct? Otherwise. Good afternoon. We will start the new session. Yes, good. Can you change the screen or what should I do? We are good?
Share her screen.
Okay, perfect. What shall we do? Now I understand. Give me 1 second.
Do you want me to share my screen right now, or do you want me to wait?
No? Okay, perfect. Okay, perfect. So you'll keep it like this? Perfect.
yeah. So if you just go down that.
Okay, good.
On yourself, even.
Oh, perfect. Excellent. Hello, Dr. Kilaki. Good to meet you over Zoom. So we are starting the next session. My name is Șerban Constantinescu. I'm a nephrologist. I'm not a transplant surgeon. I'm a nephrologist. I'm professor of medicine in the section of nephrology here at the Temple University School of Medicine. And also I'm the Temple University Hospital Medical Director for Kidney and Pancreas Transplant Program. The topic of this section, of this session is transplant surgery for patients with moderate and severe obesity. So we invited a panel of transplant surgeons and nephrologists to discuss the outcomes of transplantation in recipients with obesity and the challenges of transplantations and surgical approaches in this group of patients. I will present, I'm very delighted and it's my great honor to introduce Dr. Kilaki, who is the chair, and she is professor of surgery and pediatrics at Tulane University School of Medicine in New Orleans. She has ties to Philadelphia. She moved to New Orleans in 2006 after working as a liver transplant attending at Albert Einstein Medical Center here in Philadelphia. Dr. Kilaki received her undergrad and medical degrees from Columbia University. Then she completed the general surgery residency at University of Rochester in New York. From there, she went on to complete the abdominal organ transplant fellowship at the Mount Sinai Hospital in New York City. During her fellowship and surgical career, she gained experience in liver, pancreas, intestinal, and kidney transplantation in both adult and pediatric patients. She has focused her research to clinical issues related to organ procurement, ischemia reperfusion injury, hepatitis C and kidney transplantation, as well as obesity and transplantation. So Dr. Kilaki presentation will discuss challenges of abdominal organ transplant in obesity, and this is obviously a surgical perspective. Dr. Kilaki, you have the room and microphone.
Thank you. Thank you so much for that. I appreciate the welcome, and hopefully, let me move this over. I appreciate so much being included in this symposium. I am a Philly girl, originally from there, and so I also appreciate that specific tie. So thank you for referencing that. Yeah, I think, it's interesting. I think with the three speakers that we have, I'm going to kind of touch on a few things fairly superficially and leave the details of some of them to our later speakers. But, this is something that is part of my daily life in Louisiana. Not that it isn't elsewhere, but certainly it was a big shock to me when I left the Northeast. Okay, so I have nothing traditional to disclose. My objectives today, really to reiterate that the debate still exists, of course, of who we should be transplanting, who shouldn't we, or how do we get people ready for transplant. From my point of view, of the surgical point of view, what are the practical concerns and considerations? Like, what are we actually dealing with in the moment? And then just a quick comment on living donation and obesity. So again, we recognize that there are limitations of using BMI as the metric, but whatever, however, that is the most accessible and certainly is used broadly across disciplines. And so it's what we have. Again, speaking my experience after training in the Northeast, when I moved to Louisiana, we've always been in the top 5 states for highest prevalence of obesity among adults, certainly. And you can see on the right, so 2/3 of our patients are non-Hispanic Black adults that we have in the transplant, and of course, in our general population, it's not quite 2/3, but in our patient population. And so this is something that we face every day. This is the most recent map, actually, which now is, they changed the legend a bit. So that is now including, 40 to 45 and 45 to 50 and above 50. And the prevalence of obesity in adults, in the non-Hispanic Black adults in Louisiana is 45.2. So I think, hopefully this isn't a controversial comment, but really transplanting BMI less than 35 is not something it's not something that we even think twice about anymore, right? It's just part of what we're doing. And I think that's the case in a lot of places. I think that the controversy, of course, is related to those 35 and above. And so when you look at this is the most recently available prevalence data of severe obesity, or class 2 and class 3 by WHO's definition, WHO. And you can see that total, it's a prevalence of 9.2, but that women are, overrepresented, as are non-Hispanic Blacks. This is an old graph, but it's still indicative of the trend of increasing numbers of those who are listed with a BMI greater than 35 and greater than 40. So here you can see that in 2005, 35 to 40 was about 7%. When you look at this, and I should say it's not exactly apples and oranges, because that was waitlist registrations. This is actually waitlist candidates. But if you look as of yesterday on UNOS, there are 97,000+ people waiting for a kidney alone, and you can see the distribution. And so, class 2 obesity makes up 15.3% of the UNOS waiting list. On our own list, it's about 21%. And I think, again, over 50% of our list has a BMI greater than 30. So it's something that we live with. So as we've discussed earlier today, and I don't want to be too duplicative of what has already been said, but again, just we must be stewards of our organs and consider these current understandings. I think that is a big part of what it means to be a part of the transplant, medical team, is really thinking about all sides. And it is a complex issue, no doubt. But there's the obesity paradox, which theoretically holds true, if you believe in it, of course, in the end-stage kidney disease population. Regardless of BMI, we know that patient outcomes are improved as compared to remaining on the wait list or on dialysis. But of course, we are selecting out those that are going to do better because we're denying transplant to others. And then we also know, though, that in the higher BMI, there's increased risk for wound infections, length of stay, other perioperative complications. But what's confusing is the long-term patient and graft survival. I think I've been doing transplant for quite some time now. In my training, I was finishing my training in 2002 when this publication came out in Transplantation by Dr. Meyer-Kreisch. And this is sort of where the 35 cutoff really and the 40 cutoff came, and what that showed was that with increasing BMI, there were increasing complications, and it was around 40 where it fell off. And so that's why I think a lot of programs, that's typical to have about a cutoff of about 35. Since that time, there've been multiple observational studies that support, sometimes the outcomes are better, sometimes they're worse, sometimes they're the same. In our own experience, we actually saw no difference in those elevated BMIs, but of course we didn't have that many that were included that were much above 42. And why is this? Of course, patient in observational studies, that patient populations are quite variable. The limitations of BMI as a solo metric we've talked about. And so really, is it more associated with the comorbidities along with those BMIs? That really needs to be the most important factor. Again, people greater with a BMI greater than 40 often are denied transplant. And then we've talked about the positive and negative impacts of weight loss. So our reality, I think I've nailed this into your guys' heads that, it's just not realistic to have a cutoff of 35 for us because of our patient population. And truly, if we didn't use expanded criteria, we'd be denying a large proportion of our patients who are predominantly non-Hispanic Black transplantation. That, of course, then exacerbates the systemic healthcare inequities that, we all live with, but we see crystal clear in Louisiana and other southeastern states. In 2006, when I joined the team, this was our protocol. So if you were a BMI of 45, you came back when you lost weight. We sort of nominally refer people to weight loss surgery, but the truth is that no one was doing it. They wouldn't do it. 42 to 45, we'd begin the workup, but they had to stay inactive, and we'd set their weight loss goals, and they'd be activated once they got below 42. But of course, that really never happened. Between 40 and 42, we would do that. We'd have a weight contract that would say, okay, well, if you were listed at this and you get the offer and your weight has gone up, then we're not going to give you the transplant. The truth is that was never enforced. And then other than that, 35 to 40, we would provide some dietary counseling, but again, that wasn't really successful either. And so we have just moved on. So things change over time, though, thankfully, right? So immunosuppression protocols have changed significantly. A vast majority of programs now use induction agents that can avoid using chronic steroids. And this doesn't happen for everyone, but for a lot of our patients. And this is a game changer, I know, for us and for others when it came to wound infections, development of hernia, which are associated oftentimes with surgical site infections, which can be really significant morbid events and issues for these patients. But there's been evolution of minimally invasive surgery, of course, and then the development of the robot and the rapid increase in complex procedures that are now done using the robot. So transplant in class 2 and class 3 obesity, the picture on the left there shows not a realistic picture. This is not our patient ever, really, but it does show that the kidney is placed deep in the pelvis. And so you can imagine if you have a patient who has a BMI of 42, and if it's mostly central obesity, then you literally may have 6 to 7 inches extra space having to get down to the blood vessels, right? And so that means the incisions are much bigger, et cetera. And so all the complications, they just sort of add up. I think beyond the medical complications that we've already talked about, and I won't go into those, it's just really hard to do. It's technically difficult. Someone mentioned earlier that getting exposure of the vessels can be difficult. If they've had long-standing comorbid diseases, they can have very diseased blood vessels. And so, I think when you're thinking about doing the transplant in these patients, you also have to really significantly think about, well, what kind of kidney are you actually putting in, or what kidney are you going to be putting in? So there can be some pre-transplant strategies. We've talked at length about bariatric surgery. Just a couple of comments to add to it. I think it wasn't until the transition from open to laparoscopic surgery that we really, this really became a feasible approach. Cincinnati was an early pioneer doing it open, but since then, and once bariatric, it's now mainstream to be done laparoscopically. Of course, it's the standard of care. It really, really changed it. But I guess what I really wanted to, the point I really want to make here is that it has to be a collaboration with the bariatric surgeon, has to be an intentional program development. And that's because there are higher complications and there's higher transfusion rates and all those things that no surgeon really wants to take on if they don't have to. And so it has to be a conversation with them, setting up referral protocols and making sure that the surgeons you send them to are actually going to do the surgery and not turn them away. And I think the other really important thing to think about, and this was something we struggled with for a long time, is do you have hospital buy-in? Our particular hospital loses surgery on every single bariatric patient that has Medicaid, and the vast majority of our patients have Medicaid. And so we had to work with the hospital in order for us to be able to proceed to grow that program. We're fortunate to have our hospital do that. We also have what we now call University Medical Center, which was traditionally known as charity, and they get Medicare reimbursement rates for their Medicaid patients. And so their program has just absolutely exploded, and we actually staff that program. So it's been a wonderful partnership. Up until that point, we had some private practice groups out there, but they, don't take Medicaid and certainly didn't want to take on the increased risk. So this has been a game changer for us. But then also you need to have conversations about, when are the best outcomes going to be? When do you activate that patient? When do you proceed with transplant? How much weight loss does there need to be? Can they tolerate the fluids that patient's going to have to take in? What about absorption of the medications? Do we need to be thinking about adjusting the way we are actually administering the immunosuppression to make sure they get the appropriate levels? I just want to share more of an inquiry that we've done in our experience with our pre-transplant weight loss surgery. So our program really has only been robustly open for the last 15 months, but we're prospectively looking at patients, and we have 91 enrolled to get bariatric surgery, all with a BMI of 35. They're all listed for kidney transplant. Thus far, we've done 18. And while you really can't say much, I do think what caught our attention was that half of them actually developed sustained hypotension. And one of the risk factors potentially could be normotension pre-transplant. And there's a lot of ways to manage that, but it can be a real issue because these patients post-bariatric surgery and post-weight loss might not be able to tolerate dialysis. And even in our own program, we've found that hypotension, usually systolic blood pressure greater than less than 90, that's not amenable or not responsive to medication treatment, has a very poor prognosis for long-term graft survival. And so this could potentially hurt the chances of them getting transplanted. Very briefly related to touching on robotic surgery, we're going to hear more about that. 2002 really was around the early reports in the urologic literature that came out. And it really, for the first 10 years, it was all really kind of proof of concept, anecdotal. But in the last 5 years, the publications have absolutely exploded. I chaired the session on surgical innovations for ATC, or American Transplant Congress, last year. And 90% of the submissions actually were about robotic surgery. So it's been pretty impressive. And thankfully, we've got lots of centers now that are doing this, and we're going to hear more about that. But there are huge learning curves. What are the benefits to robotic surgery? I mean, that's debated in general surgery as well. Donor considerations. So what is the donor likelihood of having DGF? We know that the delayed graft function is going to be higher in our patients with higher BMIs. And so, what's the cold ischemia time? What's the terminal creatinine? What's the cause of death? Is this a DCD? Lots of different things that come into play where we need to consider, are we going to exacerbate the delayed graft function in these patients and increase their morbidity? We have to think about complex vascular anatomy issues, and this is particularly relevant in living donation, where oftentimes a large proportion of those kidneys have multiple blood vessels, and we're having to reconstruct them or put them in different spots on the blood vessel, and just having the intra-abdominal pressure from the abdominal obesity can put pressure on the kidney, can kink it, et cetera. And so these are all things that really require nuanced approach to where you're going to put the kidney, how you're going to do the surgery. And certainly, having experience in this is essential. And then just a quick comment, this is not a big population of donors, but with pediatrics, there've really been few studies, but related in general just to size, we know that smaller kidneys can have hyperfiltration. We know hyperfiltration can be an issue in just higher BMI patients with higher BMIs. And so, is that going to be an issue for proteinuria and long-term graft survival? There was one paper that I thought was relatively well done back in 2012 that didn't really show any differences, but then again, their highest sort of category was just a BMI greater than 29. So we didn't really see what the effect was in these higher class 2 and class 3 patients. My last comment is just about obesity and living donation. We heard earlier from our colleagues at UAB, they really are the pioneers in this. Dr. Locke is, I know her, all of her R1, research, a lot of it is looking at this, about what is the effect of having a donor nephrectomy in a patient that's starting off with obesity. And so the data suggests, concerningly, that in patients with a BMI greater than 30, when it's adjusted for all these different factors, that obese live donor kidney donors have an 86 increased risk of end-stage renal disease as compared to the non-obese counterparts. That increases with increasing BMI, of course, and then 30% increased risk of long-term mortality. So this is serious. So I throw out the question, is there a role of weight loss surgery for these patients? And of course, that does affect transplant in general, because we're always looking at ways for increasing our donor pool. So I will leave it at that. I kind of touched on the several things. I have to, as others, thank my team. I'm mostly administrative now, honestly, these days, but these guys make it happen every day. So I'm very appreciative of that and happy to take any questions.
Dr. Kilaki, thank you very much for the excellent presentation. So let's see if we have any questions from the audience. If not, I will ask you a question. Actually, there is a comment. So yes, so I think that you discussed about the BMI and the fact that we had different groups of BMI, and you have for the audience, because many in the audience will have some ties with the dialysis units. If you go to American Transplant Congress and you look to the Scandinavian, they will tell you that they don't transplant people with the BMI above 30 because they don't have patients with BMI above 30. And the cutoff for transplantation is BMI 30. So we live in a completely different island. And I think that it's not only the BMI. I think that we at Temple, the nephrologists are doing the first evaluation, and we are looking to the age of the patient and the comorbidities. So I'm much more lenient, I'm much more, let's say, willing to send the patient to the transplant surgeon to see, can you transplant this patient even with their mind 40, 42, if he's young and vibrant and functional, as opposed to a 60 plus or 70 plus individual has same BMI, but much less functional capacity. Yeah. And keep in mind, there is also an allocation system. The young individual getting the first allocation in the first allocation sequence, so you don't have to keep them on dialysis too much time, because they will the KDPI will post-transplant survival estimate will go above 20, and they will lose the first allocation sequence. Yes.
Thank you for that quick comment. Just to say, I didn't update our current policy, and that absolutely is essential, because I remember learning the hard way when I saw a patient with a BMI of 43, and he just was, 6'7" muscular guy, and he was perfectly fine to be transplanted. So it does take a set of eyes and then a consideration of the comorbidities. So thank you.
Let me see if there is anybody in the chat. If not, we'll move to the next speaker, Dr. Kilaki. Thank you very much. We'll reconvene at the end. Yes, we'll have a next session. Good. Thank you. The next speaker is, sorry. Good. Can we get the screen share for Dr. Rita McGill? Perfect. Dr. Rita McGill.
Can you see me now?
We can see your screen perfectly. It's my distinct pleasure to introduce Dr. Rita McGill, who is Associate Professor of Medicine at the University of Chicago. And she's a clinical nephrologist, as I am, for over 30 years with experience in chronic kidney disease, hemodialysis, peritoneal dialysis, and kidney transplantation. Dr. McGill received her undergrad at Tufts University and then the medical degree from University of Massachusetts. She completed the internal medicine residency and nephrology fellowship at University of Pittsburgh. Shortly after, she came to Philadelphia. Again, we have ties with Philadelphia, being appointed assistant and then associate professor of medicine at Hahnemann Drexel, and also at Temple University School of Medicine. Her interest in integrated data analysis into her practice inspired her to earn a master's in clinical and translational science from Sackler School of Graduate Biomedical Sciences at Tufts University. According to Dr. McGill's own words, I will quote one now. I am a clinical nephrologist whose quality improvement initiative in hemodialysis care gradually led into clinical research activities. One of her latest research interests is recipient obesity and kidney transplant outcome, and this will be the topic of Dr. McGill's presentation. Dr. McGill.
Thank you very much. I'm so honored to be here. And my talk is going to be called The Long and Short of Transplant Outcomes, and I will try to keep it short since the day is long, and outcomes through thick and thin. Sure why there we go. Learning objectives for this lecture are to understand the impact of increasing body mass index upon both short and long-term kidney transplant outcomes, and also on a population level to understand the impact of the increasing body mass index of the population upon the long-term survival of patients with kidney failure. I have no traditional conflicts of interest to declare aside from being a donor to someone who had my kidney who weighs more than 100 pounds more than I do. Just like everybody else, dialysis patients are getting bigger. And this is an analysis that we brought to the ASN a few years ago, looking at the dialysis population divided into traditional BMI categories between 1996 and 2014, and it's a little bit easier than looking at the maps. I think what you can see is that the green line for both hemodialysis and peritoneal dialysis patients, which represents the patients with a BMI of less than 25, has fallen precipitously. And most of what is making up the rest of the population now is almost doubling of patients in the group of BMI 30 to 35 and also greater than 35. In our fully adjusted model, the BMI was rising by about 0.15 per year in hemodialysis patients and about 0.13 in peritoneal dialysis patients. Now we know that transplantation is advantageous, and this is data from John Gill looking at each type of donor, and on the y-axis you have the hazard ratio of death, and on the x-axis you have days after transplantation. And each of the separate curves is a BMI category. And you can basically see that once you get past the initial perioperative mortality, that the survival of transplanted patients is superior at every single level of BMI, every single type of donor, compared to patients on the wait list. So not, people who were approved for transplant who were then not transplanted. So we know that even for obese patients, transplantation is a great advantage. The obesity epidemic has inspired all sorts of judgmental thinking, and transplant programs are held to incredibly high standards in terms of their outcomes. And so some of the things that are in people's minds as an obese patient presents to a transplant program is, do we have a cutoff? Do we even transplant patients of this size? And in the last talk, we can see that that has been changing over time, the impact of laparoscopic and robotic techniques. There certainly seem to be different and more relaxed rules for multi-organ recipients. There's obese and then there's obese. There's fat and fit. There are people who are simply very, very tall. There's the impact of type 2 diabetes. And there's a whole question of cherry picking. Does a high BMI candidate have to have a better risk profile than a smaller one? Things that we don't know. Do you need a bigger kidney for a bigger recipient? Do you need a better kidney for a bigger recipient? Will the obese recipient and their allograft last long enough to benefit? Well, that one we've sort of addressed on the last slide. And the last one is, would the same kidney last longer if you had given it to a smaller recipient? And that's sort of a population medicine question that was very intriguing to me and to my colleague, Dr. Kalathil Suresh Kumar at Allegheny General Hospital, and led us to a novel design for an epidemiological study. So what we did was we queried the UNOS database for first-time kidney-only recipients who had a shared deceased donor. And we're able to find about 22,000 such pairs. And the advantage of using paired recipients is that as long as you can work the statistics for this, that the outcomes reflect recipient rather than donor characteristics. And so in the figure that we have here, the BMI of our recipient pairs shown as the black line rises over time. And that was also true of the entire recipient population. So our group was kind of representative. And I think this reflects two things: that recipients are getting larger and that our willingness to consider them as candidates has also improved as well. So again, we had 22,000 pairs, 44,500 people, of whom all but 6,400 were discordant for their BMI categorization. And you can see the group of greater than 35 BMI, there's about 5,000 individuals. And these individuals, compared to the other recipients, were more likely to be female, to be either white or African American, to have either diabetes or vascular disease, to have a pump perfusion kidney and lymphocyte depleting induction. They were less likely to be Hispanic or Asian, less likely to have a history of cancer, cytomegalovirus, hepatitis, receive left kidneys, or receive steroids. Many of these are intuitively logical. So going into the outcomes, the short-term outcome that we looked at was delayed graft function. And I think you can see very clearly that there is an advantage to being in any other group besides the greater than 35. And it's almost got a dose response relationship with an odds ratio falling to 0.73 when you get into 30, 0.54 as you get down to 25, and 0.41 for people with so-called normal body mass index. However, despite all of that, the length of stay on the transplant hospitalization differed minimally, a matter of hours, with a median hospitalization of about 5 days and a mean of about 7.5. Showing that there was some skewing and some outliers. Looking at the long-term outcomes of the allografts, when we considered people with BMI of less than 30, you could see that there were reductions in graft failure and somewhat more marked reductions in death-censored graft failure, and all of this was significant. However, what we completely could not show was any difference between our BMI greater than 35 and our 30 to 35 group, which was significant to us because the 30 to 35 group is generally transplantable at nearly all centers, and the other group not so much. The final thing that we looked at was patient survival, and really no difference across the board. And you can see all of these confidence intervals cross 1.00. So we're not killing our patients with BMI of greater than 35 by transplanting them. And based on the other data that I've shown, we're saving some lives. So in conclusion, certainly delayed graft function was more common with increasing body mass index, but this did not increase hospital length of stay. We didn't see any differences in graft or patient survival between BMI 30 to 35 and the heavier group of BMI greater than 35. We did see some advantages in graft survival and death-censored graft survival for patients with BMI of less than 30. And so we feel that these findings provide support for favorably considering obese patients seeking kidney transplants, as long as their medical diagnoses are diligently optimized prior to transplant. Thank you.
Good. Dr. McGill, thank you very much for your presentation. Let's see if we have any questions from the audience. While I'm waiting for questions from the chat, I will tell you that your study makes me very optimistic. Yes, there is no difference in patients and graft survival if you dare to transplant an obese patient. There is no difference in length of stay if the transplant program goes ahead and transplant to patients with the BMI above 35, which is an excellent argument for the administration. Yes, this is the huge headache. Yes, if you tell them, yes, we can transplant the patient, the patient will stay 2 weeks in the hospital and you lose all the money. Yes, at least we can demonstrate that it's possible. So yes, we can. So this is the message. The problem is, I will tell you, I would think it's that reading your study saying, this is the perspective of nephrologists, because if I'm talking to a surgeon, he will tell me, oh, what I'm doing with the wound, who is putting the VAC wound, who is taking care of, because the obese patient will have wound complication, no doubt. Yes, and we have surgeons here in the room, and they will agree with me. But overall, I think that we have to dare and transplant patients with higher and higher. Any comments or any questions, please? No, I'm not saying, but I think that one BMI. I think the BMI, we have to look at the BMI in a more, let's say, a more nuanced way. Yes, and the very hard cutoff of BMIs probably should the BMI alone will not tell you the story. So I think this is my feeling of this session, and whether the nephrologists, the surgeons have different perspective, and sometimes they have different perspective, but BMI itself will not give you the whole story. The age of the patient, the comorbidities, the sensitivity, whether the patient is sensitized or not, because if you have a highly sensitized patient, then you have to do serial biopsies. It's very difficult to do serial biopsy in the patient who is extremely obese, or it's much easier to follow a patient who is not sensitized, and you don't have to do serial biopsy. So there are all kinds of immunologic and anatomic, and I cannot speak about the anatomy, how deep is the vessels in the iliac, how narrow is the pelvis. So I, as a nephrologist, Dr. McGill probably will agree with me. As a nephrologist, you see the patient, we have a good understanding, but the final decision will be a surgical decision because they will have the headaches. Yes, no doubt. Yes, we put the ball in their field.
Yeah, well, I think, what we're seeing is that surgeons are getting out there and having the courage. Just, when you look at the way the size of the population in that study literally was growing, So I think people are out there doing it, and and I almost kind of feel it's very similar to decades ago, diabetes was considered a contraindication to transplant, but we know.
Diabetes was a contraindication for dialysis before 1972. Nobody was getting on dialysis if you're diabetic before 1972. So we evolved.
Mhm.
Yes. Yeah. Yes. So so let's go back to a table. So the table regarding outcomes, correct? So there is one table. Can we get one of the table? So one participant in the audience wants to understand better the outcome. Let's see if give me 1 second. Let's see. What's the question? You are talking about long-term outcomes?
Yeah, I can't hear the question, so you'll have to
The
coach me what slide you're on.
Yes, the third column regarding the outcome of patients with BMI between above 30, above 30, 35. Yes. Okay, this is the yes.
Is this the right slide?
Is it the right slide? Yes, the right slide. I understand. So the question, let me try. So the question is, from a statistical point of view, you were able to adjust for all kinds of covariates. I think how spread? Yes.
Loads of covariates.
Yes. How let's see. How normal the distribution of that patients were in terms of comorbidities?
I'm not sure how to answer that in that comorbidities are generally binary variables.
Yes, but I think that the analysis adjusted for age, for weight, for
yes.
for time of
analysis,
for time on the
Buku adjustment variables. We adjusted for everything that that we could find.
Oh, the question is, did you do a subgroup analysis regarding, so everybody was above 30, 35. So the group, I think, comprised in all patients above with a BMI above 30, 35, or did you separate in small groups?
You mean individual levels of BMI? I do have a we have a lot of that information. I do have an extra slide, which I think I will try to see if I can navigate to, which I think may be addressing this. Okay, getting past categorizations, and this is actually in the article, and you can kind of see what we did in this case was that we did an individual, given that we had 45,000 people in the database, we could certainly do individual hazard ratios for each body mass index, and in this case, the one that you don't see is 25 because that is our reference category. And so you can see basically there's a continuum there, especially when you're looking at death-censored graft failure. That there's a difference over time, but there really isn't a cut point. When we looked at death, actually, the table doesn't quite give you everything because really it looked more to us like a J-shaped relationship. Does that answer your question?
Yeah. Yes, yes. I think that these graphs will are very yes. The image that these images are telling the whole story. Yes. Mm-hmm. Any other questions? Let me see if anybody does. Okay. Dr. McGill, there are no other questions. We thank you very much, and we'll reconvene at the end of the session. Thank you. Good. Oh, Dr. Sharma. Dr. Sharma is the last speaker of this session. Dr. Amit Sharma is Associate Professor of Surgery and the Surgical Director of Hepatobiliary Services at Hume Lee Transplant Center at Virginia Commonwealth University. He graduated for Dayanad Medical College, Louisiana, India, and pursued a clinical research fellowship in transplant surgery at Karolinska University in Stockholm, Sweden. Afterwards, he did another fellowship in liver and kidney transplantation surgery at Virginia Commonwealth University in Richmond, Virginia. His clinical expertise in abdominal organ transplant includes several domains: for kidney transplantation, robotic donor nephrectomies, and robotic kidney transplants. For liver transplantation, live donor hepatectomy, robotic liver resection, and central hepatectomies. Dr. Sharma has several research interests, among them renal failure in liver transplantation, donor selection and safety in living organ donors, and experimental islet transplantation. So Dr. Sharma's presentation will focus on one of his clinical expertise, robotic surgery. And the title of her presentation is Robotic Assisted Kidney Transplantation in Obese Black Americans Recipients, Evidence of Healthcare Equity. Dr. Sharma, you have the floor. Thank you.
Thank you. Can you hear me?
Perfectly.
All right. All right. Can you guys see my screen?
Yes, we can see your screen.
Perfect. Thank you so much. All right. Thank you for this opportunity, first of all. I do sound a bit hoarse. I actually timed this very well. I have COVID right now. I got tested positive a few days ago. So I'm in the final run last few days. So the title of my topic of my talk today is Robotic Assisted Kidney Transplant in Obese Recipients. And I have no conflict of interest. And for our medical colleagues, these are the robotic arms as shown on the left side. This is how the robot looks like. And I thought I'll put it there so we know what we're talking about. And on the right side is the console with the VCU Health logo, where the surgeon sits and controls those robotic arms, which are where the patient lies on the operating table. These are my objectives. So as we've heard all day today, doing kidney transplantation in obese recipients is with some risk, especially patients with truncal obesity. It's harder to get to the iliac vessels. So they require larger incisions, which in turn exposes them to a high risk of wound infections, which in turn means, possibly decreased graft survival and other complications, including DVTs, PEs, and pneumonias. So for that reason, as we've heard many speakers say, many centers may not be very inclined to list these obese patients for kidney transplant. I'll get straight to the point. Robotic kidney transplant actually was done. First complete robotic kidney transplant was done by Giulianardi and colleagues at University of Illinois in Chicago in 2009. And since then, multiple centers have reported their outcomes. And the operative technique has been pretty much standardized. I will try to see how the audience feels like. I have a short video I can play at the end of the talk if we have time and if we have interest. But the operative steps are basically, you position the patient and put your ports in, and with your robotic instruments, you get to the iliac vessels and expose the iliac vessels. And then many centers will like to create an extraperitoneal pouch to make the kidney extraperitoneal at the end of the case. And then the graft is introduced through a gel port. And then you do your anastomosis like you would do in any open surgery, starting with the venous anastomosis, followed by arterial anastomosis. Once the graft is reperfused and hemostasis is achieved, then we proceed to perform the ureteric anastomosis to the bladder, most of the times using a double J ureteric stent. So these steps have been more or less standardized with minor variations from center to center. These are a couple of pictures from my patients who got a deceased donor kidney transplant this year. On the right side, on the left side of your screen is where I used a oblique incision to drop the kidney into the peritoneal cavity. And on the right side is a suprapubic incision or a phalansteal incision that we used to drop the kidney. We've also used a midline incision, in some of our patients to drop the kidney into the peritoneal cavity. The midline incision has slightly higher rate of incisional hernia formation. So we are trying different techniques and trying to, see which one is the best for our patients. Most centers will offer a robotic-assisted kidney transplantation when the BMI of the patients is more than 30. And other centers, especially in the East, India included, and in Europe, robotic-assisted kidney transplant has been offered to patients who have lower BMIs as well. But we like to offer it to patients who have BMI more than 30. Like any new procedure, you have to be very judicious about patient selection when you adopt a new procedure or new technique. And exclusion criteria can vary from center to center and also depend on the surgeon's experience. Some of the absolute contraindications currently include significant atherosclerotic plaques at the level of the external iliac vessels, or severe comorbidities which contradict robotic surgery. And also pediatric patients are generally not considered for robotic assisted kidney transplant. When this started, robotic assisted kidney transplant started, complex vascular anatomy, including multiple vessels, multiple previous surgeries in the abdomen or previous transplants, and simultaneous dual organ transplants were considered contraindications. But now some centers will take up these challenging patients as they've gained more experience. So the University of Illinois at Chicago have been the pioneers for robotic-assisted kidney transplant in the United States. Recently, they published their 10-year experience, and that included 239 patients. About 70% of these kidney transplants were from living donors. The median BMI of the recipients was about 41.4. 53% were African American, and interestingly, there were 19 cases that were that already had a kidney transplant previously. Most of the patients had a BMI in the range of 30 to 50, almost about 200 out of 239, and the remaining either had BMI less than 30 or more than 50. So how were their outcomes? After a median follow-up of about 25.9 months, wound complication rate was pretty low at about less than 4%. Delayed graft function was seen in 11% of the patients. The 30-day readmission was about 37%. And about 6% of the patients needed a repeat surgery within 30 days. 2.5% of the patients required a laparoscopic reimplantation of the ureter because of a urine leak. The arterial thrombosis rate was only 0.4%, and a graft had to be removed in 0.8% of the patients. And the most common reason for graft failure was rejection. Incisional hernia was seen in about 8% of the patients. The authors also compared their robotic-assisted kidney transplant outcomes to a cohort of patients that had been transplanted using the open standard technique, and they did not find any difference in patient or graft survival when they compared robotic-assisted kidney transplant from deceased donors or living donors, and the 1 year and 3 year survivals were comparable. Galileo and colleagues have recently published a review article where they assess the outcomes of robotic-assisted kidney transplant and compare them to open kidney transplant. Multiple authors have worked on robotic kidney transplants now, and basically what all these studies show is that there was practically no wound infections when performing robotic-assisted kidney transplant. Granted that most of these were from living donors, there was considerably less pain, and the creatinine or the renal function at the end of the follow-up period was comparable to open kidney transplant. And so all these studies show that robotic-assisted kidney transplant is at least not inferior to open kidney transplant and also has some definite advantages. How about VCU? So we started a robotic assisted kidney transplant program in summer of 2018. My partner, Dr. Chandra Badi, who's currently at Maryland as chief of the program there, he and myself had about 5 and 10 years of experience with open kidney transplant at that time. Both of us had been performing robotic assisted donor nephrectomies for about 3 years. We had previously trained a scrub team for both open and robotic procedures. For our RAKT, we used the transplant anesthesia team because they understood these patients well. Initially, during our learning curve, we were putting these patients electively in the intensive care unit and even leaving some of them ventilated overnight. We started off by doing 2 deceased donor robotic kidney transplants and then started doing living kidney transplants robotically. Currently, since Dr. Badi has moved on to Maryland, I have started focusing on doing RAKT mostly from deceased donor. And this year we've done 10 so far. So for this symposium, I'm presenting my data on 59 patients who've undergone robotic assisted kidney transplant. And I wanted to compare the outcomes in Black Americans to non-Black Americans who had undergone robotic kidney transplant at our center. So there were 42 patients who were Black Americans. Their BMIs were significantly higher at 34.69. Compared to non-Black recipients whose mean BMI was 30.79. Interestingly, most of the Black Americans, interestingly, majority of the non-Black Americans received kidney from living donors, whereas a higher percentage, about 40% of Black Americans received kidney from deceased donor. How were the perioperative variables? The rewarming time, this is a term that is very exclusive to robotic assisted kidney transplants. And what it means is this is the time from when you drop the kidney into the peritoneal cavity and put your clamps on the vein and the artery and start suturing the kidney. So it's a time from when you drop the kidney in until the time that the kidney gets reperfused. This is called the rewarming time. And it was not significantly different between the 2 groups. The anastomosis time, as the name suggests, is the time you take to suture your artery and the vein. So that is always shorter than the rewarming time, which is longer because you have to change instruments. Your assistant at the bedside has to pass you needles, has to take out those needles, and so on and so forth. So the rewarming time is always longer. The cold ischemia time in the Black American recipients was longer because they got more deceased donor kidney transplant. Conversion to open, our rates are slightly higher than other groups with more experience. And the most common reason for conversion to open was bleeding, which was seen in 7% of Black American and in about 18% of non-Black recipients. The serum creatinine levels were comparable in both the groups at 1 year. Only 2 patients had wound infections, and these were in the second group. And they subsequently developed incisional hernia that required surgical repair. Delayed graft function rate was higher in Black Americans, again, because they received more kidneys from deceased donors compared to non-Black recipients. So the mean follow-up in the first group is about 18 months, and in the second group is about 24 months. We have 100% patient and graft survival. The hospital stay was comparable between the 2 groups and was about a week. About 33% of Black Americans required intensive care unit admission. And like I said, some of these were elective admissions. And hypoxic respiratory failure was seen in 5% in the first group. So that was our experience. So there are challenges to doing robotic assisted kidney transplant, and they're very specific for living donor and deceased donors. Living donor robotic assisted kidney transplant is an elective procedure. You can plan it, you can arrange your team, and most of the challenges are related to either the donor anatomy, where you might have complex vascular graft, or you may have a right kidney where the renal vein is thin and short, and you want to use a donor vein to elongate it. And then other recipient-related issue that I mentioned in our exclusion criteria, where the recipient might have vascular calcification, previous transplant, or other medical comorbidities. For me, the interesting thing is what are the challenges to doing robotic-assisted kidney transplant from deceased donors? Because this is not a planned procedure. The kidney can come in any time, with variable cold ischemia time. So Campi and colleagues from Italy, they have looked at, they started a robotic-assisted kidney program from cadaveric donors. And what they found is that the most common reason for not doing a kidney transplant robotically was non-availability of the robotic team, which primarily was one chief surgeon who was doing most of their kidney transplants. And it all depended on when he was on call. They would do it, and if he was not on call, other surgeons were probably not as comfortable doing the procedure. So about 86% of the times, they didn't do it because the team wasn't there. Other reasons included, longer cold ischemia time, and their cutoff was about 20 hours. So if the cold ischemia time was more than 20 hours, they would not do it robotically. We don't have any such cutoff. I will put a kidney in even at about 30 hours of cold time. Then the other most common reason we've seen is non-availability of the robotic operating room. Actually, that's one thing we face more than anything else. Operating room space. And then there are other recipient and graft related issues, which might mean that somebody nicked the artery on the donor while they were procuring it, or the kidneys doesn't seem to be transplantable, and then you have to cancel the case. So to conclude, a robotic assisted kidney transplant provides an alternative to dialysis or obese Black recipients, and it may reduce the health disparities in this group. Cost has been discussed. The higher cost has been discussed in literature. However, the impact on wound complications, pain management, and overall outcomes must be included in any cost analysis. And last of all, robotic-assisted kidney transplant is one of the most complex procedures, and it should obviously be performed by trained, experienced transplant team to have acceptable outcomes. Some future directions, we need to train more surgeons so we can do more of these robotic procedures in obese recipients without having to depend on one surgeon. We definitely need more robots, so we have to convince our institutions to provide us more of these machines. We've discussed the collaboration with bariatric surgeons today. That's important. Operating room staff training and their compensation, especially if you want to do more deceased donor kidney transplant, these will be done in after hours, when elective procedures in the OR are done. So we definitely need to discuss how to compensate our staff. And then there is a need for a registry to follow these recipients and their complications. So we can, when we offer this technique to our recipients, we can be honest and fair to them. And I like to thank my ex-partner, Dr. Badi. We started this program together, and he's doing very well in Maryland now. And my operating room staff and my transplant surgery fellows who worked very hard over here. They're here with me in the OR, and they're always there to help me out. And I'd like to thank them as well. Thank you.
Dr. Sharma, thank you very much for your presentation. I know that it's 4 o'clock. We can stop here, or despite I have messages in the chat. Dr. Kilaki from New Orleans is saying, please play the video, and Lutina is telling the same, please the video. But meantime, I want to make a comment. So tell us about, so from outside, is that operating time is not longer if you do robotic as opposed to a classic open procedure? The worm ischemia time probably is longer. Probably the anastomotic time is longer.
It is, but when now, there are multiple publications out there that show us that the warm time up to 60 minutes, even if you do not cool the kidney, it's acceptable. And in my personal experience, I've stopped cooling the kidney. We started cooling the kidney, when we started doing this. But now I don't cool the kidney because it creates that condensation, and then you have to suck, and then you lose the pneumoperitoneum, and it kind of increases your operating time. The cold ischemia time, it should not be longer. If I have my own robot and I can take my patient, it should actually not be longer. The overall operative time is definitely long because there is a learning curve, not just for you, but your operating room team. And that's what I try to tell all the surgeons that I train. It does not just depend on you. It depends on your scrub. It depends on your circulator. It depends on the person who's standing at the patient's bedside. You may be a very good surgeon and you may be able to suture robotically, but if you have to work like a team, this is a true team procedure. I mean, one person cannot do it.
So I'm Avi. Questions from audience.
Surgery recently access to living donors because you are able to do living donor transplant.
Okay, so I will send I will translate the message. I will put the question on. Dr. Gillespie from Temple is asking you, well, is any chance that doing robotic kidney transplantation in obese African American will increase the access to transplantation on this particular ethnic or racial group?
Oh, definitely. I think 100%. And I can tell you, my nephrologists are after me now. They want me to have a bariatric a clinic with a bariatric surgeon, and we have actually started scheduling a clinic. Once a month clinic to look at all the patients, who were turned down because of high BMI. And our hope is, one, to see which one of these subset of these patients we can refer to our bariatric surgeons and maybe convince them to drop their BMIs, let's say from 46, 45 to, anywhere 35, 36, 37, and then do robotic surgery on them. Second, my hope is, the University of Illinois has recently published their outcomes with combined robotic kidney transplant and combined sleeve gastrectomy in this one sitting. So that's the other thing I want to discuss with my bariatric surgery group. The problem is, again, the timing of these things. Deceased donor kidney transplants are so unpredictable. No one wants to raise their hand up and say, okay, I'll be there.
I will make a comment. I'm glad that, I think that this is expected that you'll increase the access to transplantation for African American families with recipients on dialysis or approaching dialysis. The problem is now we are dealing with a donor. It's very difficult to find an African American donor coming from who is an excellent kidney donor candidate with a high BMI. And Dr. Kileki showed us that if the donor has a higher BMI, and the Norwegian data show this, if you have a higher BMI in the donor, then you'll have a higher risk of long-term kidney failure in that donor, because these recipients are coming from families which they share the same, let's say, same dietary habits. So you have a recipient, an obese recipient, and they come with a family of donors, many of them with high BMI. What do? I think the robotic, you can do it technically, but is it safe for the donor? So we are coming back now, the BMI, so my gut feeling is the following: with this procedure, you were able to reduce to overcome the huge abdominal panels of the recipient of the donor, but still you are dealing with the comorbidities of BMI for the recipient of the donor at the same time.
I'll try to play this video. Let's hope it works. Here we go. So
in the first part of presentation, I was trying to say the BMI is not everything, but BMI plays a role in comorbidities of both the recipient and the donor. And in ideal world, we all should have BMI below 30 like the Norwegians, but it's not the case here.
Okay, can we see the video?
We see the video perfectly.
All right, so this is how the port placement is. It's pretty self-explanatory, so I'll just stay quiet. My medical student did a good editing job on this. I'm speeding it up just for the sake of time.
Not everybody is a surgeon in the audience. Can you explain what do we see?
Oh, sure. Sorry. So after we've done our ports and placed everything, so this is what this is exposing the iliac fossa, the external iliac artery and the vein. So the blue one is the vein, and the one with this white loop around it is the artery. I'm sorry, I should have explained. I kind of, it's a surgical mindset. And now we are applying these bulldogs to the vessels to control the flow. So this is a bulldog that we place distally first on the vein. Just making sure that I have it all the way across, so we don't have an oops movement. We've had those, but we've cleaned it up. We edited this nicely. So we've dropped the kidney in after we placed the bulldogs. So the kidney went in through that port that I showed you earlier, the hand port. So now we are opening the vein up with the scissors. The issue with deceased donor kidneys is that the vein is so large, it takes a lot of time to suture them, compared to living donors where the vessels are short. So the warm times in these kidneys actually go up, but we've not seen any ill effect in terms of DGF or long-term graft function so far from these deceased kidneys actually. So this is the posterior wall of the vein is done, back wall is done, and now we are doing I'm suturing the anterior wall now. And the good thing about the robot is you can suture with your left hand, you can suture with your right hand, you can switch the needle depending on your comfort level.
I just have to say that the exposure here is incredible.
It's just adequate, and it's just enough to get the job done and walk away. So we've done the venous anastomosis. The renal vein this is the renal vein. We put it to the iliac vein. So we want to restore the flow and check this thing for bleeding. So I take the clamps off and I look for bleeding over here so I can control any bleeding. And then I use the same bulldogs and I control the arterial flow. And we always have one extra bulldog in there just in case. And this is, we are trying to create an opening in the artery now. So I use this suture to lift the wall up, and then it makes the cutting easier. And some surgeons will use a robotic a knife actually. I've not seen it, so we use this. And we use these threads which we put on the back table to make sure we don't grab the artery too much. Sometimes it works, sometimes you break these and then you still end up holding the artery, but
that hole is the hole in the artery, correct?
We try not to hold the vessels. We try minimizing handling. So see, I'm holding the side wall, one of the branches of the artery rather than the main wall.
Now you are doing the arterial anastomosis.
This is the arterial anastomosis. We've done the back wall, and I'm going to finish the anterior wall now. Okay. And the suture that we use is different from what we use for open kidney transplants. This is a white suture. It allows you to grab and does not break, when you hold it in a proper fashion. This is a more durable, slightly more durable than the Proline that we use normally in open kidney transplants, but you still have to be careful. And for Dr. Kilaki, I'm using a 5-0 Proline through a 5-0 suture throughout. Normally some surgeons use a 6-0. I just go with a 5-0 so I don't break it. So now we are flushing the artery with saline just to get all the air out and all the clots out. And then I keep accumulating these needles over here, and then I'll take them out once I'm done with this. So once I'm done, then I clear my field. This is where the rewarming time comes in. Your assistant had to go grab these quickly, pull them out, so you can take your clamps off and get ready for that movement. Actually, when the kidney starts to pink up, and you will see this kidney over here. We are reperfused now, and this is the kidney covered with this white gauze. So I confirm hemostasis first before I go look at the kidney. I make sure that there's no bleeding over there. Looks pretty good.
So the kidney is somewhere beneath the gauze. Okay.
Right there. Yeah. And the back table preparation is very important, which my fellows do. They're very good at doing it. So we don't have excessive bleeding from the kidney. And now we're doing the ureteric anastomosis. I open the bladder up over here. This is the bladder. So you're looking at the pelvis, and this is the bladder. So we open the bladder up. We had filled it with some betadine to help us opening it. And then this is the ureter of the kidney. So we use a PDS 5/0 suture, and basically we put this thing together to the bladder, just like open surgery. I try to copy all the steps of my open surgical procedure. Every step I've done, it's open surgery. And one of the urologists came in the room, and he was like, "Oh, you're doing it like a kidney open surgeon, And he was very surprised, because his surgeons do it like, robotically, and we try to copy the steps of open surgery. So this is a double J ureteric stent that we are putting in. Everyone knows that, so we place it across the anastomosis to decrease the leak rate.
Dr. Sharma, the audience, yes, the audience is full of surgeons, but so in general, for the audience, in general, the kidney has one vein and one artery, and the surgeon will anastomose first the vein, then the artery, and then the third step is to anastomose the ureter, the bladder. And in order to maintain the alignment between the ureter and the bladder, they put a plastic stent, which will stay there for a while, to 4 to 6 weeks.
About 4 weeks, yes.
Yes, the stent will be taken out, yes, 30 days after surgery.
So here we are retroperitonealizing the kidney, so the nephrologist can do a biopsy. So we raise the retroperitoneal flap, so it's easier for, we don't have to do a laparoscopic biopsy. So this is just trying to create some kind of a flap. Sometimes it's easy, sometimes it's difficult. And if it's difficult, then I let it go. But here it was possible, we use a clip, and then you can access this upper pole over here to do the biopsy. And then we place a drain, and then we walk away. And this is the final result. We used the port over here, and patient went home post of day 5, and there were no complications. Thank you.
Perfect. So thank you very much, Dr. Sharma. I will read only a message from Dr. Kilaki. Beautiful. Yes.
Thank you so much.
This is what she typed in the chat. If there are no other questions, I think that we end this session and we move to the next session. Yes. Thank you very much.
Thank you for the opportunity.
Speakers, Dr. Kalaki, beauty is in the eye of the beholder.
That is true.
But thank you so much. So the next session, we're a little bit behind again, not a big deal though. If you give us 5 minutes, we'll take a 5-minute break. We'll get everything ready for the workshop, and then we'll end at 5 as planned. So I will give you a little bit of time to take a bio break. I believe that there might be some snacks left out on the table, and we'll see you back in 5 minutes. I can put the code up. Yep. Okay, so we're a little bit after 20 after, so we're going to begin. So in this last part of our day, we're going to work collaboratively to develop some research questions. So we have, over the course of the day, we've been prompting folks to use the QR code to submit some already, and they've done so. So in a moment, I'll show you what we've come up with so far. But the idea here is that those who are with us virtually will be broken out into breakout rooms where we ask that somebody volunteer to serve as scribe and take note of all of the research questions that you come up with collaboratively in your breakouts, and then report back to us. Those that are here in person, we're going to just split into 2 groups on either side of the room, and we'll do the same thing. At the end, we'll come back and we'll share some of the questions that we've developed collaboratively, and then that will be the day. So just to give you some idea of like what we're talking about. Oops. So these are some questions that have already come in for keynote panel, the first keynote and panel 1. And the idea here is really to think very broadly and creatively. So I know that we are coming from a lot of different disciplines, and I think that's what makes this really interesting. It will provide an opportunity to come up with questions that maybe we wouldn't have thought of if we were just working with folks that are like us. So for instance, how can motivational interviewing techniques and nutritional counseling improve our patients' long-term success? I think that's a great question. I think one of the better ways to think about how to generate research questions, luckily we have the topic given to us, it's kidney transplantation and obesity. So kind of pick one of those. You think of some of the sessions in particular that were most maybe interesting to you, and think of what questions really came up during that session or that panel, what questions really are still remaining. And some of our panelists have been kind enough to provide some of that for us already. And we'll just start brainstorming. And there no question is a dumb question. We can just throw things against the wall and we will just take note and hopefully develop a really comprehensive multidisciplinary list of questions that we can put forth to everybody in this space, and hopefully really get some interdisciplinary research started from that. So without further ado, I believe that we have some breakout rooms that are opening right now. We're going to have 20 minutes or so to do that. So about 4:45, we'll come back together and we'll do about 15 minutes worth of working together, and then we will conclude. So please put yourself out into breakout rooms, and if you would please also, while you're in those rooms, choose somebody who again will take note of the questions and then report back to the larger group. And I'm going to mute us now here so you can do their work.
What are we supposed to do with this message?
I'm sorry, was there a question?
So there's this message about the breakup. How do you get yourself into a room? It just says the only things are broadcast message to all and close all rooms.
Yeah. So if you go to your name and then right next to the name is assigned to, and then you can choose which room you'd like to go into. Oh. Sorry, that's what I'm seeing because I'm leading.
They'll see breakout rooms at the bottom.
So if you go to, I see. So if you click on breakout rooms, you should be able, on your Zoom screen, then you should be able to make a choice as to which room you join. And then click join. I hope that was helpful.
There's just a list of like every participant, I think. Oh, wait a second. There we go. It has changed. Thank you.
You're welcome. Oh, yes, so sorry. Okay, so if you find on your Zoom screen at the bottom bar, there's a breakout room button. So if you click that button, you should be able to choose a breakout room to go into. So it's up to you which breakout room you decide upon.
Don't see it like that.
Okay, so you'll see the name of the room. So we have, for instance, a keynote speaker room, weight management pre-transplant room. We have weight management, a second one, bariatric surgery pre-transplant. You just click on the blue join button and you'll be taken into that room. You can also come back out into the main session afterward by coming out of the room. And you can go into different rooms while you're out there breaking out. Yes. Okay, it looks like everybody who is left on, oh no, we have more people joining. So sorry. Here we go. All right, I believe everybody's back. So for the last 13 minutes, we're just gonna ask that you represent your group and just share the questions that you've come up with. If you wouldn't mind too, those of you who are virtual, if you would submit the questions you came up with in the chat. We are recording still and we will have a transcript of the chat. I believe we're recording. Are we still recording? Yeah. Okay. Yes, we're still recording. So if you could put the questions in the chat, that would be helpful. Would someone like to go first? Can I invite somebody from our virtual space to go first?
I'm willing to.
Wonderful. Thank you so much.
Okay, so we had a virtual room, looking at surgery in obese patients, and things that we were thinking of is that we look at patient survival, graft survival, death-censored graft survival, and there's a lot of other things that as we begin to transplant more obese patients, we need to be thinking about new onset diabetes after transplant. We need to be thinking about secondary FSGS due to hyperfiltration. So we started to think about the variety of unintended consequences that might come up as the result of our liberalizing transplantation. How to anticipate those. We certainly all thought that there has to be something better than body mass index. And so there was a lot of talk about that. Could we come up with either a prediction model or a risk score that would help us stratify the people in the new BMI group in terms of who might benefit versus who might not, and things that we were talking about were frailty scores, the vascular access history of people, the need or lack of need for paniculectomy. And that's about as far as we got when all of a sudden we kind of got yanked out of hyperspace.
So sorry, that was rather abrupt. I know that. But thank you. These are great. These are great examples and a wonderful start. Please, if somebody from your group could share them in the chat, that would be really wonderful. And we will compile at the end and make sure that this is shared with all of the attendees. So thank you so much. Would somebody else like to go, either who is in person or virtual, either way? Karen, do you want to come up?
Not sure whether I worded this well enough, but what non-surgical weight loss techniques are most effective in achieving healthy weight for transplant? A lot of us were dietitians in our group, and we were looking at, there's not a lot of research of traditional things of what works, what doesn't. It's easy to jump into like bariatric, which has a place, but what are some other long-term effects? And looking at combining some of the weight loss drugs with the lifestyle changes can be really helpful, but what can we do to facilitate more research that's trackable and reproducible?
Thank you. And we have somebody else here who's live to come up. Thank you very much.
So we're a group of dietitians, I think. So one of the questions was, what type of nutritional supplementation is helpful or necessary pre and post bariatric surgery? So looking more at some studies on that, or maybe like what labs should be monitored, looking at deficiencies of nutrients after bariatric surgery. And then how often, prevention things, how often are patients being referred to RDs based on their renal function tests to prevent their progression to kidney failure, and maybe a study on what is the rate of progression to kidney failure for patients who are referred to dietitians compared to those who are not.
Those are really great questions as well. Thank you so much. Anyone else who is in our virtual space willing to share? Oh, it's been a long day. All right, I won't pick on anybody. We're almost at time anyway. I would like to say thank you so very much to all of our speakers and panelists, including our patients, all the panelists who made it in today in person, and especially those who are virtual and have stuck with us throughout the entire day. So thank you so much. We really appreciate all of your time and effort. If you do think of other research questions, please feel free to add them. The link and the QR code will be on the website in perpetuity, well, at least until the end of the year. So you're welcome to think about this, chew on it over the weekend or the next coming weeks, and continue to add research questions. One final note for those folks who are here in person, well, actually 2 final notes. We have an evaluation that we are interested in collecting information about in your binder. So if you wouldn't mind taking just a minute to fill that out and leave it with one of us, that would be really appreciated. All the rest of you who are virtual will be getting an online form to evaluate the symposium. We do hope that you found all of the content valuable. Our goal was really to provide a very meaningful forum for discussion about these topics. And from the feedback we've received so far, I think we've been successful. So I hope that is the case. For those of you who are with us, we have some drinks out in the lobby, so please feel free to imbibe. Maybe we'll find some music. And for those of you who are virtual, I wish you a very lovely weekend. Hopefully you do not have the hot weather that we are having here in Philadelphia and can enjoy it. So with that, we ended it a little bit early, even though we were late a lot. So have a lovely evening. Happy Friday, everyone, and have a nice weekend.